ಅದಕ್ಕಾಗಿ ಸದೃಢವಾದ ಮಾಹಿತಿ ಪರಿಸರ ವ್ಯವಸ್ಥೆಯನ್ನು ನಿರ್ಮಿಸುವುದು.
এখন স্বাস্থ্যকৰ ভাৰতৰ বাবে এক শক্তিশালী তথ্য পৰিৱেশ গঢ়ি তোলা.
मजबूत मालूमाती और माहौलियाती निज़ाम के साथ एक सेहतमंद हिंदुस्तान की तामीर.
Join us for this world-class event in Delhi on November 12.
Good morning, everyone. Good morning, everyone. I request all the audience delegates outside to please settle in. The onset of the COVID-19 pandemic has made the visibility of false information more prominent than it was ever before. Health misinformation can often lead to uncertainty, so mistrust lead people to reject public health measures, undermine public health efforts, and harm people's health. The Health of India Summit 2022 is aimed to address many such concerns about reshaping and rebuilding the Indian healthcare ecosystem and address the growing problem of health misinformation, thus fostering a critical change in how we envision the future of the Indian healthcare ecosystem. It is in this spirit that we are hosting you today to discuss ways to promote and access authoritative information to strengthen the dialogue on health in India. I am Shruti Manjula Mohan, Deputy Program Manager at Data Leads, and on the behalf of YouTube Health and Data Leads, I extend a very warm welcome to each of you here. Before we begin, a couple of quick ground rules. We have N95 masks at the reception, and we request you to wear these masks at all points of the day. The fire exits are onto your right. We also have an in-house doctor in case of an emergency. With this, I now invite Surabhi Pandit Nangia, Vice President Data Leads, to address the gathering.
Thank you so much, Shruti, and the hall looks beautiful and all nice. I'm so glad. Good morning, everyone. My name is Surabhi Pandit Nangia, and I work with Data Leads from Delhi. And it's such a pleasure to see everyone in here in person, greeting each other and being able to see some faces. This is not the first time that we're doing the Health of India Summit, but this is the first time that we're all getting a chance to see you all in person. So thank you so much. On behalf of our partners, YouTube Health, Team Data Leads, and Team Health Leads, I extend a really warm welcome to all our participants, all our esteemed speakers being present here today. It really means a lot to have you all here with us because I know it's a Saturday and I know that it's really, really early morning. I'm sure you guys are struggling from the traffic and there are people who are flying down from different cities. But thank you so much once again for taking out time for this very, very important discussion that we will have throughout the day. What brings us here and why Health of India Summit? We have done this in the past. There are quite a few initiatives that we've done, but why Health of India Summit? Why is it important to deliberate on the topic of a robust information ecosystem for a healthier tomorrow, for a healthier India? We've seen a lot of struggle in the past. We've seen a lot of trouble escalating during the COVID-19 time, and it's just not the COVID-19 time. We've seen that there has been information gaps, there has been problems in the information ecosystem, especially in the field of health in the past. It is just that it has come straight head-on to us and escalated way more during the COVID-19. So why? Coming back to why we are here, we live in an information era. So right now, just to give you numbers, and I'm sure the numbers have grown in the past, that we have approximately 700 million internet users in India, and this numbers goes up every day. And out of these 700 million internet users, we have around 450 million people on social media, which means that these people have more access to an internet service and to a social media platform than they have to any public health facilities, which means we are clearly lacking behind, which also means that people are essentially searching for any kind of health information on the internet. We've seen it, we've encountered it in the past, that we've seen people searching from cures on cancer on internet. We've seen people searching for fat diets and how to lose weight on internet. We've seen people searching for diabetes cures, and also on vaccinations. Vaccination, in fact, we were studying as to what people were searching on internet. Vaccination, immunization was something that people were really, really searching on. So people are actually relying on internet, on social media platforms to go and get some information on diseases. But is this information correct? Is the source correct? Is the person who's posting this information, is he a reliable source? So this is what it is I think we need to address right now. We've seen during COVID, people were actually forwarding. I mean, I say people, it's I think all of us in here also, that somewhere down the line, during the COVID-19 or even before that, we've been gullible ourselves. We've been privy to a lot of misinformation, a lot of fake news, a lot of malintended information related to health. And we've succumbed to it. I mean, I'm sure some of us have done that, and we've also forwarded such information. So I think it's right now very, very important that we address this information gap and we ensure that we provide a robust and a reliable information system for health. How are we handling it at Data Leads? So at Data Leads, we've been trying our best for so many years to have a very healthy information ecosystem. Just to give you, I mean, we have a lot of initiatives that we've been running for so many years. Just to give you an idea about two of our most important initiatives. One is called the Google News Initiative, India Training Network. So when we started this program in 2018, we knew that this was something new that was happening. We were talking about misinformation, we were talking about disinformation, we were talking about fake news, but we did not imagine the impact that this program would create across India. We started with 250 truth warriors, as we called them at that time, and these truth warriors were journalists, these truth warriors were media educators, media professionals, and they were trained over a 5-day TOT across India at the Google offices, and they learned the tools and techniques that are required to debunk any kind of information, any kind of news, any kind of photo, any kind of video on any of the social media platforms. And ever since this 250 truth warriors of ours have been on ground. They've been training people. Just to quickly give you that, and it's not only in English or Hindi that we've been reaching out to people. We've been reaching out to people in different languages, over 11 languages, because we realize that it's important that we reach out to people in different languages and also the dialects. So ever since this program started, we've done over 800 trainings. We've reached out to over 42,000 people across India. And this is how we covered the people who publish news, the people who broadcast news. So we thought it's important for them first, because they also sometimes are gullible and they can also fall, and we've seen it. They can also fall from some kind of a misinformation, fake news, disinformation, and they might just publish it, which goes to people who really rely on them and they believe in the news being published. So we covered this side of people who publish and broadcast news. But then we realized that there is us, there is people, there are people in the villages, there are community people, there are NGO workers, there are women groups, there are senior citizens who are so gullible, who actually receive all this information, and with the internet penetration that we have in the urban and especially the rural India, all of us have a phone in hand. All of us have the easy and a very cheap internet connection, which means that all of us are forwarding messages, all of us are receiving messages. I don't know how many, of course, but I'm sure most of us, our family groups in the morning, after a good morning message and before a good night message, is flooded with so many cures. I mean, basic cures for maybe somebody sneezes, maybe somebody has a cold, a cough, and to the most difficult diseases like cancer, people are forwarding, people are receiving messages. We have seen people, there have been videos that cancer could be cured if people can drink cow urine, unscientific claims and the most absurd claims. So, Fact Shala was another program and Fact Shala means a school. So a Fact Shala was another program that we launched to actually sensitize and educate these masses on how to consume and how to disseminate information, how to critically analyze any kind of information or news that you receive on your phone, on any of the social media platforms. And this program, believe me, was so successful. In fact, it is still running. And where, we were doing these, again, we had 250 warriors who were on ground. We had NGO workers participating in this. We had LGBTQ community. We have sex workers. We had army veterans. We had housewives. We have resident welfare associations. We have watchmen of that resident welfare associations. And I can go on and on and on to the cohort that we reached via this Fact Shala program. And we've reached over 50,000 people. And 2 million people is what we know that we have reached out via the Fact Shala program. And something very beautiful in the Fact Shala program was, how do we reach out to these small panchayats? How do we reach out to these small villages across India, who are actually, we cannot reach out to via the mainstream media. So we did a community radio program. We had 60 community radio stations being a part of Fact Shala, wherein they created their own jingles, where they created their own ways of reaching out to these people so beautifully. And this is what was actually our best with the Fact Shala. We reached to so many people, and we wanted to understand, are they really, really understanding what we are trying to say? It was not a very tools-heavy training session. The sessions were just aimed to actually equip these people how to critically analyze information, how to question the information or the news or any forward that you're receiving. Is it correct or not? Is there a reason behind that these people are receiving a message? Is there a bias behind it? So both these programs, of course, we've done in between a lot of programs. We did a program which is called Vax Check. We did a program called Poll Check. Vax Check was specifically designed around the COVID time, where we realized that there was so much misinformation on vaccination. So these are few of our initiatives that we've been running in the past to have a very, very robust information ecosystem, especially around health. And that's why we are all in here today. All of us present here today, all our esteemed speakers and all our participants are actually are the ones who want to impact the entire health ecosystem. So thank you so much once again joining us today, and I'm sure and I hope that you find the entire day very, very useful. Thank you again.
Thank you, Surabhi. Improving access to authoritative health information online is not only a crucial topic of discussion for today, but it remains a crucial topic of discussion for tomorrow as well. To highlight this, we are joined by Dr. Garth Graham, Director and Global Head of Healthcare and Public Health Partnerships at YouTube. A cardiologist, researcher, and public health expert, Dr. Graham has previously served in 2 US government administrations as the Deputy Assistant Secretary for Health.
Hello everyone, I'm Garth Graham, and I'm so pleased to be here with you at the Health of India Summit today in Delhi. Quick introduction about myself. I've spent the majority of my career focused on issues related to social determinants of health across many different parts of the healthcare industry. Now, a lot of folks have asked, what does YouTube have to do with health? How does a video site supposed to deliver better care to patients? And it really connects back to the determinants of health and the things that really drive health outcomes. There's a lot of literature looking at the impacts of things like housing, food insecurity, and other issues on health outcomes. But there's one important area that we need to start focusing on, and that is how information drives health outcomes and information as a determinant of health. So let me spend some more time on this last point because this is where the work of my team really comes in. So today across YouTube, it has really become a place where the world comes to for video. 2 billion people logged in to visit YouTube every month. Localized versions of YouTube are in about 300 countries and over 80 languages, and 500 hours of content get uploaded every minute. So really, even if you look, there's about 1 billion hours of YouTube content watched every single day. As health professionals, we want to empower communities with access to education and reliable information they need to lead a healthier lifestyle. So the reality of all of this is just that the majority of healthcare decisions are made outside of the doctor's office, in the everyday lives of our patients and our community. As clinicians, we only have a limited opportunity to connect with people outside of the exam room. And online sources have become a really important resource for questions about individual health. And therefore, we have to make sure that online sources are accessible, meaning they're free and easily discoverable, credible, meaning the sources who use the best scientific evidence that are delivering this information, and really easy to understand, so it's clear and helpful answers to questions. The questions we need to ask is really, how can we better show up at many more points within a patient's day, bring health information into their lives through the spaces that they're ready to visit, where they are already are, particularly online. And quite frankly, YouTube is already a part of the patient's journey. They turn to us for answers to their health questions. They look for a community who understands what they're experiencing, or really even sometimes just to find helpful videos that explain complicated medical information more easily. And this access information is breaking all sorts of barriers, from cost to geography to language. So as you would all agree, health education can come in so many different forms. And we've seen firsthand just how powerful video can be as a medium to reach people with health messages. That's why our mission for what we're doing with YouTube Health is really to empower people to live their healthiest lives, helping them make informed decisions through knowledge, belonging, and inspiration. And our real vision is just to transform how healthcare providers and public health organizations educate and motivate people to live their healthier lives and to empower them using video at scale. So next, I'm going to talk about our 4 R's and our responsibility framework. Our approach to health is really part of an overarching 4 R's responsibility framework, which helps us build a stronger foundation for connecting viewers to quality health information. So firstly, YouTube aims to protect viewers, creators from content that poses a very serious risk of egregious harm by removing that content that violates our community guidelines. And this really defines the rules of the road on YouTube. Secondly, there's a striking shift in our industry and an acknowledgement that it'll never be enough to just remove misinformation. So we need to remove and we need to fill that space with accurate, credible, understandable content for the public to access. In addition to increasing the volume of highly authoritative content on YouTube, we're working to increase the way people find it and to raise up its ability to be discovered easily when people are searching and asking questions, to ensure people can find these sources more easily when they come to our platform. Thirdly, we aim to reduce the spread of borderline content that we deem bad quality. And lastly, we reward trusted, eligible content with a wide range of monetization options, really in this idea of how we reward overall. Let me switch a little bit to our more recent focus and where we've been kind of channeling a lot of energy on YouTube Health. So over the last 2 or so years, we've been working on establishing an evidence-based foundation for health on YouTube and open up access to engaging, credible health information really at a global scale. Our foundational years have brought many key insights and learnings. Perhaps most notable in the public health community is just that willingness of the community to engage and work with us overall. We've spoken to and are working with hundreds of health authorities in numerous countries across the world to increase the volume of high quality, engaging health information on YouTube. Nearly every organization with whom we've kind of approached and worked with and who we've spoken to have leaned in and expressed this desire to join our mission in opening up access to quality information from some of the best and top minds in health and medicine across the world. And really, even for me on a personal level, just seeing this level of engagement and interest to join our mission has really been heartening and kind of validated a lot of the principles in terms of the work that we do. Let's take COVID as an example. Since the beginning of the COVID crisis, we're focused on connecting people with useful, high-quality information and really looking at how we have robust policies in place to tackle the issues around harmful misinformation that I said before. This includes removing harmful COVID-19 misinformation, raising authoritative and credible information. In particular, in India, we partnered with the Ministry of Health to launch an information panel around COVID to make sure locally relevant health information is available. We use YouTube's homepage to direct users to the WHO, the Ministry of Health, Family and Welfare, or MyGov in Hindi. We created a destination featuring 16 or so plus or more playlists across more than 8 languages where users could find reliable answers to their questions from authoritative sources. The destination featured content from the Ministry of Health and Family Welfare, also from MyGov India, leading hospitals, AIMS, Apollo Hospital, Max Healthcare, as well as other popular creators from Kavita's Kitchen, A2 Motivation, Mahatali, amongst others that we've worked with. We've launched COVID-19 panels around health that triggered when people search for health-related topics in 7 Indian languages, including Hindi, Bengali, and Marathi. And since February of 2020, our info panels and efforts to help users find authoritative COVID-19 health information across YouTube's homepage has been shown more than 250 billion times in India. But really, we want to go beyond that. We want to make sure that people are finding credible sources on our platform. So how did we determine which sources should be considered credible by the healthcare system? That's a challenge that we took on working with the National Academy of Medicine in the United States, and we started that process working with them in 2021. The National Academy is a nonprofit, non-governmental organization that brings together the top experts in their field to help provide unbiased, evidence-based information about health and science. They tackle the kinds of questions that are important on behalf of the medical system or other health authorities. And over the years, they've investigated and reported or given guidance in everything from climate change to the culture of health and even to things like gene editing. So to inform strategies for accessing high-quality health information on media platforms, including YouTube, we asked the National Academy to help identify, one, that definition, a preliminary definition of authoritative sources of health information, and then look at the criteria by which these sources derive and maintain their authority. This is really incredibly important work, and we hope that other tech platforms will review the guidance from the National Academy and determine how to best apply these principles in their own work as they go around and promote health information. So really, as we look to expand these features internationally, we wanted to ensure a consistent set of principles to identify authoritative health sources across the world. So that's where the World Health Organization and the National Academy of Medicine came together to convene a meeting of experts, really interdisciplinary experts across a variety of fields from around the world to review and validate these principles for global application. And earlier this March in 2022, we rolled out 2 new product features in India. One, health content shelves and information panels as well, providing health source content available in English and Hindi. These features help to connect people with sources that they can rely on, with new credibility cues that really guide users, consumers in understanding the information that they're receiving, and looking to point to more verified sources and high quality videos, and making those more visible in search results. Now, when users search for specific health conditions, example like lung cancer, breast cancer, or lymphoma, or hypertension, or stroke, we surface a video shelf of related health content from accredited and otherwise vetted health sources and institutions. But, we want to grow on what we've done. And when we think about future expansion, since these particular features launched earlier this year, we've really been working on ways to expand the pool of YouTube channels that would be eligible to appear in these particular features. So we've invested in how we grow our platform more, using this concept of both the principles that we talked about earlier, but also the products in terms of how we do use trusted information and drive public health communication within that context. So working with others at YouTube, we've really been committed to connecting viewers with health content from authoritative sources. And as our health features grow, we're looking to expand the types of health sources used within these health features. So to expand eligibility for authoritative sources, we've introduced an application process for health-focused YouTube channels. And to inform this process, we've worked with third-party health authorities to define these principles. So particularly on the US side, there was a Council of Medical Subspecialties, again working with the National Academy of Medicine and the World Health Organization. And we're piloting this overall process in the United States and Germany to start to kind of look at how we look at individual content and individual content creators, particularly those who are clinicians, so doctors, nurses, psychologists, health professionals around those lines. And we want to bring this process to more countries and other regions in the future. We're also working on ways to expand this eligibility criteria to more other health professions and other health sources. And to kind of give you a context of how it looks, firstly, applicants must be licensed, like I said, doctors, nurses, or mental health professionals. They then go on and attest to these information sharing principles developed by the groups I just mentioned that came together, the Council of Medical Subspecialties, the National Academy of Medicine, and the World Health Organization. And really, they state that content should be created in the best efforts to be both science-based, objective, transparent, accountable, and really taking into account the issues around inclusion and equitable access to information. So that health creators who attest these principles apply for their own channel or for a channel that they oversee or that the channel that they're in charge of, or that they're reviewing the content for. So they apply on behalf of those channels. And all channels that apply there are reviewed against these guidelines, and the license of the applying healthcare professional will then be checked and authenticated. And then that allows us to be able to promote these sources as verified sources of health information. So in the coming months, eligible channels that have applied through this process, they'll be given a health information panel right under at the bottom of their channel that identifies them as a licensed healthcare professional, and their videos will appear in relevant search results within the health content shelves. And health creators, particularly on the US side, we opened up that application on October 27th, and we'll continue to expand the availability to other markets and additional medical subspecialties, as I said, in the future. So really, we're just getting started. We're making important steps towards helping people more easily find and connect with content that comes from the extraordinary community of healthcare professionals and creators across YouTube. You know, these are some of the most smartest, dedicated, and creative folks who are transforming the ways that we share medical information. And effective communication is really at the heart of improving people's lives. And throughout my years of working in public health and practicing medicine, I've really seen the benefits of getting the right information to the patients when they need it, particularly in an engaging and in a way that the patients can feel a part of the information that they're receiving. And we're so excited for this next phase in our work. And by working with experts to develop some of the principles to inform our product features that I just articulated, this is really how we kind of transform healthcare communication across the board. And the overall end goal we have is connecting people with highly authoritative, credible health information that is both evidence-based, but also culturally relevant and engaging as well. So, to close, we invite you all to join us in this overall effort in terms of how we bring health information at scale in a credible way to the world. I'll close by just saying, my overall view and the mission is really this concept of bringing and making public health information truly public and bringing the best information to our communities across the world. Thank you.
Thank you, Mr. Graham, for this very informative talk. I now request Syed Nazakat, founder and CEO of Data Leads, on stage.
Hi, good morning, everyone. What a pleasure to be here on Saturday morning. And as Ruby was saying earlier, this is our first gathering after COVID. And I was so grateful to a lot of people in this room when the second wave devastating was happening, and we were really confused what's happening actually. As basic information, whether to take a vaccine, whether this is a lockdown, what is the safe way to come out of the crisis, people were really looking on social media for truthful information. And it was so amazing to see some of doctors actually became YouTubers, became, Fahim Yunus in US became a huge popular on Twitter, and so many other doctors in social media who were really reluctant ever in their life to be on social media. They came forward, they said, no, let's help people also with information because people are really looking for something. If Dennis can help me with this one. Is it? If you just, sorry, and people were really searching for, just be here for a minute if we could. Yeah, people were really searching for information how to go about the life. I will just make a couple of quick observations why we are doing this summit and why is YouTube Health supporting it and why all of you decided to join us in this collaboration. I know it has been a communication from last couple of months where we are trying to build what are the couple of discussion points we need in India to build a new collaboration and understanding about public health communication, health information system. I think it's fundamentally important for us to understand what's happening globally in a larger information ecosystem. How media, how press, how people are consuming information very differently. Earlier, there used to be a newspaper and people will read that, circulate that in neighborhood or in a bus stand or a transport. That's not happening anymore. And for the first time in the human history, we have more access to information than we're able to consume. And it creates a serious challenge for us. Sorry, And we saw one critical thing during COVID and before COVID as well, and I will tell you our story very quickly in a minute, that information vacuum actually is one of the key elements to drive people towards misinformation. Because when people do not have access to accurate and timely information, then they start looking for all kind of information. And that's where the problem starts. And our story has been very brief, and Dennis, I think something happening with this presentation. Our story has been very brief. This is a picture of our first initiative in 2015. This is a government medical college in Kashmir. What we did beautifully, we realized, I come from a very strong journalism background. I have no doctorate and all. But we realized we journalists can communicate better, but we are not experts on this field. We need doctors with us. So we brought 20 scientists and doctors representing different government organizations and 20 journalists in the room. The person you are sitting in the front is a Director General Health Services. He sat as a student for a whole day, and the rest of the folks are actually journalists. The person who is facing the screen here is the Director of Data Sciences at the AIMS Delhi, who came all the way to Srinagar for this initiative. My understanding was doctors will not come for this workshop. Why are doctors interested in communication and information, and why they want to sit with journalists? They have patients to attend, they have a lot of other things to do. To my surprise, 8:30 next morning, the room was half occupied. All the doctors were in the room, 20 doctors. Journalists were coming one after one after one after one. This was an amazing experience of how collaboration can function in the 21st century, where the scientists, policymakers, journalists all can work together. We took this initiative to the next level. move the next one. Yeah. Yeah, we took this initiative to 17 Asian countries, to Malaysia, to Hong Kong, to Singapore, all across, where we brought doctors, public policy specialists, and policymakers together. One more. Yeah, just move on. And we eventually had, now today, this is a group what we call First Check, which is a part of Health Leads, where we have the doctors all across from the world volunteering to be a fact checkers for public health. And during COVID, they did exceptionally well. If you have seen the stories published in the Nature about this initiative, how doctors came forward during COVID particularly to help fight misinformation. And as Surabhi was mentioning, Google has been an amazing partner and supporter of this initiative. And we decided when we saw people are not taking vaccines during COVID, we decided to launch a pan-India training series online. That's how we met last time during the Health of India series. We went all across India, one after another. In every state, we did something called Vax Check to just inform people what are the misinformation which are circulating about our time. Two quick things actually, which is like the future of misinformation is, is going to be there no matter how much effort we will make. It's very human to lie. It's very human to deceive others. It's very human to be bad sometimes. So now what we can do essentially is to build competencies in our communities. And today we are going to have a discussion on these critical components. We will start and then we will end the last session today on health misinformation workshop. How can we prepare for next year? How can we empower communities together? And once again, thank you so much for all for joining, and thanks to YouTube Health for supporting this major initiative. I'm very sure we will be having conversations during this summit. And I see a lot of thought leaders in this room. Thank you so much for joining. I'm particularly very keen. There's also a YouTube team still at the back, and they will be also available here for any discussion, any conversation about how we can strengthen the information ecosystem about public health. Thank you so much. Thanks a lot.
Thank you, sir. It indeed is my greatest pleasure to invite Padma Bhushan awardee and one of India's leading thought leaders, Professor K. Srinath Reddy, to deliver the keynote address for the day. Mr. Reddy is the founder president and honorary distinguished professor of public health at the Public Health Foundation of India. Mr. Reddy was the former head of the Department of Cardiology at AIIMS Delhi. He has also served on many WHO expert panels and has been an advisor on health to Indian states such as Odisha, Andhra Pradesh, and Punjab. During this tenure, he has also served as a physician to 2 Indian prime ministers. Welcome, sir.
Good morning. When one is invited to deliver, within quotes, a keynote address to a gathering of experts in health communication, one starts with great trepidation as to what one has to really say. And much of what one might have wanted to say has already been very elegantly and eloquently stated in the preliminary presentations. So let me start with a few challenges. Today, we started off with a news item that a cruise ship pulled into the Sydney harbor, the Majestic Princess, with 800 persons infected with COVID and confined to the ship. 1 out of 4 passengers was infected. Now, roll back to 2020, and when you had the Ruby Princess having a very similar and scary experience of a large number of people on a cruise ship who were confined and who were responsible also later on for spreading to several others when they actually got out of the ship. What has changed and what has not changed between 20 and 2022? Have people learned nothing? Those are the questions that people who are experts in behavior change communication perhaps should answer. However, we recognize that much has changed during COVID, and much has changed because of COVID. But when we really look at health in the broader perspective, there is a lot that still needs to change. Dr. Graham basically spoke about informing and empowering individuals, and particularly in terms of not only promoting and protecting their own health, but with the strong focus of a clinician, he talked about how people who are suffering from any ailment can benefit from accurate information given in a timely manner, which they can acquire and adopt in order to protect their own health and be part of the treatment process itself for better health outcomes. Having donned the hat of a clinician for several years, and later on having become a refugee to public health, let me try and bring the population perspective of public health into the picture. Health communication is necessary not only for informing and empowering individuals, but far more importantly, for bringing about changes at the population level in terms of behavior. And that is very clear from COVID. But if you really are going to challenge me on whether clinical medicine and public health exists in two different universes, I would say no. They're essentially a continuum of looking at health of people, because public health identifies and influences the determinants of health at the population level in order to impact upon health at the individual level. That it does through policies, it does through systems, it does through programs, it does through community engagement. And ultimately, the beneficiaries are the individuals or the composite units of that particular population. And therefore, building up public health capacity is also very important, and effective communication for population behavior change is absolutely critical as well. Just to point out how artificial this difference between public health and clinical medicine is, let me simplify it a bit. Clinical medicine delivers health in retail, public health delivers health in wholesale. Ultimately, we are doing the same job. But as we are doing that, we must also recognize when we are talking about individual behavior change, individuals' behavior is determined by a number of factors. It is not entirely something that is the sole choice of the individual, which is unfettered. If you look at some of the industries like the tobacco industry or those who sell junk foods, they'll come and tell you, we don't want a nanny state. We don't want people influencing people through regulatory measures. We want unfettered choice of individuals, that's freedom. And that you see, even in COVID, for example, you have seen how societies and countries which had a much greater social cohesion, greater confidence in a social collective, and had a spirit of social solidarity, did much better than the highly individualistic societies, just to name the United States of America, for example. So we do recognize that there is a need for influencing the social collective. But let me get back to the question of choice. Choice can be conscious based upon the correct information or incorrect information. So we have a responsibility to provide the correct information. Choice can be conditioned by aggressive marketing, promotion, peer pressure, sometimes cultural traditions. We need to address them as well. Choice can be constrained by economic factors, where you may be told that you must have 5 helpings of fruit and vegetables every day, but you may not be able to afford those helpings of fruit and vegetables because your pocket doesn't permit. You may be told that the N95 mask is the very best for you, and the organizers have very kindly provided each one of us with an excellent mask. But you tell the same thing to the slum dweller. Are they going to choose between buying some amount of scarce food for their children, or are they going to be spending it on an N95 mask? Why didn't the governments who have been advertising so much on mass media about how well they've handled so many things, could they not have distributed the masks to each family, about 5 masks for each family? So those are some of the questions that come up, how you have to really remove the constraints as well that exist. So behavior change is interconnected to the social dynamics. Just to also tell you how it can reflect back onto policy. Tobacco control was very difficult to achieve because the industry argued on the basis of individual choices and freedoms. It was when second-hand smoke became very well known and people realized that non-smokers in the family or in the working environment were getting adversely affected by somebody else deciding to exercise their freedom to smoke. And people were getting unwell, diseased, including children with asthma or others even exposed to secondhand smoke getting heart attacks. That the popular pressure built up on policymakers to come up with strong regulations, and the industry had to back off. So information is absolutely critical even for policy change. And when policies are actually introduced, for people to buy into that, to accept it, to willingly implement it, then again, the right information is required. And the right way of communication is required. And that we have seen in COVID as well. So it is absolutely important for public health that we maintain the channels of communication, both for community mobilization as well as for policy change at the top level. And of course, at the level of the individuals, for them to also get informed adequately and alter their practice. So the same thing applies to unhealthy foods. We are fighting those battles now of ultra-processed foods. The industry will say it is the choice of the individual, but then the choice of the individual is not fettered, and that's where public health has to step in, and where effective communication has to come in, addressing the policymakers at one level and mobilizing the communities at the other level, so that the groundswell of support in the communities actually takes the voice of the people up to the policymakers and policy response. Now, obviously, communication is a skill that everybody must acquire, particularly if you're in public health. And we must partner with the media much more effectively, and that is absolutely important. Clearly, if we are really looking at how to provide the right kind of information, counter and dispel false beliefs, it's also important that we also constantly understand, interpret, and accurately report science. We had challenges, even in the scientific community. We had people saying that there was no aerosol spread, it was all droplet spread. So introduction of masks was delayed. Then we had people saying herd immunity has arrived magically, like a clock, that we are not going to get a second wave, we are not going to get a third wave, that we have all got herd immunity. Little recognizing that firstly, the immunity acquired is still transient, lasts a few months, but more importantly, is herd protection, that as long as the majority of the people around you are infected, the virus may not be able to come and reach you because they're being blocked by immune bodies which are immune. But the moment you step out from that place and go to another place where not that many people are immune, the virus can still get you. It's therefore a herd protection. And in this highly mobile world where there's mobility within cities, within countries, between countries, what kind of herd immunity did we really think that we got in January 2021? And it is this kind of misconceptions that should have been constantly challenged, debated. Of course, we can never work on 100% certainty, but in fact, absolute certainty is only for the divinity and like-minded clinicians. But we must think in terms of balance of probabilities. Okay? If you do this, if you wear a mask, there is a 30% probability you might still get infected. If you don't wear a mask, there's a 70% probability you might get infected. Or if you are aged above 70 and if you get infected, this is the probability of you getting severely ill. If you're under 30 and get infected, this is the probability that you'll get severely ill if you don't have comorbidities. I think it is the communication of probabilities that becomes important also, so that people then can make the right kind of choices. But again, it is not only the individual. You have to decide who your family members are, who your neighbors are, who are the people at the workplace are. So the constant reminder that you are not just an individual, but you're part of a social collective, that is a very important element. And I'm glad that the social media is now recognizing the importance of social collectives. And I heard the introductory remarks that even watchmen in residential colonies were being reached in order to influence behaviors. I think it is the social collective, whether in small units in residential colonies or in the larger communities or at the country's level itself, that must be reached out. Because the individual is still likely to be guided by the social dynamic. And therefore, social media becomes absolutely important, and public health has to use social media with great efficiency. Therefore, our messages will have to be correct, clear, concise, cogent, and always likely to be also consistent. And that is very important for us to do it, rather than having what I can call our confused and contradictory messages being drowned out by the bluster, bluff, and blare of false news. And that is where I believe a partnership between public health and the wider media community is going to be absolutely critical for advancing public health across the country. And we at the Public Health Foundation of India would very much welcome an opportunity to partner much more effectively with those who can actually inform and influence people both at the individual level and at the community level. And we seek partnerships with other organizations which are also dedicated to the same vision and pursue the same endeavor. Thank you very much.
Thank you so much, sir, for this very insightful talk. It's always a pleasure to hear you speak. We are now virtually joined by Dr. Supriya Besbarwa from the WHO headquarters in Geneva, Switzerland. Ms. Besbarwa is the Global Team Lead for Science Translation in Public Health Emergencies at WHO.
Namaste. I'm Dr. Supriya Besbarwa, and it's a great pleasure to be speaking to all of you today. It's a pleasure and privilege because it's a subject that's very close to my heart. I was originally trained as a molecular biologist, but for the last 20 years, I've been working on public health risk communication, most of the time with WHO. I'm currently the team lead globally for science knowledge translation for public health emergencies. So this gives me an opportunity to talk about two of my passions. One is science, and the other one is science communication. Now, you might be thinking, why is that my passion? Firstly, the science. Why do I think science is important? It's because it's with science that we get the data, the evidence to really understand a health situation fully and to find solutions and answers essentially to the issues that plague us. So it's critical, and that is what we need to help make a situation better. But as we've learned from COVID-19, it's really people who are at the heart of any health issue. It's people's actions that make the difference in whether things get better or whether things get worse. You may have the best doctor prescribe a medicine to a patient, But if a patient doesn't like that medicine and doesn't take it or forgets to take it or finds it too bitter or whatever the situation will be, the patient will not get better, right? We may have the best recommendations by governments, the best policies, but which are all science-based. But if people don't follow it, if people, and we saw that happen, in crowded places, people were not wearing a mask because it was too hot, too uncomfortable, whatever the reason, then it doesn't work. You cannot mitigate a situation. So while you have the science, it's people who make the difference. When do people follow something? For them to follow the science, it needs, first of all, they need the information. They need to be able to get the information easily. Secondly, they need to understand that information. Thirdly, understanding is not enough. They need to also, believe in it. It needs to make sense to them and into their lives. They need to know how they can use it, whether it will really help their lives if they use it. And fourthly, it's a matter of convenience. You may really want to do something, but if you're too busy or if it's just not convenient, you're not going to do it for whatever reason. So we really have to take science to the people. For example, we've seen in vaccination campaigns, for example, when you've had door-to-door vaccinations, or when you've had vaccination centers that are close to people's homes, then they're likely to be more successful because you've taken the scientific solutions to the people. If it's somewhere really far off, but you campaign and you tell people you must get your children vaccinated, mothers will not be able to go far away with their babies to get them vaccinated. It may mean leaving a day's job to do so, which may not be convenient, which may mean loss of income. So convenience is also a huge issue, along with good communication, to take science to the people. And of course, people finally only follow what they trust. So how can we make science understandable, accessible, and trustworthy? Let's contemplate that in a 21st century situation. As we all know, we live in a very complex information environment, unlike our parents and grandparents. And actually, our children will be in a far more difficult information environment. Now we are digitally connected all over the world. Even in remote places in India, you have people, with smartphones in remote villages. You may not have other amenities, but you will find people with smartphones. They will receive WhatsApp messages. They may not have a TV perhaps, but they will receive information from their friends and family through WhatsApp messages. Probably every day, a good morning message or some sort of advice on what to do or what not to do. Now, that's the irony of our age. We have so much information, we have too much information, and that results probably in difficulty accessing credible, proper information, what to believe, what not to believe. How do you sift through that? So as public health risk communicators, that's our challenge, to help people sift through that overwhelming amount of information, to help them make the judgment of what is credible and what is not credible, what is correct and what is not correct for them. And so we need to then look at what people do, tend to believe and trust in. They tend to believe and trust in very often experts, like scientific experts. So expert speaking does make a difference because people think that's an authority, that's a person who really knows what he's talking about. But we need to then work with scientists to make sure that they are communicating their work, their wonderful work, in a way that makes sense to people who may not have as much knowledge as them, to make it simple and relevant to people. So that's the first thing we need to do as risk communicators, help the scientists communicate better. Secondly, people believe, their friends, their family, their community leaders, those they trust, especially community leaders. So again, we have to go to the community level, talk to them, find out what's relevant for them, and help them understand that science is a process, and this is how science works. And thirdly, the media. The media continues to be very, very influential. And you have excellent science journalists who, during COVID, have done some excellent reports. But as we saw during COVID, we also had journalists who were not experts in the field who also had to report because that was the key news at the time. And sometimes they did not have the background to fully understand or grasp the facts. And, there was unintended misinformation is perhaps a too strong a word, but slight change in information which may not have been absolutely accurate, and that sometimes gets amplified and misunderstood. So we need to work also with media across the board, not just the science media, to strengthen the scientific understanding of the media. Those are three key issues. Now, we've also seen in COVID-19 that there was a lot of uncertainty, and people were wondering what is true and what's not. But the way science works is initially you go with the information you have. Initially, we knew very little. As time progressed, scientists, worked round the clock and found out more and more. And as we understand more, our evidence gets stronger. Sometimes the recommendations, the science-based recommendations change. It's not that they were wrong before, it's just that the situation evolves. But the change sometimes confuses people. So it's very important also to help people understand that science evolves. That doesn't mean it's wrong. That just means it's evolving and we're getting better and better data. Sometimes because of the change, we've had conspiracy theories coming out and false news coming out. So we have to work with the public beforehand to explain how science works so that they do not get caught up with the conspiracy theories. Finally, to build trust, the key principles of trust remain: be open, be transparent, and be timely. Again, because we living in an interconnected world, any information, even if it's fake news and information, spreads within seconds. And once that is embedded in people's minds, to get the facts in, displace that misinformation with facts gets more difficult. So we have to be, the ones to get in there first with the credible information. So timeliness is of essence. And these, finally though, the most important thing in building trust, as with everything else, is relationships. And science sometimes has a PR problem. People think of science as, oh, that's not relevant to my life. That's too difficult. But it's not. It's science that leads to all the good things that come in your life, science and technology. So we have to work probably with people before a major issue happens, build up that relationship, explain how science works, help them understand the science at the level of the people, to build trust in science, so that when there's a major health issue, they understand what is right, they understand what is relevant to them, and use it and go forward, and together we deal with a health issue and successfully overcome it. In other words, what I'm saying is we have to take science to the people. It's a science should be for the people, of the people, and taken forward by the people. Only then will our work as public health risk communicators be considered successful. Thank you, and I hope you find that useful, and I hope you have a wonderful summit.
Thank you, Dr. Supriya. We are so glad to have you at the summit. To draw spotlight on the future of public health, I now invite Professor K. Srinath Reddy, founder, past president, and honorary distinguished professor of Public Health Foundation of India, Mr. Neeraj Jain, country director, PATH India, Dr. Kavita Singh, director, South Asia, DNDI, Dr. Chandrakant Laheria, public health and policy expert, Dr. Jaya Sridhar, Asia Media Health Advisor, Internews, and co-author of Let's Talk Vaccines, Dr. Indira Behra, Vice President, Global Health Strategies, onto the stage. My colleague, Jisha Krishnan, will moderate this panel.
Hello, everyone. Thank you so much for joining us today. And after hearing all the speakers throw open this conversation and covering pretty much everything that we want to talk about today, I think we have the groundwork laid. And I'm going to dive right into the conversation. The topic that we have for today is the future of public health. That's a very important topic, yes, but it's also a little intriguing because can we really predict the future? Do we really have a crystal ball that we can look into and know what lies there ahead? Well, I definitely don't have that skill, but we are in luck today because we have some of the finest minds, the experts. If there's anybody who can do that job, those are the people on this panel today. So they have a rich experience across the healthcare spectrum. It's a diverse panel. But before we get them to talk a little about what they see in the future, let's start with where we are right now. If I were to take a pulse of the group that we have here today, how are you doing? How are you? No, seriously, I want to know, how are you doing? How many of you all would like to answer that with a, yes, I feel great? A show of hands, please. People feeling great? That's nice. How many of you all feel, okay, this sucks, this is a Saturday morning and I'm here? You can show hands, sir. It's fine. You can put your hand up if you feel that way. How many of you all feel, I have no idea, this is what, I'm doing what has to be done, right? Things have to get done and we are doing that. How many feel like we're just going with the flow? How many of us? Just going with the flow? Yeah? Yeah? Okay. So I think that's a good way. At least we have a realistic idea of where we stand. Let's do that with our public health situation. Let's look at where we stand today. And as any good doctor would say, a diagnosis is the key. So let's get the diagnosis of how India's health is as of today. So if I can ask each of my panelists to please give me your brief diagnosis of the public health situation today. Dr. Reddy, if I can start with you.
You will notice that for your initial question, nobody on the stage lifted their hands. So there is a certain amount of concern about how India's health is. There is much to celebrate when our life expectancy is improved from 58 years in 1990 to about 70 now. In fact, even our infant mortality rate at 27 is supposed to be better than the global average for countries at the same income level. But when we compare ourselves with our South Asian neighbors, we are lagging behind in life expectancy, infant mortality rate, and many others, which means that commensurate with our rapid economic growth in the last 2 or 3 decades, we have not achieved the same amount of gains in health. But far more worrisome for me is the fact that there are huge glaring gaps in equality between different states, within states, between urban and rural areas, between social groups, between gender groups, and it is this that needs to be bridged. And of course, there have been several reasons why this has happened. Our primary care has been greatly neglected. We have been top-heavy with our investment in tertiary care, but that's also not evenly distributed. Our secondary care, again, has been a bit patchy with our district hospitals in neglect in several parts of India, though in some states there is a reasonable emphasis on primary, secondary, and tertiary care being strengthened and linked fairly well. And therefore, there is much that needs to be done if we have not only to catch up with our SDG targets by 2030, but SDG targets are also, in a sense, aggregate indicators. They hide a lot of disparities within the country. If you have an almost 8-fold difference in infant mortality between Kerala and Madhya Pradesh, then in the same country, then that is something that we really need to correct. And therefore, I believe, in terms of our own health, we do need to do a lot more. But from my point of view, one of the critical elements that we need to really look at is how we have actually configured, resourced, and managed our primary healthcare systems, both in rural areas and urban areas. Rural areas, the design existed, but under-resourced. Urban areas, the design did not even exist in several parts of the country. And that fundamental foundation of a health system has not really happened. And one of the key lessons of COVID-19 is that unless you have an efficient, equitable, and empathetic health system performing reliably in the steady state, even without a public health emergency, you'll not be able to create a strong, swift, and sustained response to the public health emergency. You'll be flailing. You cannot run fast suddenly if you're limping on one leg already.
Ditto?
Yes. No, you can't say that.
You can't do this. You can't invite us and have Dr. Reddy do the keynote and speak first. I have nothing left to say.
You know how Indian patients are. They would always want a second opinion and a third opinion. I'm coming to you for the second
I'm having a fanboy moment anyway, and then, there's nothing much. But, okay, so if you insist, I'll just give you some additional thoughts. I won't repeat what Dr. Reddy said because I agree with everything that he's already said. I think, we are also, on a positive note, we are sitting at a moment where I think public health has really come front and center of the general discourse. It's becoming highly political, and I hope it stays that way, because if it remains political, then there will be action on the ground and everybody will fall in line. It's also understood that equity is critical because it has a huge economic impact. We've seen what COVID did to us. The unfortunate thing is, I was listening since the morning, and I think we say during COVID. I don't know why we don't say during tuberculosis or during malaria, or all the other diseases that we still have and have had for many, many years. So there is a lot of work to be done. The challenge is going to be for all of us to actually come together and really go fast, because people will forget COVID very soon. As I was walking in, I was given a mask and I said, "Is anybody wearing a mask?" She said, "No." I said, "Then why are you wasting it? Keep it, So I think we've forgotten about masks. I see one or two people in the audience who are still doing the right thing. But COVID will be forgotten. It may fall off the politicians' map. Economics will go on. So let's be quick. Let's come together and let's start making a difference beyond COVID in all the areas that Dr. Reddy has already talked about. Thank you.
So your diagnosis is that public has a short memory and we have to make most of while we are there.
It's an emergency moment.
Yes. Dr. Singh, do you agree?
There is no point of not agreeing. It's what both of them said. I could also say ditto, but maybe just add on a few more, few pennies of my thoughts. And let me see it through the lens of neglected tropical diseases. And let me also explain why am I going to do that, for next minute and a half. Just to set the context, these neglected tropical diseases are a group, if you go by WHO classical definition, they're a group of 20 parasitic, viral, fungal, bacterial diseases, which affects the lower part of the, below the equator. That's tropical diseases. And the fact is that they really impact, these diseases, they impact the most vulnerable and marginalized communities in any geography, wherever they exist. And they create this vicious cycle of entities and poverty. So entities, you have a disease, you have Kala Azar, you have lymphatic filariasis, which we call as Hati-Paw or elephantiasis. And what will have, it will cause disability, it will cause disfigurement, it will cause social stigma, it will bring in loss of productivity, bringing in poverty. And poverty, what it does, it doesn't allow you to have the right access to water, sanitation, hygiene, standards. And that is where these diseases thrive, because they are vector transmitted, and that's where they get. So this whole cycle continues. And the fact is that out of the 20 diseases, many of them cannot be in India because we don't have the vector, but 12 of them still exist. So the message is that if it is a litmus test, if this is a proxy of our universal health coverage, then we have a lot to attain yet, a lot. And in so many of those diseases, we naturally, because of our population reasons, but the fact is that we are the largest contributors globally in the numbers when we say these are the numbers of these diseases. Neeraj started with a positive tone. We need to be positive. We have eliminated a couple, but what has happened? Our basket is full now. We have all of them existing. We have new ones adding on, and we have NCDs adding on. We all saw during COVID, diabetes, diabetics, hypertensives are more at risk, and same things happen here. So it's a double whammy we have in our basket. And maybe I'll just stop there because this is a litmus test, and if we have not passed that, we still have a lot more to attain.
Dr. Lahiriya, the double whammy exists?
Thank you. Thank you very much. I agree with most of the points which my fellow panelists have made, except one. But I'll come to that later on. So the current diagnosis of India's healthcare system, I would say that one thing is certain, that India's health system at the national and state level is definitely better prepared for any future outbreak or epidemic. So COVID-19 pandemic has done that situation that we can definitely handle epidemics, pandemics better than we were before. We were in a situation before 2020 or before COVID-19 pandemic. Having said that, I think another development which has happened in the last 2 or 3 years is that the weaknesses, loopholes, or challenges of India's healthcare system have been better recognized. But the unfortunate part there is that the recognition itself is not enough. I do not agree, and I do not think that health or public health become a priority in India. When something happens in emergency situation, there is no way but to respond to it, and that's what had been done in India. We read the it was in the front pages of newspaper and the prime time of television channel, and everyone was talking about health because we had no other issue at that time. But if we have to say that it has become priority, the real test of such priority that whether it is sustained beyond that emergency situation. And I don't really see that it has been sustained. We are hearing that it has almost been forgotten. And I am afraid, I wish I'm wrong, but I'm afraid that in a few months from now, health will be sidelined, relegated to the sidelines, and nobody would be talking about it. It is not an election issue, it's not there. So I do not think even this pandemic could make health and public health, and these are two different things, not a discussion, are public health priority. And third and final point, and of course I would be happy to elaborate later on, third and final point is, ironically, in my opinion, the COVID-19 pandemic, which should have brought attention on public health and preventive promotive care, but I strongly believe that it has further medicalized healthcare system. Thank you.
That's a very interesting diagnosis, and so we don't have a panel that agrees on everything is being said here. So Dr. Sridhar, if you could tell us your diagnosis of the healthcare situation in India today.
So let me just begin by congratulating YouTube and data leads and health leads and for the privilege of being here in this, what I would think is my mothership. And I fear it's becoming an echo chamber because there's so much agreement and acknowledgement all around about the state of public health, not only in this country but globally, as well as the information ecosystem that is sort of perpetuating the sad state of affairs. So let me first begin by saying thank you so much for the privilege of learning from all the esteemed members on this panel. And let me go on to add a few things to what's already been said. The first thing is I would like to pull back a little from public health in India and just nest that concept within global health. I think that's a really important conceptual shift we have to make, not just regional, also global. And if you look at the global health context, we have to position public health in India within the larger concept of One Health. So we live in a period where there is already talk of a sixth mass extinction. We're moving towards that. COP27 going on right now. There's climate change. What we fondly refer to as neglected tropical diseases are extending far beyond the tropics. Mosquito domains are going up. We're no more trying to, I think WHO is trying to reclassify and, take away the term tropical diseases. So I think there's a lot of shifting sands. The ground is sort of corroding under our feet as we speak. And as Dr. Laheria was saying, we're still firefighting. As Neeraj was saying, we still firefight health. We look at emergency situations and try to take the opportunity to sort of quickly address it. It's going to fall by the wayside. And as Dr. Srinath Reddy was saying, public health, primary health, investments, all of these things have to seep into public consciousness. But let me again pull back to say, wouldn't it be wonderful if we could reshift our paradigm a little bit and put health into practically every sector of the government, into everything that we do. We should have a health audit. So what does it mean when I'm setting up a factory? What does it mean when I'm going to put a bunch of tailors in a small enterprise in a village somewhere where someone has TB? Do I have ventilation? I mean, this kind of thinking that health, let me say, Jisha, as I'm fond of saying, you may have heard me say this before, we come to the health sector only at the fag end of health. We come to get the Band-Aid put on our coffins. We come to get some remedial action for something that was put in motion by a number of other sectors long before, and we as doctors are left to pick up the pieces. So preventative health, I think, is really what we should be talking about across the board at a global level and hold people accountable. I think there's a lot of information activism that's needed at this stage to hold governments to account, to hold policymakers to account. And me, for one, I would love to see India's polity to start with getting a good class on public health, maybe led by some of the luminaries in this room, so that they can understand how a health audit is very important for everything that they do, every decision that they make. And if we did that, we would see investments opening up across the board for public health, and the burden on just the doctors having to diagnose and treat the damage that's done by the other sectors would be far less. So I think the investments and the wider thinking really might make a change. And it's interesting to get some discussion going on around that in our global public information age that we are in now. And it's interesting to tap into that thinking because we have so many young people now all over the world who's so exposed. I was thinking when I heard some of the other participants, we, at our old age, if I may say so, we are sort of overcome by the shock of so much information, so much choice, so much mis and disinformation. But when I talk to my young students who were born long after the AIDS pandemic peaked and declined, and they say, no, it's enough, we can handle it. They seem to know where to go, what kinds of information, so their mindset, their comfort level with what we see as an infodemic is far higher, and it's different. And I think it's important to tap into that understanding, to see what are they doing, how are they navigating the info space today, and we older people have a lot to learn from that. I have more things, but I'll save them for later.
We'll give you an opportunity to say more on that because that's an interesting point and we definitely want to touch on that. But Dr. Behra, before that, if you could give us your diagnosis of the health of India today.
Thank you so much, Jisha and the team at Health Leads. And of course, I think there's a lot that's already been said over here. Can everyone hear me? I don't know how much really that, I can add to this, but I will say, and at the risk of repeating, I think we're doing okay. If that's an okay diagnosis to have, because as Dr. Reddy, of course, started by saying, when we compare status with countries which are in similar leagues, from a socioeconomic standpoint, we really have a long way to go. We're going to be the most populous country by 2030, apparently. And that's a huge strain on resources. And I understand we're reaching, most of our states have reached replacement fertility rates, but we still have our outliers. And there are huge disparities between states. We have many countries within our country. And there has to be far more balanced and equitable and perhaps, tailor-made focus on all of these states. And health itself, it doesn't really exist. It is multidimensional, right? And it is multidisciplinary because there are so many factors that go into it. How much investment are we really putting into health? As a country of this size, we spend, and I believe that our public spending has actually contracted. 1.23% of our, 1.28, 1.3% of our GDP is nothing. And if you translate that into a per capita spending, that's, that we do need to put in a lot more. We have huge out-of-pocket expenditure and huge catastrophic expenditure on health. And in a country where, 70-odd% of your wealth is concentrated within, 10% of the population, that you're bound to have gross inequities. And you can't deal with some of these things without dealing with a lot of economic issues. But, beyond that also, you have to look at how you're addressing the needs of 50% of your, 49 point whatever percent of your population, women. Where are the women in, when it comes to education, when it comes to actually holding on to income? Where are they in workforce participation? All of this matters, and even in leadership, this matters because it affects how our country's demographic transition will happen. It affects how people access care, how children, how healthy children are born. It affects how policies are made that are, responsive. How are we looking at things like nutrition? How are we looking at things like TB? It's gone on long enough. And I know there is an effort, but these are huge problems. We're talking about 1.3+ billion people very soon. We've got a huge NCD wave coming in, with heart disease and diabetes. We've got increasing rates of cancer. How are we going to think about screening? How are we going to think about preventing? Where are we looking at vaccine R&D for any of these things? How are we looking at screening and prevention of treatment? And I think even my biggest worry in all of this, climate change is a big contributor, right? And it's the elephant in the room. We just walked in there from, somewhat of a gas chamber outside. How is this going to affect everything that we're doing? And maybe, even in the, in the human health space, I think the idea of One Health is so important to consider because We have, and that's what scares me the most. If you ask me what one thing scares me the most, I think it's AMR. Because there is a huge problem coming our way. And I think we probably need to be a lot more coordinated and quick in addressing it. But beyond that, there's always hope, and I know that's part of your next question, so I'll leave it at that.
Oh, I like how doctors put it. They'll give you the worst of news and they'll say, but that's all right, you'll be fine. But how exactly do we get fine from here? My question is actually for Dr. Reddy, because you have been in this space for so long. When you can see the solutions, you know obviously the things are going wrong and there are better ways of doing it and they're not being done. How do we ensure that we do not get cynical about it and we are able to still get the work done? Are there actionable insights that people in this room who are here today, and if they are in positions where they can make a difference and they should do it, is there anything at all that we could perhaps take away from this conversation? And if you could tell them, okay, things are bad, but we could make it better right now.
Well, the New Zealand rugby team has a motto. Better is never permanent, better every day. So you have to constantly try to be better than what you are today. And that is where the health system has to improve its performance. Firstly, there has to be more money for health, but there also have to be allocative and utilization efficiencies within the health system, with the right kind of priorities, with the right kind of performance and monitoring, and that is more health for the money. However, I believe it's absolutely important to address the question that Dr. Laharia raised. How do you stop health, and particularly public health, from becoming a fading entity on the radar screen of policymakers, of even the media, for that matter, because the media will switch on to something else? But I think the important thing is to root it in the communities. When I say that, it is absolutely important to take advantage of the opportunity now being offered by transfer of funds to the local bodies, the panchayats and the urban local bodies, thanks to the 15th Finance Commission, for primary health care. Which means that primary health care, again, is not just health services, but also, as rightly been pointed out, many other sectoral activities which influence health. Water, sanitation, possibly pollution, many other things that come in. Road safety, all of these will come in. If we can constantly engage the local communities and help them monitor, firstly help them make the right choices in how they allocate money, but also monitor progress, and mobilize the communities to ask for better services, public health as well as medical services. That's going to be an important engagement. Thailand has a model of village health assemblies, then provincial health assemblies, culminating in an annual national health assembly, where community representatives, representatives of the government, representatives of the academia, representatives of the civil society, sit together, examine the progress or the lack of progress over the previous year, and chart out the course for the next year. So there is an accountability mechanism as well. Unless we actually bring that level of community engagement, and there is no reason why data leads cannot actually organize district level and state level activities. So for that, you need decentralized data. You need that data to be fully shared with the people so that they have aspirations for improvement. And then we start asking the right questions. Not just, is there a hospital where you can take your child when the child gets sick? But what can we do to prevent your child from getting sick? So we have to engage the communities in those conversations. Unless that groundswell comes up from below, you're not going to see policy change coming in readily and steadily.
That's a fair point. I want to come to you, Dr. Singh, because as people have been talking about how during the pandemic there has been greater interest in health, but it's not an equal playing ground for all the health problems that we have. Like for neglected diseases, I believe that the investments have been a lot lower. You all have been facing other kind of challenges. So while the spotlight is on health, a particular health crisis, there are a lot of health problems that fall off the radar at that time. So if you could tell us a little bit about the challenges and how do you see a way out of that?
The second one is difficult to answer. But no, you've actually touched a very right chord, which is so close to all of us who work in the neglected tropical disease space. But there are a lot of learnings also. Maybe, and I don't want to throw COVID out of my plate for learnings, at least using it as a learning platform. What did we see during COVID? We saw that investments were made. We had diagnostics, we had treatments less, we had vaccines at an amazing speed of innovation. We have never seen globally, since the world is there, since we're making drugs, we've never seen this pace of innovation. And honestly, if we see dengue, we talk about dengue much more for much more diseases, but scientifically, we have less than 10 to 15% of scientific information for dengue in comparison to COVID. So, that's why I say we really have so much of surrogates to understand. It means what has happened. It means investments have not gone in. And normally when I participate in public health conversations, I never see a demand of research and development. I have never seen it put it on the table. We talk about preventive, we talk about expanding public health cares, reaching the child early, reaching them to school, but we never demand our rights for a new drug. We never demand the right for the right tool. Okay, post-Kala-azar dermal leishmaniasis has been in the country for centuries, I should say. We still don't have a right drug to treat it, right? While for COVID, we had a test which costed just 500 rupees, while costed $50 in Geneva at the same time. But I still don't have a good test for lymphatic filariasis. We still don't have a right drug to treat snake bites. We don't have treatments for rabies. We don't even talk about them. We don't demand them. As a user, as a community, as a patient, I don't demand. I just accept what I get. So I would say maybe it's time for the countries which suffer from these diseases. We know North doesn't suffer. We know North will not invest. We know large pharma will not invest. They don't get returns on investment. But is that the only bottom line we are looking at? Maybe that mindset change. And when you asked for what can be done, then I would say the countries need to invest to push the boundaries of science, to enhance innovation, and make the innovation available as tools at the right at the right space. Today also in Bihar, which is endemic to Kala-azar, there is just one center which does bone marrow aspiration to CLD bodies, just one. How do the poor travel to reach that center? And you can see the delay in diagnosis and the delay in treatment and the poverty cycle which then sets in. So, I don't know, maybe I've answered you here.
Yes, most. And you have also put out a lot of questions to which we do not have the answers, or we've not found the answers yet. But Dr. Behra, you also work a lot with multiple stakeholders in advocacy. How do you put these points on the table? How do you get all these stakeholders to consider this important enough to discuss beyond the return on investment, or how it will make us look, the public perception?
Yeah. Thank you so much, Isha. That is something that I wanted to bring up, and it goes to the point that Dr. Reddy also made about how you generate demand in general, and that is very directly linked to the bridging information asymmetries. Now, a lot of people just don't know, whether it is people in decision makers in politics, across the administrative departments, and through the tiers of governance across the country, and even on the demand side, that is the consumer side, the patient side, the population side. People don't know enough about their own health and about diseases and how greatly they are impacted by it to actually feel that sense of urgency. So until you bridge this information asymmetry and you build that kind of awareness and understanding, there isn't going to be that kind of demand from people, and there isn't going to be that kind of prioritization even on the side of decision makers. There are too many things to do. It's a huge country. We have a lot of things to deal with. But building accountability into that system, I think, is a very important thing. And we did work at Global Health Strategies at the block level in a few blocks around the country, and where we worked with the Gram Pradhans or Sarpanchas to make them more aware of particular health issues and RMNCH, reproductive maternal child health, TB, COVID, and figure out how they could actually build awareness, spread awareness, but also be more aware of what they can do, what their roles and responsibilities as community leaders can be. And immediately, once we did that, we saw an increase in the number of times the Village Health Sanitation Nutrition Committees were actually convened. The VHSNCs were convened. VHNDs were more effectively run. People started looking at more and allocating resources towards upgrading their health system. So that is one big, part of it. And even when it comes to political leadership or people outside the health departments, when you start getting district magistrates involved, when you start getting MPs involved like we did, we just give them simple Excel sheets which were trackers of the basic data from the program. And now the TB program is doing something similar. They're able to see just very simply what matters to them. Is it working? Is it not working? And then they can actually come in and be effective troubleshooters and problem solvers, escalate, ground level, district level, constituency level issues, okay, and get solutions, brought in so that these challenges are solved. So it's important to create these feedback mechanisms, use data, and build awareness effectively. I think another thing about when we're bringing in R&D, and this is another part of it, right? How do you get people to invest? It's only when they understand the magnitude of the problem. And you have to make them aware of, whether it's from a regulatory, whether it is from the availability of technology, okay, or it is, the lack of supportive regulation. There is a lot, I think, that we can actually do to improve, for example, the speed at which the amount of money that goes into new technology and services and the way it's delivered, or even creating frameworks that allow for new technology. For example, new medication in TB has, have finally come around after decades, okay? How do we do things that can accelerate? The ASEAN, for example, has this idea of, standardization and harmonization, where if countries of a certain group have said, okay, this works, okay, let's see how quickly we can bring it into the country. So how do we make an environment that is overall conducive to awareness, accountability, but also bringing in new ideas, new technology and services? I think a big part of this will be whether you have the right kind of people in the right places. I mean, we do have, large disproportions in, healthcare providers, but also even across sectors, like it was being said, how aware are people of, health-related issues and how they can actually support them? So
it's interesting you should make the point about getting different people together. And I know that I'm going to the safest person on this panel. Neeraj, if you'll back me here, because the others all have some kind of medical background. And so as the only non-doctor in this group, if you can tell me, sometimes doctors can also be a little tough to work with, no? Like, they may have all this knowledge, but they may not be the best of collaborators. Have I got that completely wrong?
Well, I run an organization which has about 700 people, of which 400 are doctors. And I studied finance in my postgrad. So, yeah, I'm completely feeling inadequate on this panel right now, just like you, Disha. No, I think without the doctors, we cannot deliver on health. Ideally, if they've also got a public health background, like many of them on this panel, then they are able to sort of go beyond just the patient to a larger population health thinking, which is quite different and which is extremely important. I also find they are very collaborative. So they would, if you think about where they want to go or where the impact they want to try and create, it's always common. Their pathway is always different, and they will argue about that. So as long as you're focused on the end result and continue to have the banter, we get there. So that's just my learning from working with many doctors and delivering a lot of good results, actually. Thanks.
That's one misinformation busted. I'm happy to know that doctors are easy to collaborate with. That's a good learning on this panel. But Dr. Sridhar, would you say the same with about journalists and media? Because you have been working very hard to get journalists to understand science and communicate science in a way that is not just factually correct, but also engaging. Are journalists a difficult cohort to work with?
Sometimes. Depends which journalist it is. And I, and I also think the difficulty comes from a lack of comfort or security with your subject. Most journalists tend to get defensive or file misinformed articles when they, as many of the earlier speakers pointed out, it's just a simple question of, did you read that paper? Did you attend that conference? Did you listen to Neeraj or Dr. Srinath, Dr. Leria or other, did you learn that new thing? And were you able to understand it and interpret it, as Dr. Baes-Barua said? So it's a question of getting comfortable. And getting comfortable with science means you have to put in the hours, you have to do your homework, you have to be where the expert speakers are and learn to grasp the evidence. It's hard sweat. But if we can do it when we're covering India's nuclear doctrine, when we're covering the politics of petty politicians, even in the smallest towns and cities, you know who said what when we're able to cover film developments and sports with such avidity, it's just getting interested in this subject, which is so relevant to our lives. So every journalist in this country is capable of rising to the best kind of science communicator there can be. That's my undying belief and hope, and that's what inspires me to keep working with them. But I'd like to point out that one of the things that really needs a lot of time and investment is empowering journalists who report in the local languages in this country to really have the same opportunities and the same level of confidence reporting about health that their English counterparts do. It's local language journalists who reach a huge number of the Indian population, particularly in the tier 2 and 3 and 4 cities, which is now rapidly getting internet savvy and getting access to a lot of digital information. And when local language journalists get the terms in their own languages for scientific concepts, such as window period, for instance, or what is a confidence interval, I'm going a little far here, but still, let's not assume that they don't get it. They very much get these concepts if you take the time to sit down and work with them. And what's more, they're a wonderful pool of talent to tap into because they can convey those concepts in a way that culturally resonates with the local populations that they report for. And they not only, if you look at the flavor of reporting in the local languages, you'll find it's full of cultural idioms and metaphors. It's full of the local religious beliefs, and it really sings with the people in a way that the English language, dry, analytical, sometimes intellectually egotistic work never does. So we need both. We need a mix of both. But I really think it's time for us to acknowledge the the opportunity that local language offers and invest in scientific training for them, scientific communication training for them, so that they can really make a quantum jump in the way India understands and relates to science. The accompanying thing to that is building a scientific temper among our population. It's a long-term goal, but an investment that needs to be made, should have already been made. We're late getting there, but I think it's happening now. Why? Because we're getting misinformed everywhere, and that's, again, we're firefighting the misinformation. But had we invested in helping our local language journalists and helping these conversations, going a long time ago, we would have been far better prepared to interpret the amount of information that's being flung in our faces now. So cultivating a scientific temper means not expecting people in a village somewhere to straight away get it that, scientific evidence may change according to evidence that's changing. To swiftly evolving science, masks one day, no masks another day, ivermectin today, no ivermectin tomorrow. So what is changing? Why is the WHO changing its guidance? If they're the holy cow of public health, then, but that's the way science works. As all of us are fond of saying, science keeps building on itself. Science doesn't have the answers. But getting someone in a village to sort of grasp that, you mean scientists don't know? That's the single overriding message they get. So how do you get them to respect the way science works as its strength uncertainty as its strength. Scientists are very certain about what they're uncertain about, and that's something to get people comfortable with that you need to live, change, grow, and take the best possible guidance from the available evidence at the time. So this means a lot of conversations through a lot of channels by some very influential, powerful, trustworthy sources. And we're talking about, as we've been saying throughout this conversation, that's the kind of healthy information ecosystem we want to move towards. So a lot of players need to get involved.
Right. And those are very interesting points you made, and I've saved the best question for you, Dr. Lahiri. You'll thank me for that, I hope. All these people are working with different cohorts, or at least I tried to tell them that they are difficult to work with. During the pandemic, you worked with, I think, one of the most challenging information ecosystem that you could work in. You were online, on social media, very active, trying to dispel all the misinformation. And I'm sure that has been a very, did that teach you a thing or two, or was it a very humbling experience? What kind of an experience was that?
Thank you very much for the kind words. And since I'm coming last in this round, so I'll reflect about what has been discussed and this journalist and my learning part. So let me address second part first. I think it was immensely learning for me as a medical doctor. I'm a medical doctor, worked in public health, but the communication or packaging the complex information for general public was not something which I did as part of my role. Like I went to the academic conferences, spoke there and all of these things. So this was really challenging. And this is what I have learned and hopefully improved over a period of time. But I would also reflect about journalists and medical doctors. And I think during the COVID-19 pandemic, this has been a really important development which should be sustained. I probably can speak on behalf of medical doctors that all medical doctors are not the best public communicator. They are good in clinical skill, but that does not translate into being a public communicator. Alongside journalists, and we know people who are in journalism know that a health beat was not even considered a respectful beat before the COVID-19 pandemic. So health was not being addressed, and then they were dealing with the pandemic where every passing hour the information is changing. So it was a complex situation. I think I learned because I worked with some of the journalists, and this duo of journalists and medical doctors where complex information was unpacked by medical doctors and then presented by journalists to the media, and that communicated to the wider, informed wider audience. But if misinformation also emanated from likely reliable sources, it was because even journalists got the wrong people to provide them information. So we cannot blame anyone on this one, but this is learning. But what I have been arguing, and that's my key point, that if we want to derive learning from this pandemic, probably medical doctors, especially those who deals with the media public, need to learn a communication skill little better, simplify that thing. But I also think, and I have argued a couple of times, that learning from this pandemic, and we heard earlier conversation about different social media platforms thinking of bringing health to the forefront. It is time that newsrooms of both print and broadcast media need to have a medical expert, independent medical expert who guide or at least go through those information or news writing. I know journalists like their independent, everyone like their independent viewpoint, but sometimes technical information being vetted. So in US, for example, there are medical doctors who are part of the broader media team, and that approach should be considered. If you allow me, I would reflect a few more points about this earlier. Quick point. So coming to the reflection about how India's healthcare system can progress on this thing, and I would say narrate the story of this, like in Indian mythology, we all know Samudra Manthan, the churning of sea happened, and that brought out 14 items. Now what the point to remember is that churning of sea or Samudra Manthan is important part, but it happens only once. And that analogy, if we take to the any healthcare system, for example, we keep saying about National Health Services in UK. This was immediately post-war, and then they designed a system. Now that churning for India's healthcare system had been slightly slower, but we know what need to be done to improve healthcare system. So we cannot expect a fresh churning or something very transformational coming. In fact, in India, led by Dr. Reddy and a high-level expert group. The second churning also happened to design what should be done to India's healthcare system. My summary point is that we already know that what need to be done for strengthening India's healthcare system. Key that we identify key points such as private sector is a reality, so we need to work together with the private sector. We need to
Dr.
focus
Lehra,
upon
I'll
primary
give you a
healthcare.
chance to say that because I have one quick word that I want each one of you all to tell me. This is the last question before we open it up to the audience for a couple of questions. Quickly, because we are already in November and we like making resolutions for the new year. So tell me one health resolution that India should make for 2023. One resolution each, and then we open the questions up to the audience.
The resolution is simple to state, but will be rather difficult to implement unless everybody joins hands. We are now moving towards Sustainable Development Goals of 2030. Health is the best summative indicator of success in each of these goals and across the goals. Whether you take poverty alleviation or food security or urban development, everywhere health is impacted. And if we can recognize that it is health that needs to be measured as the indicator of success across the SDGs, then we'll bring in multi-sectoral coordination, we'll align policies, we'll align different communities across that. But that message needs to be very clearly communicated and adopted. So health impact assessment is a very important element which the media again also must take up.
So we have health impact assessment. Neeraj, if you would like to add to that.
Yeah, for us, for me, it's going to be collaboration. We saw that in the last 2 years, people who normally would never talk to each other are collaborating. I can tell you, I'm collaborating with most of these people on stage. We have to collaborate if we want to really make a difference. So 2023 should be about taking all the collaborations forward, making new ones, the health sector really coming together, donors, partners, private sector, development partners, everybody's got to come together. And you guys, very important.
Definitely. So we collaborate in 2023. What else would we do, Dr. Singh?
So it's continuing on collaboration, take the collaborations beyond the boundaries, get regional collaborations. And I'm sorry, but I'm going to harp on this again. I would again say R&D has to be on the agenda, and R&D collaborations can bring amazing results. You know, the sort of deep domain knowledge which exists in different parts, we get them together. That's why cross-border, regional, South-South collaborations with R&D as one of the main pillars of the health system.
Dr. Lehra, the resolution for 2023?
The resolution which I would like to come forward is strengthening of systems at all levels for collecting health data, interpreting that data in timely manner, and use of that data for action. Thank you.
Yeah, there's so many things, but I'm like completely supportive of everything that everyone has said, and I'm all for Dr. Reddy's like health audit across sectors. I think that's key. And I think the resolution ought to be the starting point, which is getting thought leaders from across all sectors, getting the polity on board, and I think giving them a clear grasp of the context that we are in globally, regionally, and nationally, vis-a-vis public health, and that all the investment we've made thus far can erode and crumble very quickly. That sense of urgency has to creep in. So I think we have to start with persuading a very small but determined group of powerful decision makers who have the money bags at the end of those fingers. We have to get them in a room, convince them, and then go from there. I think that's really key.
I love the sound of that, Dr. Sridhar. And Dr. Bera, the last word.
Okay, to add to what everyone else says, I suppose, well, we're taking over the G20 presidency, so the world is watching. We definitely do need to do all of this, including spend more money, you know, go for specific targets. Number one, I would say two things. Go for specific targets, nutrition, TB, cervical cancer, you know, and there are 2 or 3 others up there, and focus on the women. it's very, very, very important that we focus on empowering women because that makes up half of your population and it can do wonders for the way this country's health goes.
So now we have time for a couple of questions. If we can have direct questions and you know whom you're addressing it to, please, if we can have the mic there, please.
Thank you so much. So it's absolutely a pleasure to be part of this gathering with distinguished speakers and experts. So I am Dr. Dikshit and I was part of the Common Review Mission team of Government of India and we returned yesterday itself. So had a very rich public health experience from the field. So my question is directed to Professor Reddy, who is an expert in primary healthcare. So, sir, I want to share with you my experience of being in villages recently, very recently, just last week. So I noticed that all the registers are, which the health workers are maintaining, are being diligently filled and, very well kept. But when we validate the same in the digital counterpart, the tablets which have been provided to them, so that there's a huge discrepancy there. And as Chandrakant Laharia sir also pointed out, that how this data collection can be improved from the primary healthcare level. So I would really be happy to know your thoughts on that. Thank you very much.
Firstly, I think we must make it easier for people to collect the data, far less cumbersome than these bulky registers. Secondly, we must overcome some of the barriers in the language which sometimes lead to misreporting. One of my colleagues in PHFI at the Indian Institute of Public Health in Hyderabad, Dr. Suresh Muniswamy, has developed icon-based software for ASHAs, auxiliary nurse midwives, to do the reporting, and which is totally language neutral and which can be applied across the board in India and elsewhere too. And if those can be perfectly validated, then it becomes far easier for people to enter the data in real time and with great accuracy without having to puzzle over which words and which slots to fill in. So I think it's important that we use the strength of digital health appropriately by making it easier for the frontline health workers to report in a timely and accurate fashion.
Do we have the next question?
Thank you. So my question is to Dr. Kavita Singh. We talked about health audit and like from the 2005 onwards, NHM, NRHM was there and we've been trying to, sort of morph into a district level approach. Makes a good case, but still the health priorities, at least the public health priorities, are majorly driven by the top-down approach and like how to basically transit to that that it's health audit driven and what needs to be achieved. So that's a difficult thing and we have been talking about a lot and a little progress, please.
Are you sure you want me to answer it? I have better people, better colleagues here who would maybe take this question. Yeah. Chandra, the chair,
yes,
want to
please.
take that? Dr.
Sridhar. Under a USAID supported project, the Resource Group for Communication and Advocacy in Community Health is working as a partner of the National TB Elimination Program. And in order to promote communities to get more involved and engaged in decision-making about their own health, something which was underlined repeatedly by Dr. Reddy, the community engagement aspect, what's happening is we have trained TB champions to go and work among the communities that they themselves come from, to relate their own TB experience, and then ferry the patients for diagnosis to the TB units, as well as follow up with them post-treatment. And then we've established a feedback loop system where you can talk about your experience through the care cascade. What was it like, your diagnosis? How was it, the counseling that you got during your treatment? How are you dealing with side effects? How are you dealing with the social impact of your illness in your home and at your workplace and at the village level? So this community feedback is being fed back into the MOTC, to the treatment supervisor, into the NTEP. So this is, I believe, really important. There have been attempts to establish these feedback loops earlier, but this time it's a completely community-led, accountability-driven initiative by TB champions, and they're very credible sources of information for the communities. So the idea is also to align it philosophically with the WHO's global move towards people-centered care. So you want people to be equal partners with the health system in decisions about their own health and make them feel part of the process, not be passive recipients of healthcare. So that will reduce the burden on both the healthcare providers as well as the recipients of healthcare. And I think this is a good way to sort of democratize health, make it community-led, and give them the confidence that you can question the health system. So there's a lot of good headway being made with this. It's in its second year of, third year of implementation, and I'm happy to share some feedback with it. And I'm leaving the thing open to the other panelists to sort of engage.
If we can take one last question.
Good morning. This is B.K. Mitra. My question is directed to Dr. Reddy. Sir, you mentioned that in Thailand there are community survey or the community take up by the health workers. But what I consider, considering the huge population of India, we have got dearth of public health workers. There must be good number of health workers, so we can have some school or training center for public health center workers every 100-200 kilometers, so that huge population of India can be covered, and we will also generate the employment opportunity. The government is thinking not thinking, government is already going for increasing the number of medical colleges. But not only the doctors, we require public health workers. So what I feel that there must be a large number of health workers, and the policy makers should think of these points. So what is your view, sir?
I completely agree with you, sir. It is absolutely essential that we build a multi-layered, multi-skilled health workforce, but having adequate number of well-trained frontline health workers is absolutely pivotal, especially since we have been talking about the importance of primary health care. Indeed, if you look at the data from WHO, they say that we must have, for achieving SDGs and universal health coverage, 44.5 doctors, nurses, and midwives per 10,000 population, and we have actually much less than that if you count the numbers who are actually active and are fully qualified. We have about 5.7 nurses and 4.8 doctors per 10,000 population, which is much, much lower. So we do need to bridge the gap. We can't train doctors in a hurry. Therefore, we definitely need to train technology-enabled frontline health workers in larger numbers at district hospitals and sub-district hospitals as the training centers, and move them as close to the block as possible. That will also improve our economy by way of creating many more jobs, because job creation is also an important function for stimulating the economy. So both for health system needs and broader developmental needs, investing in a large health workforce in the manner you have suggested is absolutely important. We must move in that direction.
Just to, no, I can't obviously follow up from Dr. Reddy, but, maybe just one or two more things that I think maybe looking into the future we could think of doing is, how are we also adequately, number one, using the capacity, existing capacity in the private sector, even if it's for, effectively task shifting, so that, it's not entirely on the public health system. That's number one. And number two, there is going to be, and yes, there's a lot of infrastructure development and scaling up that we do need to do, but there's a lot of scope for technology to actually come in to take some of the load off, to reach hard to get to hard to reach areas, to support healthcare workers to improve decision making, make decision making more efficient also, and even be predictive in the way we do our policy making, we allocate our resources. So I think there is a big part of both of these things as well here.
Thank you, Dr. Behra. So thank you, everyone. Thank you so much. They will be available here and hopefully happy to answer your questions during a coffee or a tea break soon after. Thank you so much for joining us, and to the diverse panel over here. And I hope you found the insights actionable and things that you can take back to your organizations. And just to quote somebody very wisely said, and this quote has been attributed to too many people, so I do not know whom to attribute it to, but the best way to predict the future is to create it. So I hope that we are able to create a healthier future for India. Thank you so much.
Thank you, dear panelists. What a pleasure it was to hear you speak. We now take a quick 10 minutes break. Grab your cups of teas and coffees, dear audience. We have an exciting day ahead for you all. everyone. Hello, everyone. Hello, everyone. Welcome again. We are at the Health of India Summit, and I'm Shruti Manjula Mohan. Moving on for the next session, we have with us Dr. Sameer Kaul, Senior Consultant, Surgical Oncology and Robotic Surgery at the Apollo Hospitals. Dr. Rajnikant Srivastava, Director, RMRC, Head Policy and Communications at the Indian Council of Medical Research. Mr. Madhur Gopal, AVP Marketing and Digital Initiatives at Manipal Health Enterprises. Ms. Komal Narang, Counselor and Mind-Body Therapist, Anna Chandy and Associates. This session is moderated by Mayank Agarwal, science journalist and member, the Reporters Collective. Over to you, Mayank.
A very warm good afternoon, ladies and gentlemen. Thank you so much for joining us today. I'm very excited to host this panel. And thank you to all the esteemed panelists for joining us today. I'll just take a minute to set the context, and then I'll give the floor to the esteemed panelists, because compared to them, I have very basic knowledge about the subject. But I just want to start that health misinformation and Indian system goes back time immemorial. And I'll just give you an example. We do not have data for the country like India, but if you look at a country like US, every day during COVID, there was a loss of around 50 to 300 million US dollars because of health misinformation. We had loss of thousands of lives because of health misinformation. We know that this happened in India as well, but we just don't have the numbers. So just to start the session, I'll ask Dr. Sameer Kaul to set the context, to start the session, and tell us what exactly health misinformation for us is, and how it has emerged as a public health crisis for a country like India.
Am I audible? I think I am. At the beginning, I know I'm taking valuable time, but I think I must thank data leads, health leads for conducting important that I'm cursing. And believe me, when this topic to be part of this discussion came to me, I didn't know a lot about it. And I delved into it. And when I did, I realized what an idiot I'd been. Because the all-pervasiveness of misinformation, it's not that there was no misinformation at all. Misinformation possibly has been there, or disinformation has been there right from the time mankind probably started. But the fact that online means of communication, the digital methods came in, and then social media got added to it, the whole problem compounded. And it compounded manifold to the extent that it is all pervasive. Now, being very specific to the medical thing, what's possibly come into everyone's mind here is that, yes, because COVID is just about trying to recruit, it's not completely gone out as yet. So we rudely got exposed to this part, this misinformation, disinformation, conspiracy theories, and whatever else, the other components that we'll discuss as we go on, as a part of the COVID thing, what we experienced. And possibly at the top of the chart in terms of pervasiveness of misinformation, cancer would be a leader. So would mental health, which I'm sure there are people going to talk about it. But cancer, misinformation is rife. And I can't quote you any figures because, like I said, a lot needs to be done in terms of research and epidemiology and data collection, efficient data collection. Even in the West, that's why I'm happy to be part of this today, because maybe this has begun for us. We are going to get our figures this part of the world, because we are multitudes here, but we have to have our own figures. So Whatever I will quote to you today as a part of my discussion will stem from the HPV vaccine experience, for instance, regarding cervical cancer in North America, or breast cancer figures done by a technology platform called Pinterest, because it was so huge. Its subscriptions are women, 70% all over the world, largest. But the industry contributed by doing research, getting actual data on the basis of, on every aspect. Who are the right, which is the right time for this misinformation to occur? Who are the most vulnerable misinformation to strike and create a problem? What are the kinds of impact of this misinformation on the lives and health of communities and people? All aspects. Which part of health is being miscommunicated? Is it the preventive aspect? Is it the treatment aspect? And some of the bad misinformation is all pervasive in all, it works simultaneously in all spheres. Short term, of course. So I'll talk only from conjecture. I'll only talk of what I observed in my environment as I got trained in this field and I started working. I don't have figures. Indian figures or Asian figures for that matter are going to be something that we must contribute to and look forward to. Possibly what we are doing it's present in all the most of the United States pertaining to breast cancer. Why? To begin with, because breast cancer was their most common cancer. It killed the maximum women in that part of the world. So maximum funding. Either money or power or some such thing, or political control or influence. And you saw that happening in COVID across communities across the world. So then people have tried to classify misinformation. When we talk about particularly online misinformation term, are we talking about being imposter, doing imposter posting? Are we not putting factual things there? Are we exaggerating facts? So there are many issues, and how the final thing that our talk should devolve around is how to tackle them. But how to tackle this at every level is going to only come from when you first identify where all the fault lines are. So, I think you should start thinking in terms of, and it has become so complex because of because of the mushrooming of the numbers of these platforms, very difficult to monitor. Because there are now chat groups of all kinds. A lot of misinformation comes on these only. And most of the misinformation actually evolves it is from individual experiences. People talking about miracle cures that they went through. Misinformation. So while we're talking, we've got to keep in mind that most of this misinformation is actually not misinformation, it's disinformation. Because this part of the world, it's done with intent. And I wouldn't want to name any particular group here. For instance, giving the example of things like herbal medications, natural sources. I won't name anybody, but I'm saying that in this part of the world, we see a lot of that. We see a lot of Vedic, the religious part of it overlapping with credible science. We see, and if you're asking my personal experience, there have been far too many people who shouldn't have died. I mean, the numbers are more. I can't, who shouldn't have died had they accessed the right kind of the medical treatment at the right time. There are issues that you'll talk about, things like denial, conversations with the patient, the time given for such conversations, listening to what the people, and only when you listen will you be able to guide whoever is accessing that information where to get, and then where to get credible information from. How do people do it? How are you going to tell them? What is credible information? Is it a body, a government body like for instance, cancer, the American Society of Clinical Oncology, the National Cancer Institutes? We don't have figures, so we currently follow these guidelines. So they, over a period of time, have got their own information services, which give out information. So I think, as a clinician, I must admit, a part of my interaction has to be now devoted to this. And if I don't do it, I'm not doing my job well.
Thank you, Dr. Kaul, for setting the context. We may not have the data, but we have health practitioners from across the country. We have online. But just to understand, Ms. Narang, if you can just tell us that when we talk about risk-taking behaviors, do you think that misinformation and disinformation is actually leading to risk-taking behaviors and impacting the treatment that the doctors or the health practitioners are basically suggesting?
Yeah, first of all, let me thank Data Leads, Health Leads, and YouTube Health for giving mental health a voice. Very much needed in today's age. Mental health the COVID has had a cascading impact, and mental health workers till today are grappling with that cascading effect. So thank you so much for giving mental health a voice at this forum. I would like to address this issue from a mental health lens. We know what is misinformation, we know what is disinformation, the intent being, the main divisive factor there. And before talking about the risk-taking factors, I would like to talk about stigma, because I think it is the stigma that acts as a backdrop by which misinformation and disinformation thrives. And let's talk about the various types of stigma regarding mental health. At a personal level, there is stigma, false beliefs and attitudes about self. I'm not okay, something is wrong with me, and I can never get better, for example. Stigma at a public level, public stigma. We are a collective society, and our collectivistic mentality and attitude really impacts how we think of ourselves at an individual level too. So like Dr. Samir spoke about superstitions, religious beliefs, exclusion, and a lot of these cultural biases that we have also impact and stigmatize mental health. Then we also have professional stigma. There are a lot of medical professionals, for example, sexual health experts. They also face a lot of stigma. Even mental health experts who are constantly dealing with mental health issues, clients who have mental health illnesses are also stigmatized. So this is another layer of stigma that we experience, and therefore there is a lot of hesitancy among the public or among students to even pursue psychiatry, psychology as a profession because of the stigma. And you will see that there is a huge gap in the demand supply between mental health professionals and the demand for mental health professionals as a result of professional stigma. We also see stigma at an institutional level. When it comes to public health policies, organizational policies, we need more inclusivity when it comes to mental health to acknowledge and recognize the importance of mental health at the organizational level and at an institutional level. And I think these stigma helps thrive misinformation and disinformation. So I think it is so important to debunk at this level itself. And this can be done through various platforms, using social media. We were just having a discussion how, at organizational levels, at professional levels, having a conversation. Dr. Samir was saying everything begins with a conversation. Making this a coffee table conversation, or talking about it in the living room, it's so important. Now, coming to your question that you asked me about risk-taking behaviors, all this leads to a lot of myths. For example, what comes to my mind, I can give you an example right now. Vaping and e-cigarettes are harmless. It's one of the biggest myths, and this leads to so much of risk-taking behavior. Suicide. There is media which the way suicide is being reported sometimes is very insensitive. There is information on how to commit suicide on the internet. Obviously, this leads to a lot of risk-taking behavior, eating disorders, which are projected as lifestyle diseases and not looking at the mental health aspect behind it or the underlying factors behind it, lead to risk-taking behavior. Addiction. Addiction is another huge myth. People are talking about addiction as, self-control, or, you need to be strong and you'll get over it. And this leads to people not taking or seeking professional help or medical help. And, a lot of addictions, therefore, can lead to death and significant social and even professional negative consequences.
Thank you, Ms. Narang. We know that the health misinformation is there. We know that it is a crisis. We know that this is impacting medical treatment. Dr. Srivastav, I want to come to you to understand, when we know all this, as an administrator, what is your take on who is fueling this misinformation? And as an administrator or a body that is dabbling in this, what exactly can be done to tackle this menace?
Thank you. Is it working? Okay. Thank you so much for this panel discussion on misinformation and disinformation, how we can tackle it. Since I come from the Indian Council of Medical Research, ICMR, and right now, next to right is sitting Dr. Samir Kaul, is a renowned oncologist, and she also spoke on the mental health. I will speak upon because during the COVID-19, there was a lot of misinformation was there, even disinformation was there. And being the head of the policy and communication, we were also dealing with the media. How to tackle with the misinformation. So misinformation, it has happened since ages. It was there, but if you look into past 5 to 10 years, now it is spreading like a wildfire. Why? Today in India, we have around 658 million internet users, more than 500 million WhatsApp users. In 2015, there were only 19% of the people, those who were using only WhatsApp. Today, we have that number around 58%. That has increased one way it is useful also, because any information can reach to the million of the people in a fraction of a second. On the other hand, it has some problem. If this is misinformation, disinformation, it also reaches to millions of the people. And that is causing problem in the decision making. Because if there is a misinformation, the target audience is not aware whether it is correct or right, and it started behaving like. Similarly, if it is fabricated, again, it is causing a problem. It also caused problem for the policymakers also to making a proper policy. So during the COVID-19, because that was a separate problem, we were dealing with the COVID situation, and huge amount of misinformation was floating around the world. For example, number one, virus originating from the Chinese lab. There was no evidence whether it is coming from the Chinese lab or not. Misinformation was there, it was spreading like wildfire. Second, COVID-19 is happening because of 5G towers. This was again a misinformation. Extended lockdown, panic buying, because market will remain closed, you will not get the household items. So huge buying was happening. Even the medicine shop, the tablets, medicines, even the paracetamol was not available at certain situation of a time because there was such much of hue and cry, and the people they were storing medicines in case something happens. What we will do? We will die. So such kind of a misinformation, they was causing lot of problems for the policy makers and as well as for the target audience. Second, for example, ICMR was on the forefront in dealing with the COVID-19 pandemic. Many of the people, they were using certain information, 21 point, and with the logo of ICMR. Don't travel for foreign country for 2 years. Don't do this, don't do this, don't do this, falana and falana, with the logo of ICMR. Many journalists, they were asking whether ICMR issued certain kind of information. I said no. So that was the biggest problem so far as the misinformation is concerned. Now how we can tackle it? Tackle it, number one, if you are receiving anything, you have to find out the credible source. Whether this is coming from your friend or someone else. For example, if we are working in a health sector, you should find out a credible source whether this information is coming from WHO, from the ICMR, from the Ministry of Health and Family Welfare, from the Niti Aayog. So that is number one, you have to find out the credible source from where it is coming. Number two, when you are forwarding any information, you should be sure and ensure whether this is the correct information or not. False information should not be forwarded to anyone. Number three, what we were doing in the ICMR, because we created a COVID-19 communication group, and we were dealing with all sorts of communication, we were dealing conversation with the media. Regularly, we were using the press release, indicating what we have done, what are the research that has happened. Number three, social media, WhatsApp messages we were doing, press releases, opinion editorials. Then there was a problem of vaccine, whether vaccine is coming, vaccine has come now. Then people were scared. Vaccine takes 8 to 10 years for the development. How a vaccine can be developed in a 10 months? So again, there was a confusion whether we should take this vaccine or not. So huge amount of vaccine hesitancy was there. What we did, we used some celebrity star for vaccine advocacy. For example, we utilize the service of Harbhajan Singh for the second dose. Dusra liya kya? So you have taken the first dose, it is also mandatory to take the second dose also. So I think this is very important to deal with the misinformation and how you can tackle it. I think the scientists, they also need to understand the art and science of communicating science, because in ICMR we have started a health communication course so that we can train our scientists how to communicate complicated science into simple formats so that the journalists, they can understand, number one. Number two, at the same time, journalists, they also need to understand the complexity of the science. So what we are doing, we are taking some group of journalists to our labs so that they can understand what research is doing and how it should be communicated. So I think in a globalized world, in the interconnected world, when internet has become very, very mandatory, and the social media, we are not going to get rid of from the social media, but we have to be vigilant and we have to be alert whenever we are forwarding any information, whether we are using any information, whether we are consuming any information. And Madam was telling about the mental health and stigma and COVID-19 stigma. We also did a study on the COVID-19 and stigma. So these kind of issues, mental is a big problem right now because of misinformation also. Other reasons are also there, but so much of digital exposure, social media and everything. So stress is there, strains are there, fatigue is there, that is causing mental health. Dr. Samir also told about the cancer-related information, how misinformation is creating a problem for the patient also. So I think this is the right time we should discuss and we have to find out the solution.
Thank you, Dr. Srivastava. I'll come back to you on this, what exactly the government can do or health administrators can do. But Mr. Gopal, I want to come to you now. We have a diagnosis and you belong to the healthcare industry. How exactly can the healthcare industry respond to this? Or is healthcare industry already responding to this?
Yeah. So, first of all, I'm happy to see that we are discussing about this misinformation which has been there for some time. And I do handle social media also for Manipal. So we were talking about social media, how it is kind of, spreading misinformation. So I'll, touch base few things, what as a group we have done and what we feel can be done. So there are, we all realize that, misinformation is a big issue. And in fact, from a tertiary care or a quaternary care brand point of view, no information itself is a big cause, because when people really come for something, they don't know about that disease or about that procedure, And that's why they kind of fall prey to, the whatever information is available to them. So before I get into that, a quick number which actually was released some time back during COVID time, and it was on misinformation. And when they, studied various countries, they found that India was one of the most affected country with a 16% on COVID misinformation. And also from the source of generation about this misinformation content was also created from India, maybe because of the population, but also because of the social media penetration kind of what we have today. Now, if we really see and, answering Mayank to his question, what can we do as a healthcare, player for sure, but largely, who are the other stakeholders who can contribute to really handle this situation? So I would say, and I'll try to frame my answer in 2-3 parts. One is stakeholder-wise, one is immediate, midterm, and long-term kind of, what all we can do. So from a healthcare point of view, I think what we need to see is in this changing consumer, changing behavior world, do we need to have certain department who are working on this, right? Now, traditionally or conventionally, we don't have a department per se who is creating this content to educate people. We do have marketing department, we do kind of, educate people, but that's largely on the procedure or with the intent that can this patient consume our services. But are we creating a genuine content just to educate customer and let him decide where he want to go? I think that's something which we need to start immediately. Something on these lines we did during COVID time, and I'm sure many other hospital chain also did, as there was a lot of confusion and misinformation which was happening during that time, at least to our own patient database. We identified what are the challenges. I mean, when we spoke about mental health and we realized in phase 2 of kind of COVID when people were stuck at their home for some time, that's when the mental health started kind of becoming more important issue, and we picked up that issue and we started engaging with our, customer base. So not getting into the detail what all we did, but there was a programmed communication and a very well-planned communication for each phase, because we knew what customer is looking to know or what are the confusions which are lying over there. Now, to extend this, now it should not kind of, die down over there. To extend this, we all know when the influenza season is coming or when dengue season is coming, and or even other specialities and procedures, we should continue this kind of communication which are more educational in nature and which is something where patients are confused. Now, can a hospital on its own can do it? Answer is no. There is a collaboration which is required because the believability, the trust factor of any communication when it comes from a third party is very, very, essential. So going to which third parties can contribute to this, I think the second part to this, right, is the social media platform itself. And if you remember the number which I was sharing in the first part, the source of misinformation, if you see social media contribute to around 85% of all misinformation kind of sharing. So that's why this number is multiplying in last few years. So how do we kind of, it's very important for social media platform themselves to have certain regulations, certain, control mechanism, so that people know, like, just now, he was mentioning that how does customer know that whether the source of information is genuine or not? Now that's where social media platform can, YouTube Health is already doing it and working with many healthcare players, that it's a verified content. So something similar, I think, like Facebook contribute to around 65% of all communication which move from one part to another. That's also the number coming from a study. So can they have that this is a genuine, or the verified content? That is something which we should have so that customer knows what I am reading is verified by someone or not verified, right? Moving on to the second part, I think this is what we do. What we do is we identify the TG and the medium, what they are using. For example, if you see an old person, for him consuming a video on a WhatsApp, which is a forward, is something which is, you will find more widespread versus a communication on Instagram or any other channel. But what happens is that when institutions create communication, they create one communication for all channels. So the engagement, I think, changes from one channel to another, and we need to create, TG specific or the target group specific messaging, and the channel specific, or I would say from where they are consuming, because the format changes completely, right? Other thing I was just, discussing before coming on the stage is that collaboration with third-party platforms like, Practo or the aggregators or all the, the blog content writers themselves. Happiest Health is one of the initiative which was just started. So we talk to them, and we are still talking to them to create a content which is educational in nature. For example, someone is advised for a surgery. Now, where do they go, right? Is there a way to select which hospital I can go to? I think these are the platforms they should write that, boss, this is the guideline. This is how you can choose the right doctor or the right hospital. Now you decide. And we will be very happy to help them out. It's not content which we want to really, bring the patient to our hospital, but to help them take the right decision where they should go, right? And I think I'll not be taking more time, but this is a lengthy subject. We can keep on talking on this. I would say that government has to play an important role. And I was sharing, I don't know if you have seen, Viber is used in most of the Southeast Asian countries in place of WhatsApp. And WHO Health has created a very interactive, bot kind of thing, which has a two-way communication. It's a very friendly UI. I think something on these lines, they started in COVID, which was very helpful, but actually they have moved on. So basis on, say, if influenza is coming, they start messaging on that, bot. And if people have two-way questions, they can actually go ahead and ask the question. It's still a premature, but I'm sure that this initiative can grow to something. It's a verified content. It's coming from a genuine source, and it is helping people to take, the right, to consume the right information. And maybe pretty long-term, maybe the long-term short is, we all know, this technology is changing, the way we are consuming health today. So I give this example many times, but when my parents, they used to talk about, the financials that we have saved this money for house and then we can buy this car and all that. Today's generation, if you go, a general talk is, I have burned these many calories, I have walked these many steps and all that. So there is a change in the way we kind of, perceive healthcare, or the way we kind of, use these devices for our health. I think some amount of, intervention from these companies, because where OS and Apple, these probably the two largest platform will be there for wearable devices. In fact, they should, be able to communicate at the right time that this is what you should be doing and all that, and some kind of collaboration can be worked out. Very premature at this point of time, long term, that can be something which can be thought of.
Thank you, Mr. Gopal. Thank you so much. Before I ask audience for questions, I have a few of them myself. Dr. Kaul, I want to come to you. We talked about how cancer is becoming an epidemic of sorts. In the way we consume information, in the way internet has revolutionized the way patients want to understand their treatment, how do you face that barrage of questions, and how do you ensure that that misinformation at that particular moment is not spreading, or how do you control that as a practitioner?
If I understand your question correctly, I mean, we've already understood that online misinformation is a problem, and it is so, like I said, if I, as a healthcare provider, because I think if improvements have to, all the solutions that we talked about, there are so many stakeholders to this whole issue. I'm just a cog in the wheel. I'm a healthcare provider. But the technology platforms, the health educators, the digital health media, the healthcare companies which provide, the government which formulates policies and monitors, hopefully, whatever's happening in this area. There are so many stakeholders. Unless there is a collaboration across these stakeholders, it's not possible to effect a change, number one. Number two, and change needs to be implemented at every level. Now, your question to me at my level, what can I do and what should I be doing to obviate some bit of this problem that I face? There's absolutely no doubt today that the moment you give the diagnosis of, now I'm talking about active treatment, the misinformation starts even before. It's about prevention, what prevents the disease. And there is so much, the internet and digital media is rife with preventive strategies for cancer. But I'm talking about at my own level, if I give adequate time to my patient and I have a conversation regarding what already exists in the patient, and it's just not the patient, it is the patient and the attendants. Everyone has a quorum which makes that important decision as to what kind of healthcare and when to access it. All of them, their beliefs that already exist in their mind, including what we technically call as cognitive biases, they already exist. And we already have enough information from the United States and other, Scandinavian countries, which have clearly shown that an average individual is more likely to accept and assimilate misinformation than proper and factual information. Because then again, see that every level, messaging, what kind of messaging delves deep in, which sort of pervades your barriers. Emotional messaging, the colors that are used, the tone of the voice, of the videos. There are so many aspects of it which become all pervading and help a message to sear through, and with the cognitive biases that we already are. So if I center my conversation and my interaction with the patient that I'm treating and have a conversation regarding, if you want more, first listen, not being judgmental as to what already exists in their mind. Then slowly guide it. And this takes time. And then guide them to the right resources if they do want to, because they do access it. The moment you get a diagnosis of cancer, you are shocked and overwhelmed, and you go through that phase of denial that we were discussing on the table there, where you don't want to believe that this is a diagnosis that you have, this is what you are suffering from, and would not like to believe it. And that it takes its own time, and there is anger, there is all sorts of things. Then there comes a time when acceptance starts coming in, and desperation takes over. So there are various phases, and if you feed this information that you are giving, factual information, correctly and don't give it so much that it doesn't get assimilated in just one go, which we generally try to do because we are fighting against time. If we do this interaction a couple of times and take our time getting the message across and talk about what resources, digital, online resources are credible, are available, and what can be assessed, and then have time for debunking the conspiratorial beliefs or the myths that are already in the mind. If we take time, so it's about time. It's about having that conversation. And from time to time, people get desperate with this disease. When cures don't come, when the kind of results that people want, their grief, their desperation gets channeled along different lines. They can get easily misled. They get misled from one person to the other, one hospital to the other, one kind of treatment to the other. So, and talking about complementary, most of the stuff that interferes with allopathic treatment for cancer is basically what we call as complement, the additional treatments, the alternative treatments, the complementary treatments that are taken. There is a time and a place for them, I'm sure, but certainly not what would delay something that has an enormous amount of evidence, scientific evidence supporting it. So it happens a lot out there. So having the time and keeping this in your mind, having the mind space that this aspect needs to be touched as much as the diet that needs to be consumed during cancer treatment, as much as the do's and don'ts that we give to our patients. But if I incorporate the where to access credible information regarding that illness that patient has and debunk various conspiracies and myths as I go along from time to time. It's not a one-day, one-off deal. It takes time. But if I have it and I believe in it, that is one. The other aspect that I can do at my level is to be a credible, scientific, evidence-based communicator myself. I can communicate to my patient communities things about cancer on a larger scale, digital. Whether I do it as a part of online chat groups of similar-minded individuals, or I do it individually on my own, it may be a drop, but if all of us do these little drops, we'll make an ocean, I can tell you that.
Thank you, Dr. Kaul. Thank you so much. Let's change the lens. We have discussed about too much information, infodemic. As a patient, as somebody who wants to understand what is happening to me, how can I sift through all that information and go for the science-based information and avoid misinformation as a common man, as a common person? Mr. Gopal, Mr. Srivastav, anyone?
He's talking about the patient.
If I understood that how patient can navigate is the broad question. I think some of these things will be repetitive in nature, but today, and it was discussed in the previous panel, one is how do I, decipher whether the information is right or not. So that will help, to large extent. Second is all the social media channels getting it verified, the content. And for the consumer itself, I think these larger bodies have to come to see that, the patient is navigated properly. So just to give you the example, like Happiest Health, they have just started, but the whole idea is to create a lot of content which is a genuine content and which is targeted to these patients. Now, if you see, and I'll repeat, what Dr. Samir was saying, and I'll just give one or two examples. If you see this misinformation is happening in what kind of, group, and I'm talking largely from our hospital point of view, when patients come for something, to the hospital for something, which they were not expecting, and they get to know about that diagnosis, for example, cancer, a patient is in denial mode. They just don't want to accept, I can have this particular thing. And that's when they are the most viable to kind of fall prey to any other information. But as institute, do we have that body who can navigate them? Yes, to some extent we have done. For cancer, there are patient navigators who can who help them. They are survivors themselves. They talk to them and kind of, till they move into acceptance stage, they kind of handhold them, right? But for other diseases, if you see, when someone is going for a ESRD patient and, at some point of time, they are advised to go for organ transplant. I mean, big decision. They don't know what to do, whether it is right, not right, what is the process around this. And that's what I was saying in my first part, that many of the times there is no information. And then you have these large groups who will come and tell that if you take this, your creatinine will become normal. You don't have to go kidney transplant. You come back to. And I'm giving this one example, but it happens in majority of the cases. So that's where the touch points, what we are having, these touch points need to become more educative. Because if we go in masses, it's very difficult because then it's a very, very long journey. I think if we identify these touch points, that's what can actually help patient. The patient has already come. He's contacted doctor. That point of time, it's the easiest to kind of, demystify their, queries. Other area, I mean, given the marketing background, what I have, we do a lot of these camps and all that. And we were talking to Google Health. They have come for the DR kind of AI algorithm based, which can be used in camps and all that. That is another area probably when it comes to education, we can use that another touch point to kind of educate patient. So to me, I think immediate answer is really on these touch point where patients are there. As healthcare institutions and as I was mentioning earlier, other social media platforms and all that, there is a possibility we can educate them better. We do, there are possible ways of target marketing. So there are the databases which we know that they are prone to certain kind of disease. That's where we can kind of, do the target marketing. As far as the mass communication is there, then, many bodies have to come together and help patient to kind of, to get to know the right information. So content is the key. If in single line I have to say, content is the key, building right content and delivering to the patient is the way we can actually go ahead and navigate patients.
Thank you, Mr. Gopal. I have a few more questions, but I've been told my time is up. But before we end the session, I'll open the panel for questions from the audience. Do we have any? Okay. Can we just quickly take the questions and we'll ask the panel to give a response, and we'll note the questions and then we'll open the questions to you. Can we get the mic to the gentleman? Yeah.
Good afternoon. I'm Dr. Rajiv Kumar Jain, and I'm Vice President of Association of Environmental and Occupational Health. Due to the pandemic, I think useful focus has been laid on infodemic and how the science and art of infodemic management is to evolve. Now, WHO definitely played a crucial role in evolving the science and art of infodemic management during the pandemic. Now, we in India need to focus now in using infodemic management tools, the science and art part of it, through a partnership where civil society, the government at the state, center, and the local bodies, and the private sector together agree that there should be a portal and social media handle to give credible, verifiable information on an ongoing basis. And in that process, all the channels of social media, YouTube, health included, Meta included, they have to understand that they have to handhold because they have a crucial role to play. So what is the roadmap? I would address Dr. Rajnikant Srivastava on that. ICMR, would it take up the role of a nodal agency to develop on behalf of Government of India as a science and art of infodemic management?
Thank you so much.
Dr. Srivastava will come to it. We'll take another question first. We'll take all the questions.
And because will be much better. I will get confused. Let me answer his question. So thank you so much for raising this question. And we all know that infodemic was more problematic than the real pandemic. And WHO gave that this new term infodemic in March 2020. And India was doing excellent in managing the infodemic. From the ICMR point of view and from the ministry point of view, we were regularly having the media briefing. And in the media briefing, Dr. Vinod Pal was sitting there, Dr. Ram Bhargav was there, sometimes Dr. Ganga Khetkar was there, Lav Agrawal was there. So that was the reason that the correct information, evidence-based information should go to the journalists and to the masses, number one. From the ICMR, because we were at the forefront, we created a separate web page only for the COVID-19 related information. What was happening, because that was an evolving situation. We were not knowing what is the correct, what is not. For the scientists, it was a new disease, new virus. So initially hydroxychloroquine was working, later on we found it was not working. Plasma is working, plasma is not working. Remdesivir, again not working. So it was an evolving situation, and as per the research was being done, based on the evidence, we were providing information on the website to the journalists, to the masses. We created a separate WhatsApp group also sharing all this information. Opus we were writing. So infodemic we was managing very beautifully. So that was not a problem, and India was doing excellent in so far as misinformation is concerned and infodemic is concerned. But even then there was a misinformation. I think there is a need, as we were talking about, developing a collaboration, partnership, and some rules and regulation, and because we have a Disaster Management Act also. So I think some stringent policies needs to be made so that we can demystify and we can debunk the misinformation and disinformation. Thank you.
We'll just take one more question.
Good afternoon. So, good afternoon. I'm Mihika Baklu, and first of all, thank you to all the speakers. It is really enlightening. So, my question is regarding stigma. So, we work with people with TB directly with the community, and we have ample of examples where people with TB or TB survivors have faced stigma, but they were unaware that they have been stigmatized. Stigmatized at different levels, self-stigma, family members, community members, at different levels, and even from the healthcare providers. So my question is directed towards Ms. Komal Narang. What are the possible solutions or suggestions or strategies where we can, disseminate information correctly to the rural community or the community who is affected more efficiently and debunk or bust myth regarding stigma? So at different levels. So it's just a TB example. There are numerous diseases which has to be tackled at different level. And my second part to this question would be directed towards Dr. Srivastava, where like you have stated that you have already done COVID and stigma research. So if you could quote some examples, what were the strategies at COVID level, as in? So yeah, thank you so much.
So thank you for asking that question. Very, very pertinent question. So there is a need today for, like I said, because of professional stigma, there is a lot of hesitancy for people to take up this as a profession. And I think India, because of low literacy rates, there is a dire need for lay counselors to work at the grassroots level, right? And in fact, at Anna Chandy and Associates, we've also started a program for lay counselors where we have a 6-month training program. And we've started it in a small town called Rajapalyam in Tamil Nadu, where we train lay counselors and they address all kinds of stigmas at various levels and in the regional language. So I think this can be really addressed through extensive training programs at the regional level, rather than, using social media, etc. Because those channels, like one of the speakers said, WhatsApp is the most common medium. Other social medias are not really used at the village level or in the tier 3, tier 4 cities. So I think lay counseling is the answer.
Thank you, Ms. Narang. Dr. Srivastava, you want to take the second part?
Thank you again for the COVID-19 and stigma. So we all know it was really a big problem. In older days, we all know that the leprosy was a big stigma, and Mahatma Gandhi fought for dealing with the stigma related to the leprosy. So when COVID-19 came, it was really a fear, and even the government, they were not aware what to do, what not to do, and there was a huge sign and boards, and the whole of the society, they were being locked. No one can enter, no one can come out. And if there was a COVID positive patient, there was a label pasted on the front of the door. This is the COVID positive patient. So huge problem was there. Then there was a problem related with the mental tension, shock, fear. And as Dr. Samir will agree that many of the people die because of the fear, not because of the disease. It happens because so much of a fear was there, but time is a big healer. Gradually, there was more awareness, more knowledge was there, more information was there, and stigma also diluted to some extent. And we have done a study, Pan India study, and I can share the paper. It has already been published, so you can get more information on the COVID-19 stigma.
Thank you, Dr. Srivastav. I'm so sorry I can't take more questions, but I think the panel will be very happy to share their experience and their information. And I thank you to all the panelists for pouring their heart out. Thank you so much. You have been a lovely audience. Thank you so much. Have a great day.
Thank you, dear panelists, for this very insightful session. We would now request you for a group picture under the rise. I've always personally wondered, what do people search online about health? Well, at the Health of India Summit here, we have a data trainer who will help us decode this. I now invite Anuja Venkatachalam to walk us through these trends.
Can we have the slides, please? Okay, good afternoon, everyone. I have this massive challenge of going right before lunch, but I'll keep it very brief. My name is Anuja, and I work as a data journalist. And today I'm here to give a flash talk about a pilot project that I worked on with Google. So I would like to thank the organizers and also for going right after the session on health misinformation, which has pretty much set the context for me. But let's quickly recap on what the challenge is, right? So the biggest challenge is the proliferation of misinformation online. We know that there are about 650 million internet users around the world, and this is not just an urban problem. Around 2 in 3 Google searches actually come from outside metro cities in India. In fact, local language searches have increased by over 10x. And so the challenge really is, how do we control misinformation online, right? So if we take a step back, I think one of the common themes that came up was the number of stakeholders that are involved in this, and how do we really collaborate and essentially make this a well-functioning, well-oiled machine. So the pilot project that we worked on kind of attempted to do this collaboration, but at a very, very small scale. And we did this during COVID-19, and it's something that we would like to scale going forward. All right, so as you can see in 2020, a lot of the online searches on Google were dominated by health. I just checked the stats for this year. It's gone down slightly, and searches for films and sports have positively increased. But that's, nonetheless, to take away from the fact that people do look up health information online. Can I get a quick show of hands to see how many of you have actually searched the internet for anything related to your personal health? And I don't mean specific websites or verified websites, but just doing a Google search. I certainly have. And it seems like almost 70% of this room has, right? So I think we can agree that searching for information online itself is not bad, but to really kind of take a step back and think about what differentiates a person who searches for health information online from someone who searches for health information online and then actually acts on information that is made available to him, right? So the COVID-19 infodemic was kind of the context for this pilot project. As I mentioned, the right end of the spectrum would be deaths from misinformation, which we have seen in India as well as across the world. All right, so how can we use online searches? I think the biggest gap here is We know that people look up health information online, but how do we know what they're searching for? And how can we verify that and further disseminate it back into the audience, right? So online searches can signal misinformation vectors, and specifically they can highlight areas where there is a lack of information, and I'll go into that in a little more detail. And also, interestingly, you'll see through this project that online searches can also provide some insights on how people perceive certain diseases or what the misconceptions and attitudes are towards certain diseases. All right, so what did we end up doing? This was in April 2020, right at the onset of the COVID-19 pandemic. Google had pledged about $6.5 million to work with news organizations. The specific Google platform that we used is called Question Hub. I'm not sure how many of you are aware of it, but essentially it's a platform that is available on a beta version online. The idea was to provide content creators across the world access to topics where there is a lack of information online. So I'm sure all of you have used Google search. You search for something, and then Google collects data on the search volume for a specific topic. If the volume is low, then those questions / searches get recorded in a database, which we were able to access. This initiative was called Fact and Fit, and it was a collaboration between Data Leads, Boom, and was also supported by Google News Initiative. So essentially what we did was we took this Google platform, we looked up questions related to health. So fortunately, the questions are tagged by topic. So say I want to know, what people have been searching for related to COVID-19 and where there is no information around it. Those questions will kind of pop up on this software. And as a data journalist, a team of journalists actually extracted those questions from the platform and then prioritized it for fact checkers. And then we had a network of doctors as well as frontline workers who helped us fact check those questions, and then we inputted it back into the platform for it to be accessible to users. All right, so this is kind of the three-step process. You have users who have Googled something where they haven't found the information. That gets logged onto Question Hub. We at Data Leads extracted those questions. Of course, the volume of questions is a huge challenge for journalists because how do you decide what is critical or what needs to be fact-checked? On average, on a daily basis, we were looking at over 1,000 questions. So how exactly do you prioritize those questions and send it to medical experts? That was one of the challenges which we tackled with a little bit of machine learning, where we essentially built a classifier that would automatically tag questions to different topics. For example, questions related to medications were provided higher priority for fact-checking than questions that were related to just information about rules and regulations around the lockdown, for example. So just a quick summary of the numbers. We covered 9 health topics, including cancer, chemotherapy. We had diabetes, asthma, of course, COVID-19, cardiology, etc. We covered over 9,502 questions with the support of 13 medical experts. We ended up publishing around 96 fact-check stories. We also generated newsletters for medical experts, flagging, for example, during that week, what were some of the misinformation vectors that we saw. So, okay, I think the slides are a bit, all right. So if you could just look at the boxes, you'll get a sense of the kind of questions that people had asked. So this is related to COVID-19. So you can see a lot of questions around medications. The scary part is people just searching for very specific medicines that could potentially be available over the counter. Disinfectants, sanitizers, as well as alternative cures were some of the questions that we received from users. We also looked at other diseases, although COVID did take a large chunk of our time, as those were kind of the vectors that needed to be fact-checked immediately. So here are some common misconceptions / questions that people had around cancer, chemotherapy, as well as hypertension. I'll just pause for a few seconds so you can take a look. And finally, we also looked at managing mental health. Although mental health was not initially on the agenda, we did end up including it just because of the spike in the number of questions that we received during the lockdown. And here you'll see that it signals to certain perception problems that might be of interest to researchers as well as medical professionals. So this is just to show you the raw data in a sense of the questions that we receive from users. But imagine that on a day we were looking at 1,000 plus of these questions. And then we had automated this to some extent where we could filter out questions that are of low priority and essentially sent out newsletters to our task force summarizing vectors that needed to be fact-checked immediately. So just to quickly kind of touch upon some thinking points, I guess. Some of this has already been discussed in the previous sessions, but having worked on this exercise, there's definitely scope for working in collaboration. So if we had done this just as a newsroom, we would never have been able to have the impact that we did, simply because we had these doctors who very, very generously gave us their time to review the questions and to fact check them and to generate verified content for us to share back with Google. I think there is also definitely a lot of scope for policymakers, especially at the front line, because a lot of policy is around information interventions, and data like this can really inform you as to what some common misconceptions are, particularly in rural areas. Secondly, data availability. I think a lot of the topics that we discussed today were around the sense that doctors get about misinformation vectors when they're dealing with patients, which is at a very, very small scale. But there are platforms out there that you can leverage to collect data at scale, and to really kind of think of using these platforms innovatively is something that is definitely to look forward to. And finally, to target health interventions to specific challenges. So I think we still think of misinformation very broadly. So we know that there is a lot of misinformation around cancer, but we don't really know what exactly those vectors of misinformation are. Are they more about symptoms? Is it more about treatment? Or is it general perceptions? And having analyzed questions for multiple diseases, we found that there is variation in the kinds of questions that were asked. So for example, lifestyle diseases, you'll see that there is a lot more questions around lifestyle changes and diet, etc., right? So I think just thinking about how to use this data better, and how you as medical professionals can engage on a project like this, because really getting that technical expertise is a challenge. But yeah, I'll just wrap with that. Thank you.
Thank you, Anuja. Now that we know a bit more about data and the key search trends, let's dive directly into understanding how to use this data. For this, I now invite Dr. Ramanan Lakshminarayanan, founder HealthCube, to address access to healthcare through data and diagnostics.
Good afternoon, everyone. I need to press the green button. Okay, there we go. So I'm going to talk about HealthCube, and HealthCube is, so I'll get right to the problem statement. So This is the Lancet Commission on diagnostics, which just came out a few months ago. And the calculation from this group that studies diagnostics is that 47% of the global population has little or no access to diagnostics. Now, why are diagnostics important? Because it informs treatment. If you don't have diagnostics, you have inappropriate treatment, you have antibiotic overuse, constituting wrong treatment. But also from a public health perspective, that's how we really get our data. It's from all of our individual records that the COVID data comes from. It's from all these individual records that we know what proportion of the population has, diabetes or cardiovascular disease or cancer. Now, in India, we have a problem that the 5 largest lab networks serve less than 4% of the population. In fact, most of the diagnostics come from very, very small operations. And across the world, about 4 billion people lack access to reliable, affordable diagnostics. So if you don't have it, it's something as simple as a case of malaria or dengue could result in death. Pregnant women with undetected gestational diabetes or preeclampsia is a greater risk for dying at the time of giving birth. And also your costs go up as you have poor follow-up and also financial expenditures both to individuals and to the health system. So when we went out and first talked to people at the periphery who were delivering babies, for instance, and this was Razia Akhtar, who was an auxiliary nurse midwife in Jammu and Kashmir, and she said, listen, getting quality diagnostics shouldn't be a task. Patients should be able to get their measurement anytime and not have to wait for days or even hours. Now, the typical standard for a woman in Jammu was really to go walk to a primary health center, which is typically about 4 to 5 hours away, then come back, and then either she goes or her husband goes the next day to get her results from an antenatal care checkup, and she'll have to do that 4 times. As a result, the completion of antenatal care in Jammu, when we first engaged there, was less than 5%. I'll tell you how we got that number from 5% to more than 80%. So how do we democratize access to health information through access to instant high-quality point-of-care diagnostics? This is very personal, right? All of us need this information. Anyone sitting in this room can call a diagnostic lab and get that information, literally in no time, because you can get someone to come to your house. But that facility is not available in most of the country. Now, the delays basically mean that there's delay also in getting treatment, because it takes about 2 to 5 days. Imagine your own journey. You go see a doctor when you have a complaint, they'll send you to a lab. You go next day to the lab, they'll send the results back, then you go back to the doctor for a treatment. Now, of course, they might give you an antibiotic, something as a short-term fix, but that's often not the right treatment, and this delays action. As a result, many of you also would not go get the diagnostic test. Now, how many of you have had a slip from the doctor saying, here is a test that you need, and how many of you have ever actually gone and got that diagnostic test the very next day? What proportion actually went and got it the next day? I'm seeing about 20% of hands up there. A lot of people who didn't go and get their diagnostic test done the next day. Why? Because it's a hassle. You don't have time. Next day you might feel a little better. It's not really worthwhile. So all of this, these were the reasons. Do I really need the test? The national rate is about 60% dropout between going to the doctor for the first time and actually getting the test. And if we're able to solve this entire problem through point-of-care testing, you can do this entire thing in 15 to 45 minutes, depending on the kind of test. And more than even in the cities, in peri-urban rural areas where lab tests are not there, this makes a lot of sense. Now, how many of you have ever heard of a sync test? Anyone heard of a... Okay. Do you want to explain what a sync test is? No, you're the only one who raised your hand to say what's a sync test.
I don't know how true it is. It's a very common misconception. Let me just start by sharing. I'm Dr. Rashmi. I was a primary care provider for 23 years before I moved into public health. And when I was in practice, a lot of my patients used to come and tell me, कि डॉक्टर साहब जो sample लेके जाते हैं, they just thrown into the sink और ऐसे ही report बना देते हैं. That is exactly just thrown into the sink. That is what sync tests are called.
That's where the sync tests come from. Thank you so much. So, this is not uncommon. If you go to people in the lab business, they know that lower quality labs, if they don't have the time or the ability to transport a sample, your lab specimen goes into the sink and then they make up the test result. It's more common than you think. So all of this has changed, and this is why we came up with a device, mostly for, it started with the objective for antenatal care, because, I come from a public health space, so the idea was, how do you get antenatal care to pregnant women in their households? So we said, okay, we can easily build a device. It actually ended up being quite difficult, which can do the 6 tests that are needed for antenatal care, which is, blood glucose, hemoglobin, HIV, syphilis, blood pressure. So all of these could actually be done very easily in a device like this. But as we move forward, we found that we could do far more tests. And in fact, today where this stands is, this is now a point-of-care device which can do more than 30 parameters between 1 to 15 minutes. This is a commercial device. It's there in many countries in the world, including in India. It works off just a mobile app. It's extremely rugged, user-friendly. You really don't need to know very much to operate this device. It's got an entire web backend where all the data goes. And it is certified. It's certified in India, it's certified in South Africa and Ghana. It's CE certified, which means it's sold in Europe as well. And it's high levels of data security and storage. All of this has been the process for the last 6 or 7 years to make all of this come together. And these 2 devices on top are the ones which are most widely sold. And like I said, it operates off of any sort of an Android device. Now, this is an ideal device which essentially replaces a lab in any sort of doctor's office, but really in any primary health center, or when we talk about health and wellness centers that are very essential for universal health coverage, we may not have the money to go put up entire brick and mortar health and wellness centers with labs everywhere. But a device like this that costs just over $1 lakh is a much easier option because it can do most of the tests that we really need. It covers all the tests that the World Health Organization says should be done in a primary health center. So that's really the criteria. And like I said, from a public health standpoint, it's very important because at any given point, today I could open up the back end and I can tell you how many people had malaria by district across the country, how many people had high BP, how many people, potentially had dengue or malaria, chikungunya. It covers so many of these tests that all of them can be read from one place. And of course, there's data traceability and security. If the health worker does not go to that patient's house and do the test, they cannot just fudge the result because that result has to be recorded at the patient's house. Today, an A&M can just write, blood pressure for a pregnant woman is 80, 120 over 80. They cannot do that with a device like this because data cannot be inputted in. It has to be measured. So it makes it quite difficult. So it's all integrated, real-time, easy to carry. Many people just carry it in their purse, and it's high, lots of people now use it. These are all the tests that are done on a device like this. It covers a lot of general health tests, starting from a digital stethoscope, BP, pulse ox, and so forth, maternal tests, inflammation markers, cardiac health. You can do a troponin D-dimer all on this. It has a full 12-lead ECG, on this. Renal health, diabetes care, and HbA1c is an add-on device that goes with us, urine parameters, and then a whole bunch of infectious disease parameters, including 5-part differential. Does not do a CBC, but can do a 5-part differential, which is what you need anyway for infectious disease markers. You don't need everything else. So it's compared against many other international comparisons against many other sort of devices, has fared very well on all these scores, technical performance, commercial, pricing, and so forth. And over 1 million patients served, 2.6 million diagnostics completed, and this is a fully make in India product. So it was designed in India, it's manufactured in Bangalore, and it's used widely. I would say it's nearly in probably about 28 states across the country. State governments use it as well when they stock PHCs with this. And so, I think, I'm an academic. This is not what I normally do for my general job is to teach students. But this was my attempt at trying to figure out how to use technology to be able to solve a fundamental problem, which is lack of access to diagnostics, which I think is a major barrier to our being able to provide primary care in this country. Not just in this country, I think from around the world. I think, yeah, if there are any questions, just go to healthcube.com, the website, and you know, I'm sure someone will get back to you very soon. Thank you very much.
Thank you so much, sir. We will now break for lunch. See you all at 2:30. Post lunch, we have some really amazing sessions. One on redefining health literacy in India, future of technology and ways to strengthen the voice of science. And I'm also delighted to have my colleague, Mr. Varadarajan Anantakrishnan, who will be heading a session on health misinformation. So please join us there.
Thank you. Thank you, everyone. I know a lot of people are still having their lunch. Thank you for all those who are back. And I'm going to make it a little bit interactive. I'm going to start with giving you some information. We've been talking so much about information. I will give you some information, and based on that, you have to make a decision about a day in your life. It will impact that day and what happens after that, right? So 540 minutes into day 315 of the year, you have to come to 28.6 degree north and 77.2 degrees east. Make sense? Anything? Okay, I will translate this information further into another format. Kartika Mase Krishna Pakshe Shanivasare Chatutyam Titau. Anything? Rings a bell? No? If this is what Ashish and his team had emailed you or sent you in their emails to come to this conference, I don't think anyone would have been here. But he said, 12th of November, Shangri-La Data Leads Conference, right? And that information you could use to make a decision to come here and participate in this conference. And that is the crux of the problem when you're talking about empowering communities with health information, right? Health information is at the crux of informed decision making, which determines health outcomes and qualities of life. But sadly, 9 out of 10 individuals have no idea how to use everyday medical data, medical information that is at their own disposal, right? And is routinely available at any health center, but they don't know what to make of it. Calculating numbers, for example, that determine things such as cholesterol, your sugar levels, measuring medications based on these numbers, right? And then understanding nutrition labels becomes extremely confusing and overwhelming. Processing and understanding this information is the key to informed decision making, and that is the crux of the problem, right? So what can we do to change this? Because this is what makes communities disempowered and puts power into the hands of very few people who can actually decipher and understand what these numbers and data is, and then make decisions for them, which is not what we want, right? So for this, first and foremost, I know from morning a lot of people have talked about data and information and decision making and so on. What we need is we need to provide accurate, accessible, and actionable information. What do I mean by this? I'll give you an example. From my own personal experience, I've interacted with more than 100,000 young adults in the last 20 years on menstrual health and hygiene. Everyone talks about menstrual blood is good blood, right? And I'm not even making this up. That is information, but is that accurate? Because there are people, young girls who've walked up to me in real time and said, when I cut my finger, my daddy used to ask me to put it in my mouth so I don't waste it. And everyone tells me this is good blood. So can I drink it? Literally, right? So that means information is being provided. Everyone's saying, oh, menstrual blood is good blood, but it's not accurate, right? So when we are giving information, it has to be accurate. It has to be accessible. I can't just go to a school and give a lecture, show some medical terminologies about uterus and ovulation and all of that and come back and expect them to understand everything, right? Whereas if I have an animation video which is in the local language, is interactive and can give them that information, that becomes accessible. And then actionable, right? What is actionable? For them to understand their body, to understand their periods, and then take action according to that, right? I may give them a period calendar and say, hey, take this, note your first day of period, last day of period, and so on, and then you can keep track of what is happening. But that is, again, not sufficient. When you provide information, you also have to provide the necessary skills to break down that information, right? So I tell them, how do you use that calendar? What do you make of it? Where do you put what numbers? What do those dates mean to you? And how does it relate to your own body? That will then give them skills to understand how to use that, right? And provide person-centered instead of generic information. If I tell all of them, we are all focusing, again, continuing on the same example, we're all focusing on sustainable menstruation. So I go tell them, hey, all of you have to start using cloth pads, reusable pads, or cups. And half of them stay in a one-room house with 10 people with no water to wash the pads or no place to hang them, dry them. That solution is never going to work for them, right? So giving person-centered information instead of generic is important. And then supporting that to be able to make lifelong learning as a process, right? Because 3 months or 3 years later, that same child may be able to learn, continue with this information saying, hey, now I'm able to make an informed decision to switch to sustainable menstruation. So that is, these are like 4 steps which I've broken down them into to make sure that the information that we are providing is all of these for the end user to be able to make informed decisions. How can we do this, right? Promoting changes in the healthcare delivery system. The top-down approach has to change. Incorporating standards-based health. Culturally and linguistically appropriate health information. Building partnerships, guidance and policies, we've all talked about that. This is when we can actually reach people who are traditionally outside of the healthcare system, right? They're not in schools, they're not in workplaces, they're not in hospitals, but they're out in the community, which is a large portion of our population that does not ever get access to this. We also, talked about who are the ones who are going to be doing this. Healthcare providers obviously are there, but it doesn't just end with them, right? There are community-based organizations, non-profits, advocacy groups, media and technology we talk so much about, right? Technology is something that is penetrating everyone. We've talked about 700 million users, but how do we use that technology to actually empower communities? We are giving them information, we are giving them all kinds of information. A lot of that is inaccurate, but how do we empower the communities to understand and for themselves to see what is accurate and what is not? We again talked about top-down approach where we are filtering information based on the source and to find out whether the source is credible. How will a villager find that out? If he gets an information saying there is an ICMR fake logo that was mentioned earlier, how will that individual go about validating that? How do we empower them to do something like that? We've not talked about. And that's, I think, an important question this group has to answer, right? How do we empower communities to understand whether this information that's coming is real or not, and how do we validate them? So the approach obviously has to involve long-term partnerships that's focused on local health issues, involves co-learning with the local communities, capacity building of these communities, shared decision-making, and mutual ownership so that the community also then can take responsibility for the outcomes, not just one way or the other. So with all of this, what is our ultimate goal? Why are we trying to empower communities, with health information so that we can develop sustainable strategies for disease prevention and health promotion? And then there is, again, we had talked about a lot of disparities, reducing these health disparities and improved access to data and informed decision-making, which is the ultimate end goal. There are several examples of how this has been done. Our own example I mentioned earlier, there's the Mizoram Health System Strengthening Project that we're doing with the World Bank. Arogya World has a great program called Doorstep Health Model. There is the Metaverse Hint VR immersive engagement model that is emerging. There are several examples. There's a George Institute model. I can talk about this outside if any of you are interested. But there are several ways in which this can be done. But the ownership is on us to make sure this happens and make sure that we are empowering communities, not just people sitting in this room, but people who really matter to be able to make informed decisions. And that is important. So all of you to think about. Thank you.
Thank you so much, Dr. Kulkarni. For our next session on redefining health literacy in a digital world, I'm pleased to invite Dr. Shabnam Singh, Principal Advisor, Confederation of Indian Industry, Dr. Rajmohan Panda, Health Systems and Policy Research Expert, Anas Wajid, Senior Director at Max Healthcare, Professor Anubhuti Yadav, Head Department of New Media and Information Technology at Indian Institute of Mass Communication, Dr. Ashish Bajaj, Chief Marketing Officer at Narayana Health. This session is moderated by Anubha Bhosle, founder in Newsworthy. In the new age of marketing, we are trying to make our speakers sit right below their names. So please bear with us for some time. Over to you, Anubha.
Good afternoon. Obviously, folks at Health Leads love this panel because we're the panel soon after lunch. So we have the honorable task of trying to wake you up. I hope you've all had coffee and are decently caffeinated. My name is Anubha Bhosle. I am an independent journalist and entrepreneur and the founder of Newsworthy. I'm just catching my breath, not because of the Delhi air, but just because I've rushed. I have a body of work on public health, conflict, gender, and politics. In my previous avatar, I was a journalist and the executive editor at CNN IBN. I'm now a new media entrepreneur. I do a lot of work that underpins public health and public health communication, which is why I get a seat. About a good health literacy is that its driving force should be science, should be facts, and should be public health. If you are short, concise, clear, jargon-free, that's a good thing. If you can be calm and composed, that's even better. If you can add some visual element to dreary text, even better. I don't think there's any one way to explain anything related to public health. Coming from COVID-19, I think it's fairly clear. Isolation at home means so many different things to so many different people. Social distancing means so many different things to different people, if you live in a one-bedroom house or in a chawl, etc. And I think vital to public health communication now, currently, is a digital framework. It can be a force multiplier, and I think it has some serious downsides as well, which is why I think a big round of applause to data leads, health leads, to putting up this particular panel. I think it's absolutely vital. And I also think it comes at a really good time. We're all coming at the back of a COVID-19 pandemic. We've all had these experiences. And I think collectively, all of you have great wide-ranging experience in public health, but also you have intersectional experience, which is why I think everybody here, all the stakeholders, have a lot to gain from you. I'm going to stop here. I thought the way we could do this panel is each of you could do short opening remarks to sort of set the context as to what you see as health literacy, changing trends, upsides and downsides, and then we can go deeper into the conversation. I'll introduce each one. I think everybody can see their designations, but I'll still do the honors. Dr. Shabnam, I'm going to put you on the spot first. She's the principal advisor of the CII, the Confederation of Indian Industries, and perhaps you could just kick it off by a broad arc of how you see health literacy, especially in a digital landscape.
Thank you. And I echo Anubha's words and thank Health Leads for this particular program. Rightfully said, it couldn't come at a more opportune time. And I think what is very critical is to understand the two components that have been woven into this. That is health and literacy, right? So very typically when you look at literacy, literacy is the ability to be able to absorb the knowledge and then subsequently have the competence and the experiential learning to be able to apply it to either use to you personally for your personal growth, or in the realm of personal growth, to be able to get a job, so on and so forth. Or you could apply it like Anubha is doing as an entrepreneur. She's adding value to society by putting in things for the community at large. So that takes care of the literacy part. So that means you get the knowledge, you're able to absorb it, you consciously process it, and then you apply it to either personal good or betterment of society, adding value. Now you look at health. So what does health mean? Health is one aspect of life, be it an individual level, be it at a societal level, be it at a governance level, be it at an individual, country level or global level. It's a much talked about subject with very little action to actually address it, because it's just too complex. It means so many different things. One, I don't want to get my blood test done because I don't want to know I'm sick, right? From a country level, you always want to be number one on that index of everything that you want. So all my values must be great. At a global level, we have all these great works, SDG, etc., etc. We've ticked the box on all of it. We will free everything. We will be as healthy and wealthy as everybody. Truth of the matter is, there is no magic wand, right? So when you club the two together, and what I briefly heard my earlier speaker, Mr. Kulkarni, say, now you can understand the complexity of this problem, which is called health literacy. In a short 2-minute introduction, I have confused you thoroughly. Haven't I? Please raise your hands. Are you confused as to what health literacy means? Absolutely. Right? So different things to different people, and I'll stop there and hand it back to you, Anubha.
Thank you. You've made my task tougher, but I'm glad it feels like a complicated aspect to it. But I think some part of it is so clear, right? Health is clear to us, literacy is clear to us. Anas Wajid, would you want to take the mic next? He's the Senior Director and Chief Sales and Marketing Officer for Max Healthcare.
Thank you, Anubha. So I would like to sort of make a couple of points really on how we see it and what's really happening. The entire digital framework that we seem to be working with, if you carefully look at it, I find 2-3 very interesting aspects. One is it's so empowering, which means that, with the digital transformation in healthcare that is now visible and progressing at a very, very rapid pace, communities have been empowered. Distant communities, remote communities have been empowered, and this has led to a couple of things. One, increased access to healthcare, which is communities can easily reach out using digital tools. And in India, we see this transformation while we work in private healthcare. We see this transformation every day where communities who were marginalized earlier, who had no access to healthcare. And that's the third point, as how access has tremendously improved. healthcare services, private, public, increasingly are going to be consumed on digital. And therefore, the literacy, the ability to run these systems, the ability to use a phone and ability to use other devices, etc., to reach out for and accessing healthcare has tremendously empowered a lot of people. And that, to my mind, is a very, very significant achievement that we've been able to see. The last point really on it comes out very often that, there are issues related to electronic health records and safety issues and privacy issues, and I'm sure those will come up later in the discussions. They're there. And, as healthcare institutions, we also face difficulties there. But I'm saying those are problems that can be solved. But the advantages, the benefits are far-reaching and tremendous, really, both on the side of access as well as transforming delivery of healthcare services to remote and distant communities. So those are the 2-3 points I thought I'll make comments on in the preliminary stage.
I think you're very well laid out. Dr. Panda, are you as optimistic when it comes to health systems and the digital infrastructure?
Yeah. I think digital health is going to be the future, and you cannot ignore it. Systems will have to adapt it. But being a researcher and professor, I like to confuse people, and I add to ma'am's confusion. But I did, one cannot theorize before one has data, so I've got a little bit of data with me, right? Absolutely. So, I read, and when I got this invitation, I do a little work in digital health, but primarily around evaluation. But I try to look up some definitions, and each and every definition is as confusing as the world of digital health. And there is one definition I really liked, may confuse some, may not confuse. But it says, in its ability to seek, find, understand. And this is what most definitions say. They say seek, find, understand from electronic sources and apply that knowledge. But this definition says seek, find, understand, and appraise health information. And I think a previous speaker, Dr. Vadrajan, did speak about who does have the capacity to appraise it. Is it just us? Is it the community? How we empower the community? And that, I think, is really the crux of the matter. Because that's where from misinformation, disinformation, the lines are blurred. How much of misinformation, disinformation, I don't think much difference, excepting the misinformation is deliberate, maybe. Disinformation can sometimes not be deliberate, but may be good with good intention. The road to hell is paved with good intention all the time, with us, with media, and all the time, right? So unless that part happens, I think we'll continue to go around in circles. This thing about who appraises the information. Now a lot of people are able to access, let's say access, even there is an issue with that, but a lot of people are able to access. The second thing which I think we talk about more, but I think my time's going to end, is we're talking about the problems, but what about research? So as a researcher, I'd like to know how many of you are aware about how many studies have actually been done to appraise of projects, interventions, or appraising health information that is misinformation. And the truth, friends, is not much. But I'll keep that for more, hopefully exciting conversation later on.
Absolutely, and I think when we unpack it further, I definitely want to know from you as to where you believe the onus lies for this appraisal. Who does that responsibility lie? How much are we willing to take the responsibility, and how much do we want to put it to the poor citizen or the consumer who already has a plethora of information on their phones? I made the error of not introducing Dr. Panda, hoping you've all seen. He's a health systems and policy research expert, and I think that's come out fairly clearly in how he has done the opening remarks. Dr. Anubhuti Yadav, who's the head of the Department of New Media and Technology at the IIMC. Do you see health literacy and public health communication almost synonymous?
Yeah, thank you so much, Anubha. And first of all, I would like to thank data leads, health leads for inviting me here. I feel proud and privileged to be part of this particular panel. So I come from a media sector. Usually I interact with the students of journalism and mass communication. I interact with the professionals from media, but this is the first time when I'm interacting with people who are coming from health sector. So it's a very nice thing. But coming on to health literacy, and I am actually researching a lot in the field of media literacy. So I was wondering that, okay, how can we connect media literacy and health literacy? Now, because we are talking about definition, if we talk about media literacy, see, it's an ability to access, analyze, evaluate, construct media messages in a wide variety of form. And this is what health literacy is also. Because in health literacy, like, we are getting very specific, we are talking about health issues. So, whether we are able to access information related to health in an accurate manner. So this is something which we are talking about, in health literacy. And information is something which is extremely important, and that is something which we have seen at the time of the pandemic. That was the time when people needed the information, and many a times, they were getting inaccurate information, and there were problems in the society because of misinformation, because of disinformation. Now, yesterday, when I thought that I had to interact with all of you, and I knew that, a lot of you will be coming from health sector, so I thought that let me read something on health literacy, and I wanted that I need to know what our policy says about health literacy. So I looked at two policies which I felt that should be talking about health literacy. One is National Health Policy, and another one is National Education Policy. Because, these are the two policies should mention, health literacy. Unfortunately, I couldn't find these two terms in any of these policies. When you talk about National Health Policy, yes, they mention health. Of course, it's a health policy 382 times. But when you talk about health literacy, it wasn't there at all. When you talk about National Education Policy, health was mentioned 32 times in the document. They were talking about mental health. They were talking about the physical health of students. They're talking about the balanced diet. So there were a number of things. But when it comes to health literacy, it was not at all mentioned in the document. So, these are the two major policies which we have in our country, which should be talking about health literacy. And unfortunately, we do not have mention of this in these two major documents. So, which means we have a long way to go. It will trickle down only when it is part of national policies. If it is not part of national policies, how do we expect that, the people in the community and, of course, the people who are there in the health sector will be able to deliver this or will be able to talk about this? So I think these are the issues which we have to talk about. Having said that, it's not that, we are not talking about health. India is a country wherein we start talking about health at a very young age. You all, all of us had gone to school. We start this, grade 1, grade 2, there's the chapter on balanced diet. Then we move on to, what are the major, vitamins, minerals. Then we move on to, like, deficiency of which vitamin and mineral will cause what disease. Then we move on to, all the systems, which means like your circulatory system, digestive system, everything. By the time students reach their 10th class, we introduce them to the reproductive system. And that too, let me tell you one thing, most of the schools, right, what they do, even if the chapter is third, they'll keep it for the last, month. That this is what we are going to do towards the last, month of the academic year. And there are a number of schools, who are not even teaching that particular thing to their students. So this is something which is happening. Yes, it is being introduced, but once we leave school, we are not talking about health at all. We are not talking about health in colleges. Look at what is happening right now in IT sector. There are so many engineering colleges, and the way, the employees are being laid off by the IT departments, I think these students in the engineering college, they have a lot of anxiety. There are a lot of mental health issues there, but we are not talking about it. And every stage of our life, we come across, a lot of problems, a lot of issues. Our bodies are going through, a lot of changes. So we need to talk about health literacy at each level. And that is something I personally feel that we have missed. We only talk about health literacy whenever there's a problem like pandemic, or like when we come across, major issues and we feel that we need to talk about it. Yeah.
Professor Anubhuti, I think you bring important points, because I think health literacy in an informal way has existed in our life, in our childhood, in our growing up stages. But I think both you and Dr. Shabnam actually articulate how confusing we are looking at it as health literacy. But I think also for our panel, perhaps one of the tasks here is how to actually simplify it. Because in some ways, communicating on health literacy is not as problematic as communicating on misinformation on news or cryptocurrency or mutual funds, etc. I think it could be far easier than that. Ashish Bajaj, Chief Marketing Officer at the Narayana Healthcare. Do you want to just set up the context?
So, Anuva, I'll say when you have such stalwarts on the stage and you are sitting the last to talk about the opening note, you really don't have left much in terms of putting out. But nevertheless, if you want to pick it up from a health literacy point of view, we need to solve the problem at the top, the 30,000 feet problem of literacy itself. Then you deep dive into health literacy. Then you deep dive into misinformation. We are at a level where the information is not in abundance. We are having, 750 million users who are utilizing internet in India. But the kind of Google searches that happen within healthcare system at a monthly level are not even 1 billion. So you can see the frequency of finding out information is also not there as an intent. So from there, I think it all starts from there. Until the time, yes, of course, there will be misinformations, but till the time the information starts getting pulled, there will be no time that the diminishing returns will start. So the right and correct information can then be discovered correctly. So I'll stop there. I think we've covered a lot in terms of the overall acumen of literacy.
Yeah, I think you've all sort of set the stage very well about different aspects of health literacy or health illiteracy, if I can say it, since all of you are pointing towards that in fair granular detail. Dr. Panda, maybe I start with you and the question that I posed to you. When we are looking at health literacy or health information, what are the pillars? Who should that first responsibility lie with? Is the responsibility here with some of the stakeholders, doctors, medical healthcare professionals, policy experts? And then comes the communication part of it.
Thank you. I think I'm going to turn that question a little around and say it depends, right? I mean, I could give a generic answer, but there's no generic answer. We know everybody is responsible in the end. Definitely professionals. I would put it a broad area of professionals. But what's striking is, maybe in this group, but whenever we have a conversation of health literacy or digital health literacy, there are three things, right? One is digital, there one is health, and there is literacy. But literacy is not just literacy, it's civic literacy, right? And we quite often ignore civic literacy at our peril, right? Believing that people who are literate will not have misinformation is the biggest myth of them all, right? Many of us live in these condos where very literate people with money, power, education, jobs, not only are the victim of misinformation, but also produce misinformation and circulate misinformation, right? So ideologue, thinking process, and the ability to be able to, again, coming back to appraise health information is some of the problem. Now, if you were to answer your question, so then professionals, is it just the healthcare system, or researchers and media, or is it more? And some of the frameworks that really need to evaluate or really develop health literacy should come from a broader understanding of not just health, but psychology, sociology, a lot of transactional disciplines that we talk about but just do lip service. But hey, aren't we forgetting something more important? We are doing it for something. Isn't that a very condensing attitude from our part? Is the audience for whom this literature is meant for, are they co-producing it? Shouldn't we think about the fact that we are still talking from a pedestal and we are saying this is information that we have designed for you? While professionals have the way, if you design a behavior change program for tribal mothers and something else for the general population, it would vary much. So I think that's what I'll
I think you make a very important point, but I think we're also constantly using these terms of digital health, literacy, misinformation, etc. But from your opening remarks, I've got a sense that health literacy, the lack of information about health, and health misinformation are actually three different pillars, right? A lack of health information could be solved for by creating more content, but a misinformation on health has far greater problems. Do you want to take that?
So let's look at, let's start from again a 30,000 feet view. If you have to solve it, we have to see how do you make those subsegments in terms of filtering out the wrong kind of information. So look at all the other industries. Healthcare is one of the industry in which consumerization has still not happened. Now, healthcare from a tech development point of view happened from a clinical point of view. Healthcare never worked towards solving or keeping consumer at the center or the patient at the center. It was always around different aspects of healthcare clinically, right? Now, in that, what happened? The information production didn't started way back. Now, there has been a plethora of information which is spurted in last 5 to 7 years. Because of that, because it just went out so fast, everyone thought that I can also create information in that regard, which led all of us to find out really irrelevant, wrong information, and we all started following that information because the content production never took place from the right sources. So I think it all started because the first level of it is consumerization. If that happens, the content creation that happens, and then is when is your again misinformation starts going out.
So, Mr. Wajid, it's the information gap always leads to content creation, or often leads to content creation from sources that are not credible, right? I'm wondering, as both of you, as folks of sort of public healthcare providers, you're increasingly talking about consumerization. And I'm wondering whether sitting here, we are looking at this completely from the lens, from an urban lens. That, as Dr. Panda said, that when you're doing social behavior communication for tribal women in Maharashtra or anywhere else, what you're going to say is going to be very different. The tools you're going to use are possibly going to be very different. So this is not to sort of dampen the spirits in digital literacy, but to take a more holistic view. How would you see it?
Okay. Like I said, there have been a lot of pessimistic views articulated, and I still feel that there is a cause of worry on certain aspects of what you're saying, but there's a lot more which is positive and which is happening around us that we need to kind of look at. If you allow me, a few simple points to make, and I'll come to the nuances in communication that may be there for an urban audience versus a rural audience or in various socioeconomic classes, etc. But look at ourselves. Is there anybody in this room who doesn't look at Google before you want to go and see a doctor? Is there anybody in this room now who wouldn't do a search before you have, for example, you need to go and see a doctor for a fever? Is there anybody in the room who won't do that? And you'll get a lot of answers, of course. You will learn a few things. You'll become apprehensive. There may be some very, very sort of wrong answers there, but we do it, right? Second, is there anybody in this room who still doesn't have, and pardon my asking this question really, who doesn't have a healthcare app on their phone today? Is there anybody in this room? There's one gentleman, there are two people, there's some people still, right? But a lot of people would have a healthcare app on their system. It gives you information. Now, it depends which app you have got, because we trust different sources of information. An app can be considered as that, and it then allows you, apart from giving you information, to interact, to really go out and get the service that you want for yourself, for somebody else, for a distant relative, for a family, for a friend, anything. So the point one is making is that digital literacy is transforming healthcare, at least for some people in India. Right? That's point number one. And that some people is a very large number of people, by the way. A lot needs to be done. Now I come to that. What we need to do, of course, is figure out. And unfortunately, most of the healthcare communication today is being done in a language or in languages that are not so easily accessible, etc., mostly English and so on. We need to look at that. We need to start making or tailor-making communication for other segments of the society that we need to reach out to. But there's nobody who is sort of tasked with this, really. Is there any government body, is there any public sort of authority which is tasked with creating genuine, correct, accurate healthcare communication in vernacular languages? There's so many in India targeting specific communities. There's none. So therefore, there is probably a need for a central or at least, at state level bodies which are tasked with this particular thing to be done. Most of the communication, for example, healthcare companies here and there, I found lots of friends from various private hospitals here. We do a lot of community creation of communication, right? We try our best to ensure that it is accurate as far as possible. But the fact remains that we do have a commercial interest in this, right? And therefore it colors a lot of things. However, we need that body which can sort of sustain and drive this across the system. I think that's very, very important. And of course, we need safeguards against misinformation. I'm saying that's not a problem with healthcare alone. Misinformation is there on the digital sort of platforms for everything, whether banking, whether anything that you look at it. So that's not a particularly healthcare problem. That's a problem for digital sort of experts to solve for across the sectors, including healthcare.
But I think the solution has to be tailored to different sectors because health misinformation can play out in very different ways compared to news misinformation or financial fraud kind of misinformation. So, Professor Anubhuti, I see a lot of scope for many of your students. I do have to say that the Ministry of Health and Family Welfare does have public information departments that are making tailor-made communication, etc. There's still a variance here. There is still a variance here. There is still an information gap that everybody is talking about, and yet we are talking about misinformation, and we are saying misinformation is a result of almost this information gap. To your mind, as you see public health communication over the years, and you've made an important point of health literacy sort of being in our life always. What do you see in today's day and age with the digital landscape should be the anatomy of a good public health communication message? What should it contain? What could it look like in this setting and possibly in a slightly rural setting? Where too, Anas, where too they are using the phone. So my case for urban is not to say that people in urban India are not using phones or are not using the digital landscape. My case for making a separate communication plan for rural India is that you speak their language.
Yeah,
go ahead.
This is what I wanted to say. So when you say that, what that perfect health communication message should have, you need to speak the language of your target audience, right? So that's the most important thing. Another thing is that, you talked about my students. At Indian Institute of Mass Communication, we are, planning to start a course in health communication. Now, this is one thing which had happened at the time of the pandemic, which all of us had experienced. See, there were two groups of people who were interacting with us. There were one who were coming from the health sector who knew this subject well, but they were not able to explain it to their target audience. And then we had another group of people, communicators, who knew how to communicate well, but they were not aware of, medical terminologies and the lingo, right? So there was a gap. And, that was the time when we realized that, these two groups of people, they have to come together. And we need to work towards that. Well, I've been to a number of hospitals, right? And, nowadays, if you go to hospital, it's a huge infrastructure, a lot of people, a lot of departments. And I feel that, they should invest more in communication department. It's very important because why this misinformation is there? As you've said, whenever there's any, maybe like crisis, the first thing which we do is reflexively we turn toward our smartphone and we try to find information related to that. And if the information is not coming from authoritative sources, if it is not credible, then there are a number of people who are creating content. They are not creating content so that they want to make people aware of that particular issue. They are creating that particular content because they know digital marketing well. They know that people are searching this, and we need to create content with these search queries so that we come on the first search engine result page. There will be a lot of traffic on our website, and we'll earn a lot of money. And this is what gap which we are talking about. So instead of allowing those people to create content, we have to create content. People who are there in the health sector, they have to create content. Doctors have to create content. And yesterday only I was looking at YouTube Health. They're doing a wonderful job, wherein there are a number of YouTube channels, and they have certified that, okay, these are good channel, authentic, authoritative sources, and if you need to have information related to health, you can visit this particular channel. So I think we need to talk about communication. Hospitals need to have communication department, and as he said, the first thing which we do is we type a search query and we try and find answer to that particular problem. When someone is typing that search query, then the response should come from the authoritative sources, people like you who are working in the health sector.
I think that's very well put. And as communication professionals or media professionals, my urge often to anyone working in public health is, please make communication the centerpiece. Don't think of communication at the end of the crisis. Think of communication even before a crisis has sort of even hit the doors, when the first warnings have come, when you're just about seeing the first signs of despair. Start thinking about communication then, because then you'll be able to preempt all scenarios. You'll be able to make it a truly inclusive message. And I think what sometimes, Dr. Shabnam, happens in our country or in our landscape is that we keep thinking of communication as we go along, right? One symptom has come, so let's now put out a communication strategy for it. I'm not trying to take out a COVID-19 example, but I think even in previous scenarios, we think of communication as we go along. You've had wide-ranging experience. What do you believe have been the trends that make us smarter today? What are the things that we need to be mindful of when we talk about health literacy or health communication?
So I'll just take some pointers from the discussions here. We started off by saying that health literacy has been with us for eons, right? And it comes from our grandparents, our parents, our aunts and uncles. And if you look at that circle, it's a circle of trust, right? We got embedded by that circle of trust with our basic sense of health literacy. Then when you fall sick, the second circle of trust is your health provider. Now you look at what is that ecosystem of health provisioning. At the rural level, it starts with your ASHA worker, right? And then it creeps up. It goes to your physician, your provider of care. You have no way of knowing whether it is an allopathic or whatever it is. There's no way that you would, but you come through a circle of trust, as I said, of this ecosystem from which you've come up from, right? So they support it, so that becomes the input factor. Then you come to places like where Anas, everybody else is, and then they give you these pamphlets, etc. You take it home, and then you get educated about your problem. And in today's current world, you have this entire internet and the digital way where your children now search for you and then give you back the information, especially a generation like mine. We are not digital natives, so as to speak, right? So this is the ecosystem. Now, when you're working in this ecosystem, you need to solve it here and now. And misinformation, as very rightly pointed out, is not only unique to health, but can carry with it the problem of the maximum amount of personal damage it can do to you, right? Now, what is it that every human being wants to ask but is always diffident to ask? So I'm saying, put this pen down. You want to ask why, right? Now, in this entire portion, other than your first circle of trust, you don't have that confidence to ask that question why. Doctor ने आपको पर्ची दे दी, आपने वो पर्ची उठाई, you go to the chemist, you कहता है 3 बार ये खा लेना, you will never ask why. इसका कोई side effect है, कुछ है ये, nothing. But how do you effectively embed health literacy in the current context to address all the complexities, the rural-urban divide, digital native, not native, whatever, is you have to start with children.
Start with?
Children. Because everybody looks towards the child, मैं ये phone कैसे कौन सा button दबाऊं? Even a 2-year-old knows how to switch this on and off. So if you are able to formulate a world in which you start educating them, and to your question which you started with, whose responsibility is this, right? So we like to akin what we say patient-centric care today, that health is a responsibility and accountability of every human being. You cannot pass the buck on. But the question is, how do you make that individual knowledgeable enough to be able to take care of their health, right? Is the question.
I actually want to put the onus, because health is also a state subject. Dr. Panda, as Dr. Shabnam said, what would success look like? And I'm jumping several loops here, but what would success look like? Would success look like if tomorrow our ASHA workers, who are the foot soldiers of our public health system, are carrying with them smartphones with simple, clean, vernacular videos that tell you, see, this is what a doctor is saying what you should do. What would success look like for health literacy and the digital landscape to truly meet? What would it look like?
That's really a loaded question, but I'll just try to tell you what I look at in the beginning, right? We've been talking about appraisals, right? I think the first step is to say who's creating the content and who's creating the content and are they really capable content. So for me, success could be anything that you talked about, but for me, the first step would be to actually build the competencies of people who actually do create the content.
Who is that subset? I mean, who is that set?
It could be the ministry, it could be public health professionals, it could be a multidisciplinary collaboration. I don't know really. Sure. But I think that's something that is a start. And then we will see that thing that you talk about maybe in 2 years, 3 years down the drain. But I think we need to start with something that is powerful to be able to, otherwise we'll have another workshop where we again say who will do it, right? Or what needs to be done. But I think this needs to be done, that we need to build competencies. And that's not happening today.
Ashish and Mr. Vajid, both of you can take it. Ashish, maybe first. Is that a genuine problem, that healthcare professionals are not able to make content and they do possibly need the help of Anubhuti, her students, and professionals like mine?
Absolutely. As Prof has covered this very well. And it's a day-to-day problem. And that is what we as the team try to deliver, that we enable them to deliver those kind of difficult nuances of healthcare in as much as easy language for the consumer. So we try our bit. I think we still have a long way to go.
Mr. Vijay, do you face similar problems?
Slightly different take again. Okay. In my view, the communication that's created by large hospital chains, marketing communication people, etc., is done for a certain set of clients and for a certain set of audience, right? I dare say, that bit is addressed fairly well. The communication that goes out to that set of audience is very well made, in my experience at least. But that's probably 10% of what needs to be done. And that the other 90% we're really not addressing. And we're not addressing that set altogether. And therefore, and private sector hospitals, I dare say, would probably still not do that because, they've got a particular kind of audience in mind for their communication. The communication is meant for that audience. It's consumed well there. But for the rest, 80-90% really, we would love to contribute in some way, but, it's just very, very difficult for us to put resources, people, experts, etc., to create and develop that communication. I think it's going to take a lot of time, and maybe we are not the right sort of people to do it as well.
Fair enough. And I think that's where everybody's expertise comes into being, that there needs to be this capacity building. I'll open it up to the audience. If you have a couple of questions, we could address it. Do you have a mic, sir? You could go ahead. Or maybe we could hear you just like that.
Happened around personal literacy, personal health literacy. So what about the organizational health literacy? So do we have examples of some of the systems and practices that would enable an individual to navigate the information landscape in a manner that makes it easier for individuals to access and utilize that information? And related to that, and one example we have seen in case of YouTube Health, where it's authenticating some certain information providers. So other examples, and somewhat question, that do we think that there is a need to
Okay. Frameworks or frameworks within organizations on health literacy.
Right. So I'll give you an example of an institutional framework which CII has adopted, right? So it's twofold. One is that all the companies are given a toolkit of sensitizing their employee base, and the thought behind is that for every one employee, you'll have minimum four people attached to that, and through that, there are various communities at large. So you give them a toolkit, and you have a sensitization workshop, where again it's templatized, where you tell the employees about the basic tenets of healthcare, as well as inform them as far as possible. At this present moment, our entire focus is on tuberculosis, right? So we tell them where you can go and get a free TB test done, where are your public facilities, and so on and so forth. Planning to expand this entire footprint, because whatever pieces that are I can't say, which are made by government, whether it is a blindness program, maternal and child, all of them, state as well as center, they have to be distributed appropriately. So using those as a platform, we use the employee as the recipient of the health information, and through him or her to the rest of the community. What we are struggling with is, how do you make this a two-way conversation, right? It's just not wanting to be a sage on the stage, that they know, but they don't have the ability to ask back. And that's something which is in progress to be fine-tuned. If I start addressing all the questions, we might spend a...
Yeah, I'll take in one more, and if we get time, we'll address the maternal health question as well.
The question that I have is
We'll take one
regarding
and then we'll come to
health literacy, as to who is the owner or who has the responsibility. Mr. Wajid rightly mentioned, somebody has to take the responsibility of driving the entire ecosystem of health literacy in the country. Now let's define. On the platform, we have only one representative from Government of India, which is indirectly Dr. Anubhuti, which is Indian Institute of Mass Communication, which is under the Ministry of Health, Ministry of Information and Broadcasting, if I'm correct. Is it correct? Right. Now, there is an Indian Information Service, Group A service of Government of India, having professional responsibility for disseminating information. Won't you feel that instead of searching for the health policy, instead of searching for the education policy, you to see within. Is it not the responsibility of Indian Information Service to sheet anchor, to be the nodal agency for driving the entire health literacy process in the civil society domain, in the governmental domain, and the non-governmental domain, that is the commercial domain, where we have Dr. Ashish and Mr. Wajid on the platform, and indirectly Dr. Shabnam Singh for a long time in the same group. So won't you feel that it is the responsibility of the Ministry of Information Broadcasting and the technical wing, Indian Institute of Mass Communication, and you especially as the head of Department of New Media and Information Technology have the onerous responsibility to drive the whole process of redefining health literacy in the digital world?
That's a big responsibility
Yeah,
you're giving.
that's a big responsibility.
He is the
you're
most
giving me.
competent person, actually.
Yeah.
That's a big
No,
responsibility.
but I will take, your, not question, but the comment. And definitely I would like to respond to this. And you're absolutely right, Information and Broadcasting Ministry, and you have Indian Information Service officers, who has this duty to do this. And I think all of us, we have seen at the time of the pandemic what PIB has done. Press Information Bureau. Every day there used to be a press conference. When at the time of the lockdown, we were all limited to our houses, right? We were actually watching them. All the doctors were there in National Media Center, and every day we actually listened to them and we got the updates from there. So this is which was done by, Information and Broadcasting Ministry and Indian Information Service Officer. Another thing which, because you talked about it, so I thought that, I should tell the entire audience. Another excellent thing which, Press Information Bureau has done was they have set up a fact-check desk at the time of the pandemic. There was a lot of misinformation around government policies and programs at the time of the pandemic. And every day they were fact-checking that particular information. So you're right, it is our responsibility, and we are doing that. The only thing is that maybe, you're right, that, being at national level, we should reach each and every citizen of our country. But the efforts were made, and, there were a lot of people who were watching those particular programs. So, and at Indian Institute of Mass Communication, and as I said before, that we are planning to start a course in health communication, because this is our takeaway from the pandemic, that we need to have a course in communication, and especially something which is focusing on health.
I think, sir, with due respect, health communication also needs health expertise and professionals. We are communication professionals. Our job is to help the health professionals. It needs to be foregrounded in science, in fact, and health. It needs to be. I mean, I'm not against IMC being the nodal, not for a moment. Ma'am, you had a question.
Dr. Panda and Dr. Anubhuti, both of them spoke about the importance of health education at the school level. And there is a very good program by the School Health and Wellness Program by the Ministry of Health and Social Welfare. So there are the specific modules which are developed for school children. And these are delivered by the health and wellness ambassadors in government schools. The thing is, and again, I think it needs some communication. There's a lot of very good information. It's a joint initiative with the Ministry of Health and the Ministry of Education. The thing is, it stops there. It stops there. So is there any way we can continue this initiative or this communication beyond it, beyond just the few very elementary, what is delivered at the schools, school level, and only in government schools in a few states at the moment? Is there any way we can carry forward this communication? Is there any platform at the moment?
When you say carry forward, do you mean dissemination?
Dissemination at other levels in the broader community, maybe at higher educational institutions and at organizations also, Dr. Shabnam?
I think Dr. Shabnam made the point about students.
Yeah, actually, I am privy to certain amount of what you said. It is work in progress. All that has been done was in pilot forms, and there was in 17 or 19 states, they have this capacity building program in skilling for various areas. And this, as well as CPR, is being introduced. So there's a lot of work being done. It is being done with state as well as center, right? Because health is a state subject, and so a large part of education is. So it is work in progress. I think in the next 4 or 5 years, you will see the impact and effect of it. Okay. It is there. It is coming in now.
I Okay, do we have time for one more question?
I just want to add something. We've been talking about dissemination, information. I think we should also have inclusion of media owners as well. So being a media owner, newsworthy, I think you can also be instrumental in making that change.
How much coverage?
I think mainstream media in India is its own story and its own panel, which I'm not sure Syed would be very happy if I took the panel there. But I am completely of the opinion that public health is in public interest. And it is absolutely, should be on the agenda of mainstream media, of new media. New media today is actually more, Syed and data leads and health leads actually comes from the same framework, right? They are more aware, embracing of the fact that India today is public health, needs information on reproductive and maternal health, needs to look at intersections of gender and climate change. I wish I could say that for large sections of the media, which doesn't happen, and I think there is a fault there, but I think that's a different panel discussion. I don't think we have enough time for this one, and I think that could go on for more. I think I'll take one last question, and then we'll do final remarks. Do we have time to do that? Yeah? Okay, one last question.
Okay, I'll make it very quick. And my question is to Dr. Shabnam. Now, this is from something I'm currently struggling. So I am from IP Global, and as we are talking about making region-specific, language-specific context, we did that. So we have a program, we did that. Now the part is mobilization of youth, and the approach we wanted to go through is industries in the district. Now the problem where we got stuck and is being very challenging is that we are just not able to get through the gateway or the door, provided that there is no policy or mandate for private industries to let their workers, because it's loss of their labor, of that time, to get even into a session with us where we will be able to teach them about family planning, participation in maternal health, or anything and everything. And it's just so hard to communicate with those doormans and get through even the owners of those industries. So how do, even if we are trying, so all the other aspect, let's see if we fix that. How do we do this?
Okay. Very quickly, Dr. Shabda.
Yeah, so that's where you need industry associations like CI, etc., to help you. So offline, very happy to discuss this out with you.
Okay, I'm going to give, thank you so much. I appreciate that a lot. I'll give final sort of remarks to each of you, and I think I wanted to go in far deeper in different aspects. I wanted to nudge Mr. Wajid on privacy issues, etc., that private healthcare providers need to take care of. We haven't got time to go there. But if I was to sort of leave it broadly open to you as to one low-hanging fruit which you believe could, move the needle a little bit when it comes to health literacy in the digital lab.
Well, if you really looking at one big thing that we need to do in that space is, I think we need to reach out to a lot more people than what we do currently through targeted programs, which means that, for example, if I have a community of, or I should have a community of people who I know are diabetics, and therefore I should have targeted, focused communication for that community that can be regularly sent to them. And similarly for other communities, maybe a community of pregnant women, for example, every week, every fortnight, every month, a piece of information that goes to them which is targeted, which is relevant to them, and they're not searching for it, they've opted to get it and there's someone sending it. I think that will make a big difference.
I think the opt-in. Yeah, can I give it to him because they come from the same?
So yes. See, Mr. Wajid, the thing is, I'm not being associated much with the healthcare industry for long. So coming into the healthcare industry or the hospital industry per se, the problem is, we think patient journey, patient cycle. We need to start thinking consumer journey, consumer cycle. So that means there is a problem. People who are in market looking for healthcare solutions are not where we stop. So that's like 12 to 15 million people in India, private health, and of course, 80 to 110 in government health. Now you have to go beyond that. We are 120 bill. Now, if there we are, you need to start thinking, how do we solve for that consumer at large? Right? What we are still talking about is we have communities, we have information systems, but that needs to go beyond, say, a diabetologist problem or say gynec issue. We need to start thinking about preventive. We need to start thinking about how I should have myself looking into mirror when I'm 35, 45, 55, at an age when I'm 25.
I asked you low-hanging fruit.
That's the lowest.
I said low-hanging fruit. Why don't you take the mic and just delve on that a little longer? Because I can understand what the biggest crisis of health communication is. Telling someone, ye kar lo, varna bimar ho jaoge. No one wants to hear this. No one wants to hear the fact that if I don't do this, I will get a cardiac arrest.
Correct. So, of course, you don't have to be scary. You don't have to be scary as an information provider.
When you've looked at the panel today, do you believe that is where the focus should be? Preventive healthcare?
Absolutely, yes. Absolutely, yes. Because it allows you to look at yourself, brings back, I think we've picked up information or say conversations about, is it honest to me or is it honest to public information system? Now, I think both of these guys have to work it out. Now, if we have to work it out, public information system, we know how it works. We know how much time it takes. The lowest hanging fruit is tomorrow morning, I start saying that, okay, right now I'm going to start taking care of myself. I think it cannot be lowest from that. And it's a decision that we have to make.
And I have to say, as a communication professional, that's an easy line to communicate. In this day of self-care, self-awareness, Dr. Panda.
I'll agree with what Ashish said, even though you may think it's not a low, it's definitely not a low-hanging fruit. But I think patient-public involvement, PPI, in co-producing it, if you want to have owners, you have to co-produce it. You cannot speak from a pedestal. You cannot tell them what to do. Like, you just said it. If you, as one of my friends who has just hit menopause says, all they say is eat kale, drink water, walk. Kale, here in India, I mean that's how bizarre it gets, right? So, and I can say countless other examples, right? So the onus is not just PPI, but co-producing it, co-PI. It's not a low-hanging fruit, but let's say it's a middle-hanging fruit. A low-hanging fruit for me as a researcher and professor at Public Health Foundation is very easy for us to say that building competencies in health professionals at all level, not just the doctor. I think we make the big mistake of just going out to talk to doctor. Doctors are not good health communicators. Talk to the nurses, train them well. Talk to the A&Ms, talk to the ASHAs, they train them well. But invariably, by the time you had the training for the ASHAs, it's so diluted that just a figment of what you had really planned for. So I think that's a low-hanging fruit, but that's a priority that the government must give to this kind of communication.
I'm not giving away my health, but I am a voracious consumer of health podcasts. And I find that this is such a gap here in India because I listen to Tim Spector, Huberman Lab. I can talk about prefrontal cortex, although I have no training. And I do that all because I'm consuming so much information, which is easy, digestible, I understand it. Of course, I come from a place of privilege and all of that, but even for someone like me. Final word to you. I think we've got a lot of work today, or potential for work.
We've got a lot of work today. So I feel that, there are a lot of initiatives which have already been taken, right? And I think, the best thing would be, and best case scenario would be that if someone has any question related to health, that person should be able to go somewhere, any repository. We have, again, I'll talk about, Government of India. We have National Health Portal, right? So we do have a lot of things which are available, but we need to work more on that. So it's instead of, starting something afresh or trying to find out another solution, so why can't we make that system a robust system wherein today morning only, I said that, okay, let me ask this National Health Portal about arthritis. And when I went there, that page was not there. So we need to work on that. These are the areas wherein we need to work.
Is there any industry from which we can just copy-paste an example which has done this well? Anyone in the audience? That they've done this? Fintech. Still, it's worked. Lack of information. Yeah, okay. Any other industry? Okay. On, but fintech guys put on a lot of guidelines. Read the subject to market risks. Read the fine print.
But you can't make that kind of thing for health.
Yeah.
That's the problem.
You have to put a lot of disclaimers. Fair enough. I'm going to close this panel here because I think the rise of the doctor influencer and the health influencer is also ahead in the summit, right? And I want them to take a little bit of this heat as to what they are putting out and how well they are putting out. Thank you so much. Thank you so much.
Wow. Wow, what a panel that was. So insightful, so damn insightful. Thank you. Thank you, Anubha. Emerging technologies such as big data, artificial intelligence, and cloud computing are evolving to be game changers in the healthcare industry. And today, we have leaders from these sectors among us to talk on the future of digital and technological transformation of healthcare. I now invite Kshitij Kumar, Vice President, Health Systems, Philips, Rajiv Sikka, CIO, Medanta Hospital, Prashant Singh, Director and Chief Information Officer at Max Healthcare, Kishore Joshi, Chief Business Officer, Teleradiology Solutions Group, Srinath Honnavalli, Founder and CEO of Travelo Healthcare. This session is moderated by Dr. Arun P. Jose, Deputy Director, Center for Digital Health at Public Health Foundation of India.
Hello, and a very good afternoon to everyone here, and thank you for joining us on this much-awaited session. I think the previous session was very engaging, and there are a lot of questions that I think were supposed to be asked, which probably would be answered at this session. So, India is on the threshold of an healthcare revolution. The digital transformation in other sectors probably started 3 to 4 decades ago. The healthcare sector has been slow to start, but they've been accelerating at a massive pace. And I think, in a way, it's been good that other sectors started first, because many of the technologies that they developed for their respective sectors have contributed to the health sector and has helped us leapfrog a lot. AI, big data, machine learning, techniques like edge and cloud computing, blockchain technologies, and so many more are making its presence in healthcare also now. And moreover, it's an exciting time for digital health. A lot of investment has come in. The private sector and the public sector are making large investments in digital health today. And there's an increasing felt need amongst patients as well as the providers in use of digital health. And the government of India has made a very large commitment towards improving digital health in India through the Ayushman Bharat Digital Mission. So today we have a panel of awesome experts. And I think it's going to be a learning experience for me. We are going to learn from them about some of the innovations and futuristic technologies that they're working on currently, the challenges that they have overcome for its success, their perceived challenges and threats to the digital health journey in India. And also, we will end on an optimistic note on seeing what their predictions are for digital health. So the title of the session is Future of Digital and Technological Transformation. And I thought it's only apt that we hear about the futuristic technologies and digital health innovations that our panelists are working on in their respective organizations. So with this, I'll start off the discussion. I think we'll start off with Mr. Kshitij Kumar, who is the Vice President of Health Systems at Philips. So Kshitij, Philips has been a household name in India. They've built trust amongst the people of India since a very long time. And it's considered as a pioneer of digital health and health tech. So can you elaborate on some of the exciting and futuristic innovations being done at Philips at present?
Yeah, let me first start. Thank you, Dr. Arun, for having me on this panel and moderating this. Whenever we talk of digital health, we should talk about two eras. One is the pre-COVID era and the post-COVID era. And I think it's only apt that why we should talk about these two eras, because what did not happen for years together or decades together in digital health happened in those couple of years. In fact, like a few months, I would say. The acceleration that we saw on the digital side is one of the positive effects of the COVID. Okay, while the COVID had its own sad memories, but I think on the positive side of it, if there is one change that has happened because of COVID, is the speed at which all of us adopted was huge. It also kind of broke down our mental barriers in terms of digital health. If I talk about it, there has been a trend going on where healthcare from an episodic care perspective at hospital versus wellness preventive outside the hospital were seen as two different bubbles. What digital health is going to do is merge the two, which means care at the hospital and care outside the hospital, the data flowing in from when you are staying and healthy living, etc., the preventive side of it, to help the healthcare providers will happen. Today, 70% of healthcare actually happens within the hospital, 30% happens outside. Fast forward it 8 to 10 years out, it's going to flip over. And that is something which Philips is working on very closely, saying that how can we help connect the data coming from each one of us, even from a longitudinal data perspective, much earlier to the hospitals, to the care providers, before the episode happens. And if I talk specifically about what Philips is trying to do, the three major areas that we are trying to focus on, starting first with how can we help the consumers who are not even patients at that point of time. They are general consumers living happily, preventive side of it, healthy living. How can they have control over their own data, which is happening? Could be Fitbits today, could be some devices today, but they are kind of sending it out of data already. They are accumulating their own data to the point where we can make the healthcare professionals within the hospitals utilizing the data that is coming in from various sources. How do we integrate that data? How does the radiology department talks to the pathology department? How can it integrate and clinically get far better insights that have not been possible in the past? Right? These are some of the few fundamental things that we are looking at from a Philips perspective, and we clearly see that the healthcare of tomorrow will not be fragmented between hospital care and outside the hospital care. It will get integrated far more than we see it today.
Absolutely, absolutely agree. I think a seamless flow of data within the hospitals as well as from hospitals to the outside is absolutely necessary for the future of digital health in India. And we have two chief information officers on our panel, quite intimidating. And the hospital industry has come in very strongly in the digital health activities of India. And I would ask Mr. Rajiv Sikka from Medanta to speak a little bit about the digital health initiatives at Medanta and how we are complementing what Mr. Shishadi just spoke about.
Sure. So, there are multiple initiatives which are going on, and they are at different stages of the flight. Some are on the runway, some are already, on the verge of taking a flight, and some are already in the air. So I'll talk about two examples, and these are predominantly with respect to impact they are creating and also the long-term perspective in terms of opportunity and potential. So first example is that we run India's biggest CSR for TB-free Haryana. We started with TB-free Haryana and then moved to 5 other states where we have our own hospital. So just imagine that a van goes to a district where there is probably no internet, definitely no internet, and even the SIM works very rarely. So in this particular case, what we do is that ASHA workers and our own volunteers generally have between 160 to 200 odd patients who are there, who are potential patients, which have TB potential. So what we do is that we, prelim test is definitely chest X-ray. So we do 200 chest X-rays. Now these 200 chest X-rays, yet they are taken, one X-ray is taken in 1 minute or 2 minutes, but it takes ages for radiologists to see each of them. And we can't afford to have 4 or 5 radiologists going there. And just one more aspect which is very important is that all of these 200 odd patients are like daily wages workers. They can't afford to be standing there for the whole day because their daily wages are getting impacted. Now, we have serious shortage of radiologists. This is the case not just in India but worldwide, but India has a more peculiar problem of this shortage. So earlier, radiologists, if they have shortage of time, they used to do WhatsApp of these X-ray, pass it to the doctors in the Medanta, and then, all kind of communication happens. Now, what we have done is that we have a box, which is an AI box in the same van. As soon as the X-ray comes out from the modality, X-ray modality, a report comes from the AI box, TB, potential TB or no TB. So what we have now is that only 40 odd X-rays to be seen by the radiologist. So just imagine that, see, AI, which we are now taking it, is not for hospitals like big names, but just imagine that kind of wonders it can do in primary healthcare where you have only one physician. He's representing 30 odd specialties on one single foot. He's standing and attending 200 odd patients. So this is one example which we think probably will take to the next leap. The other example which we are doing, other product which is in the production is that we have, and this was one example which, he rightly mentioned with respect to COVID. All doctors were impacted, hospitals were impacted, caregivers were impacted, and there was a solid need for us to have readings of ventilator and infusion pump, which are there with respect to ICU beds, to be taken outside the ICU. The simple reason is that you can't have a senior ICU doctors 24/7 in the ICU. And there was a need for us to get real-time information, almost real-time with a lag of 5-10 seconds into the handheld device. Now, what we do is that in all the hospitals, you have lab, radiology, consult notes in the handheld device, but this waveforms were not there in the handheld device. What we have done is that we have connected these devices. So one example is that now doctors 24/7 don't have to, it's a push technology and it's a zero footprint. What it means is that nothing is going to store in the handheld device, so all privacy concerns are taken care. In this particular case, so whenever there is an alert, doctor doesn't have to call a doctor on duty, whether it's a resident or a consultant, to figure it out what's going on. He has each and every information in the handheld and he can instruct the doctor. Just now extend this to tier 2, tier 3 cities where we have the capability, resource capability to put ICU infrastructure. We don't have ICU doctors. Country have serious shortage of ICU doctors. Now what we can do is that we can put the infrastructure and on a simple broadband or a bandwidth, we can have those information available to any doctor who is an ICU doctor in any large hospital. We are already experimenting with 2-3 smaller clinics which are like 30 bed, 40 bed in UP, where information is getting disseminated to ICU doctors in Medanta, Lucknow. So these are two examples which I think, have definitive long-term impact as far as the healthcare is concerned in India, where there is a serious shortage of doctors. Two examples which I took is of the radiologist and the ICU doctors.
That is absolutely fascinating. I mean, the innovations that happen, I feel that there should be more platforms for us to share some of these innovations that are happening. I'll ask Mr. Prashant Singh, who's a CIO at Max Healthcare. What are some of the innovations that Max has worked on?
I would like to touch upon a couple of activities and projects which we are working on right now. So recently, as a vision, basically we wanted to have the one single longitudinal patient record coming out of various underlying systems actually which we had. But the challenge was, some of the data which was absolutely structured, there are a lot of data which was semi-structured or unstructured also. So what we have, gone ahead and adopted the data lake technologies on the cloud, and we have created a repository called healthcare data, which is connected to various underlying systems which we had, and implemented a lot of algorithm on top of it, which included AI algorithm and a lot of OCR technologies actually which were also used. Although the work is still in progress, basically we are still working on a lot of unstructured data, that how can we actually structure them in a way that it makes a little more meaningful from that point of view. But as far as the status goes on, basically, to great extent, the longitudinal patient record, which is coming out of various core system as well as all the ancillary system like, patient feedback and maybe LIMS, RIS for that particular matter. So that is all, coming onto one single repository so that we can absolutely leverage the data which is coming out of the data lake for a lot of clinical research project which is happening at Max Healthcare. So this is a great example, a kind of transformation actually which had happened from the data transformation point of view. So that is one example. The other example actually which we have tested a great technology which is working in the field of patient monitoring. So what it does is basically, it is of course based on a lot of AI algorithm which has embedded into it. So there are a lot of patches actually which are put on the patient body, and there's a continuous critical patient data which is being captured and sent to one single hub, which has been kept in the patient room or wherever in the reach of say 20 meter or 30 meter for that particular matter. So there are a lot of early warning signs, including news and news, which gets out of it, so that the doctors can take the predictive analysis based on this particular thing. So the results are absolutely encouraging, and there are a lot of in terms of the measure of success and the KPIs which we had envisioned, in terms of reducing the ICU loss basically. So that makes a hell lot of difference in terms of the getting more capacity for the critical patients in the tertiary care setup. So that was one of the the objective actually which we have envisioned, along with certain other objectives in terms of can we reduce the code blues in the hospital if I get the early signs of early warning signs of the patient coming out of a lot of critical parameters. So these were the few criteria actually which really worked well, and we are looking forward for that particular technology to going further.
Right. Yeah. I think it's very heartening to see how hospitals are investing so much in digital health, because all of these mechanisms that both of you all spoke about, they're not really visible to the patient. No one really knows that hospitals are working in the back end and trying to improve quality of care and improve health outcomes through these embedded systems. And it's, a huge round of applause for both organizations for taking that step. So we spoke a little bit about teleradiology solution at Medanta, and we have with us Mr. Kishore Joshi, who comes from one of the first starters of telemedicine and teleradiology in India, TeleRad Solutions. I have visited your organization almost 5 years back when, digital health was not so popular. And even then, y'all were doing some fantastic work. So I would love for you to share some of the work that you've been doing over the years.
Thank you so much, Arun. And thank you, Data Leads, for having me on this panel. Absolutely. As my colleague here, Rajiv, also mentioned, that I think there is a biggest shortage of radiologists across, not just in India, but across the globe, and much more acute here in India. But it's like when COVID happened, a lot of people told us that your company was like prepared 20 years back for this, right? So it was just like a absolute way of enabling the whole digitization done, right? Per se, teleradiology has been like a torchbearer or flagship for all telehealth initiatives, because one of the reasons why it became that way is the entire data is already in a digitized platform. So it becomes much more easier for transmission, interpretation, and dissemination back. So that was one of the basic advantages, and we continue to benefit from that. I think some of the areas that we worked in the last 2, 3 years or 5 years, and we continue to work are, one is how do we reach out to large parts across the globe? Because what we are talking of is an urban area where you have all these scanners and all of these technologies and high-end packed solutions. But what about rural India or rural parts of Africa, Southeast Asia, where there are just no access possible? They still work on primary healthcare centers with just an X-ray system. Probably a lot of them are legacy X-ray systems. So in between 2015 to 17, we came up with certain programs along with NHSRC, and understood and devised and demonstrated that a simple handheld phone actually can be used to capture film X-rays, and actually can be transmitted. So we developed a technology which allowed for JPEG images to be sent across in a platform that converted into DICOM files, which allowed for radiology interpretation. So that solved a lot of problems. So now what happens is, maybe a lot of states have, in India, for example, we have a lot of legacy systems, and trying to convert those legacy systems into CR systems or new ways of digital X-rays, it's going to be an enormously expensive affair. While we can do that progressively, which is where we would end up with, but I think to solve an immediate problem, we can therefore allow for these kind of technologies to be utilized, and that's what we did. So the government subsequently in the last 5 years has been putting out or rolling out this teleradiology tenders, which allows for these kind of platform technologies to be used, which doesn't necessarily focus on the CR systems and all, so which brings in the access part very much easier. Apart from this, we also worked on or are working on having our own AI solution. So we work different AIs based on what we do currently. As teleradiology solutions, we work in nearly 150 hospitals, 23 countries. We do more than 3,000 scans per day, which is what we do. Till date, we did more than 6 million scans, and we focus mainly on the emergency as well as some of the non-emergent work. So we have identified certain AI solutions which would probably enable us to make it more efficient, make it more effective for our radiologists, and also ensure that the quality of radiologists in the terms of interpretation is well provided to them. So we work on the AI part of it. We also work in the pharma space, by the way. As a company and a group, we also work in the drug discovery part where there are a lot of clinical trials. And we realize that a lot of this work requires quantitative radiology, which is a an area which probably requires a lot more time, effort. So we're also working on certain tools which allows for automated 3D segmentations. Many of the doctors here would understand, the body parts requires a lot of segmentations. If we can look at those, that helps the pharma industry to probably look at the clinical trials in a much faster way. So we're working at different various ways. The other area which we also worked upon in the last 5 years is, as the data privacy rules, the GDPR, and all of those became quite complex and became part of the compliance requirements. I think as a part of our business requirement, it became imperative that, while it is important that the patient name is known to the physician and the radiologist who's reading it, some countries would opt for very stringent rules. So we came up with what is known as a patient security framework DICOM gateway solutions, which allows for anonymization as they transit the country, and once it hits back, it de-anonymizes, and then the patient name becomes available. So all those kind of work has been happening.
That's excellent. And it's so great to hear, how an Indian company is leading the digital transformation, not just in India, but also outside of India. And that's...
Yes, absolutely. We cater to more than 90 plus US hospitals, including the big names, including the Johns Hopkins and the UPenns and all of those.
That's so
and
fantastic.
all of them have adopted these models because they realize there's a value in all of this.
Right. So, and that also shows how digital health is a global subject, right? So, any digital health that's developed in one country automatically benefits others. We also have Mrs. Srinath Honavali, who's, I would say, a very rare, comes from a very rare background. We don't see a lot of private sector companies working in preventive healthcare. Could you elaborate on some of the work, the digital health work that's being done in preventive health? We saw a lot of preventive health being discussed in the previous session also. So I think it's of utmost importance, and I think digital health does give an opportunity for other private sector players to come in.
Sure. Thanks, Arun. I think, as you said, we are actually a 4-year-old health tech startup, right? It's a very different audience here with a lot of people from established hospitals. And, but the good thing, as Arun mentioned, we are working on things that the earlier panels talked about, right? They talked about preventive wellness. They talked about awareness in schools. They talked about health records. They talked about AIML, right? We are doing all of that, and we are just a 4-year-old startup. So when I got into the startup environment after 20 years in corporate world, I was looking at what can we do with technology in healthcare and education. And we came up with this Healthy Kid program. What is a Healthy Kid program? We are a assisted personal health record system provider for the schools. We go to schools, we do health screening for both physical and mental wellness, maintain them in digital records, also provide them counseling and awareness workshops for kids, teachers, and the parents, right? All health literacy we talked about in the previous panels, we kind of address all of that, making sure that the misinformation, the disinformation is kind of avoided. And as we talked about, catching them young is very critical. And by building this health record system for longitudinal data, allows us to do more than a kid stays in a school for 12 plus years, right? We are able to get that data not from a patient-centric, but from a consumer-centric, as we talked about earlier, right? So we are able to bring these things from a technology point of view. On top of it, to make it interesting, being a techie myself, what we focus on is integrating non-invasive devices in our screening process. So when the kids come into the school and they talk about health screening, they're really scared, or they don't want to get pricked. We integrate all non-invasive devices, both homegrown as well as built across the world, to ensure that the screening is much more accurate as well as reliable. And to make it more fun and enjoyable for the kids, we also have developed games. The kids actually think they're playing games on a tab, but actually we are measuring their mental wellness, memory, attention deficit, etc., etc. So this aspects of automation, AI, in non-invasive devices, cloud-based health records is all that we do. And again, as Arun said, it's a pretty rare that private sector is doing this. We need all the help to actually make it happen. Thank you.
Right. So thank you so much for that. So I'll pose the next question to you itself. So preventive healthcare programs are an excellent way to engage with the community. And the onus of doing preventive health programs has largely remained with the public sector. So do you think digital health opens up this opportunity for more private sector firms to enter, preventive health and make it a something that they can have a return on investment on?
Great question, Arun. I think as very clearly, preventive wellness in private sector, obviously we need to look at ROI, but we can look at different business models that is possible when we look at whether it is Fitbit or your Apple Watch or anything else, right? It is possible to come up with different business models which can still be a good ROI. When we say that, we actually go to the schools and NEP talks about health screening every year. So we work with the school management to ensure that our basic costs are taken care of by the health screening. But the data that is available, obviously through anonymous ways, we can do a lot of analytics, which is very valuable for the entire other private sectors. So we will be able to bring in pharma, able to bring in marketing for health foods, or it could be toys, or it could be games, anything that is healthy. We are more than willing to collaborate to bring in the market to be able to ensure that ROI is there.
Right. Thank you so much. And it's very promising to see, a private sector firm working in preventive healthcare. I'm going to come back to my earlier conversation about, digital health being a global topic. And my question is to you, Kshitij. Philips is a global organization, although it has a very large presence in India. And when we talk about AI and ML-based solutions, a lot of it has been produced from outside of India, using data from outside. So in your view, how important is it to contextualize some of these solutions for India? Is it necessary at all? And another question would be, what do you think is the future of AI in India? Do you see it complementing or replacing some of the functions of a healthcare provider? So this is something that's often debated topic of whether AI will replace the physician. So what are your views on that?
Let me take the second one first, because this is a question that a lot of radiologists have asked us. Will AI replace radiologists? The answer is absolutely no. Autopilots did not replace the pilots. But what's going to happen, and let's put the position first, okay? AI is not a solution in itself, okay? And I strongly believe that AI, or for that matter, any technology in healthcare, has to work for the people that it touches, which is the healthcare providers, which is the patients. Technology in itself will not make an impact till it touches at the right chords with the healthcare providers and the patients. And I think that there are three fundamental ways that AI is going to transform healthcare in the future. The first and foremost, I think that was touched upon by Mr. Rajiv Sikka as well, which is about how can AI help drive better clinical outcomes at a lower cost and reduce the burden on the clinical work manpower and the limited manpower that we have. We spoke about the shortage of radiologists. How can we do that? And that is one piece which is going to happen and which is going to happen even better. For example, we spoke about the X-ray for TB. And I worked a little bit of time in my Middle East as well. There, for the visa purpose, there is no doctor who actually signs a chest TB report. It's all done by AI, which has got a 98% accuracy versus a doctor's accuracy of 96%. So it's very well accepted there. And I think that's the way it is going to happen, right? The pathologists today sign off the reports. I don't think they are doing the titration themselves even today. That's a direction in which both radiology, for that matter, cardiology, the quantitative part of it with the machine learning and AI is going to actually help them drive better clinical outcome. That's piece number one. The second piece is AI is going to drive operational efficiencies within the hospital. And it could be coming in the form of how do we integrate the data, how could we, even for example, like how can we get AI-enabled preventive maintenance done for large equipments so that you could do your better planning. How could you improve, let's say, your radiology department workflows? It could be all AI-enabled. And countries and hospitals are already doing it. And the third part of it on the AI touches the consumer. And I think that's a very important one as well. And I'll probably give you a real example which will make it the point very clear out there is Philips, for example, has got a sonic toothbrush. Okay, and we know from a healthcare perspective, your oral healthcare is a great parameter of how your cardiac function and all other things are kind of correlated. Have we mapped out completely, connected the dots? The answer is no. But today, with the sensors put on that toothbrush, there is an app which tells you live, hey, you missed out on that molar out there, you need to clean it up better. Now, this is where the future is already arriving. And that is the kind of a longitudinal data that my colleague was also talking about, saying that how do you marry the data when you are healthy on the preventive side to the time you reach to the hospital? See how much power can you give to your clinicians, because when you land up in the hospital, you see the data only for that point of time. The ECG that is not showing, is showing an aberration. I'm sure before you landed up at that situation, there are a lot more things over a period of time that have happened to you. How much power does the clinician will get if we are able to synthesize the data and give it to the clinician, and how beautiful it will be when your data that you're giving it out actually comes with an early warning signal saying that, hey, you seem to be falling out of line. Can you start taking care of yourself? Can you get this test done? And that, I think, is the future of healthcare, and how AI might not be in the next 1 year, but definitely over a period of 8 to 10 years, you can clearly envisage how healthcare will get impacted, both on the consumer side and on the provider side, with this AI and ML coming up.
Thank you. So speaking of data, I'm going to direct my next question to Mr. Rajiv Sikka. India has always had a problem with good data. There's been a lot of complaints on how they're unstructured, they're not scientifically collected. Now, but with the personalized health records coming in and increasing popularity of digital health lockers amongst the patients, there's going to be a lot of data coming in. So, in your opinion, what should be the things that we look at cautiously today so that this can help the digital transformation? That we collect good quality data, we collect the right data points so that we don't collect data just for the sake of collecting data, but we collect data for impact. So what are your views on that?
Sure. I think the challenge in India is that we are not collecting the data, but since you have asked, there are two aspects. But before I go into this, remember a couple of years back, we have this issue of number portability. If you have a Jio phone or an Idea phone or an Airtel phone, signal is not good, you can't afford to have the same number and change the carrier. Okay, so that's a number portability. According to me, if you have basic information which is getting captured, a patient comes to a hospital in a daycare or in a OPD or IPD or any diagnostic test, he carries a bundle of papers or some films or some CDs. And now, God forbid, if you have to travel for a day or 2 days, you can't be carrying all these papers with you. So one thing is that all this information, technically speaking, should be there in handheld device, which in a portal you can download it, and all the hospitals have that information. That's equivalent of doctor portability and also equivalent of hospital portability. So which means that, tomorrow you don't like the doctor, you go and you have. So that's the basics. We have moved away from those basics. What we are doing is that, again, I'm going to take a very practical example. In a typical ICU bed, if a patient has multiple devices, including ventilation, ventilator, infusion pumps, and what we do is that we collect 20,000 data points per day, per patient, per bed. And this is huge. What we are doing is that we are not doing much as of now. We are doing postmortem kind of a stuff, which means that if a doctor comes at 11 o'clock at the round, what he has to see is that he sees a large chart which nurse has, that at 9 o'clock these were the readings, at 11 o'clock these were the readings, at 7 o'clock these were the readings. And God knows whether the reading was taken at 7 o'clock or 7:10 or 6:50, or whether the readings which was there on that are correctly monitored or not, or put in the paper. And then doctor has to turn a knob on the bedside monitor or the center monitor to see what was the trend. It's a very cumbersome. No human brain has ability to correlate 5-6 parameters simultaneously. What we have done is that we are plotting a graph, and based on the subjectivity, which is again driven by ICU doctors and physicians, we say red amber zone of the patient on the time horizon, on the time scale. So what it means is that 11 o'clock, patient is in the amber as per the, and doctor is definitely seeing the parameters. What was the condition at 10 o'clock? What was the condition at 9 o'clock? And it's a continuous parameter. So doctor can figure it out whether the patient is going in the right and wrong direction. Ultimately, we aim to figure it out what's going to happen at 12 o'clock noon, what's going to happen at 1 o'clock. That's something which AI and ML is going to do. All of this information is getting captured in a big Hadoop cluster. It's a costly proposition, but I think it's worth investing because we want to come out with a model by which we can predict sepsis. Sepsis is a condition by which patient go into a systematic organ failure, and each 1 hour of delay in sepsis prediction has a 14 to 15% mortality rate. These are published figures, you can Google it. So that's the power of data, but whether we have reached that stage, answer is no. Whether we will reach that stage, answer is definitive yes.
Thank you. I think Kshitij wants to add.
So I just want to add, you're absolutely right, Rajiv. This is the direction. By the way, the problem that you're trying to solve has actually been solved by Philips already. There is something called as EWS, which is the early warning system, where when the onset of sepsis, 7 to 8 hours in advance, is actually flashed out. So, and this is completely based on AI ML one, and we have done close to 3 million kind of a data analysis already done, where the engine is already running and saying like, and that is where the healthcare is going to change, because you're absolutely right. It's not possible, and if you're, let's say, 50-bedded ICU right now, 220, okay, I know now, Medanta, how many ICU beds it has, but let's say 220. For one person to go and look at 220, it's impossible, right? But if you have, let's say, 10%, let's say 20, 25 of them, which are actually showing red and showing an early warning signal, you're making your ICUs far more efficient, the doctors far more efficient. And this is where the AI is going to help it. And I think like technology company like us is already working on those solutions already.
That's fantastic. And I think this platform of sharing is very important. Now, coming to data again, the major concern and a lot of debate has happened on data privacy security. And so Kshitij, what are your views on that? How do we build trust amongst the patients? Because for these digital health interventions to work, the trust is the most important part.
Yeah. Let me first start with saying that the digital transformation of healthcare is inevitable, which also comes with its own set of risks and the new risks, which is around the data security, the privacy piece of it, and I can talk about a little bit about what Philips is trying to do here. What we are trying to do is, and this is very, very important that we understand that there was a study actually which was done, which found that the healthcare data has far more value, and this is a global study, has almost 10 times more value than your credit card information data if it is taken away. That's a kind of a value that you can actually generate. Not a good measure, but yeah, but this is a global study, so we can talk about it, how and why it is important. But important thing is like, the more the world gets digital, these two issues will keep on coming and haunt us if we are not taking the right precautions. For companies like us, we start by saying, not by just saying that, okay, our product, whichever it is, we start with, from a design perspective, saying data security built in. That's just a starting point. What's also important is because your device is going to be having interoperability with several other devices, you have to look at what is your device going to get used along with various other in the ecosystem itself, which is right from network, from other devices that will be sharing it, the data, etc. And that is very, very important. And I think these are the two risks that we have to be cognizant of. And I know there are two big healthcare providers on this panel as well. The amount of sensitivity that we see on the global frame about these two issues, I see a limited cognizance of that, at least in the Indian healthcare paradigm today.
Right.
And I think all of us need to recognize that it is very, very critical.
It is. It is. So, and you know, as you rightly said, we have a lot of very important healthcare providers. Another place where data security has always been a threat, or data breaches have always been a threat, is telemedicine and teleradiology. And, you know, I think telemedicine systems have been constantly innovating to prevent these data breaches. So, can you speak of some of the innovations that we can, you know, take up to prevent such data breaches?
Right, as Kshitij mentioned, absolutely, that, you know, as healthcare transcends towards more digital, there would be a lot more data available, and it would be available in various cloud formats, which are more accessible. Hard copies were never accessible. You had to actually do a burglary in the hospital to get the data. Now you have digital burglaries possible, right? So there are various means by which all of this can be extracted. So what teleradiology solutions is, as such, what we believe is ensuring, as right Phillips also said, that, you know, data security has to be built in. So the services provided has to have all of the security measures which are typically required in terms of data security, control, access. All of these have to be of paramount importance so that very limited or authorized users only avail those kind of data, right? In addition to that, as a part of this whole data, as he rightly also mentioned, one more aspect, data is oil. It's got value. How do you also ensure then that this data is available back to the original owner of the data? It does not get disseminated or to somebody else, or does not get broken down. So I think as companies evolve, we also evolve in having more infrastructures and hardwares and all of that, which becomes much more compliant. So like high availability networks, then access control mechanisms, which are of the very high end, that allows for very secure protocols. Some protocols which now people follow, all of us do Paytms and Google transactions. So multi-factor authentication has now become a standard. How can we ensure that the multi-factor authentication also becomes a standard in accessing global health records? I think that is the mechanism by which it is moving forward to. A lot of, in the radiology world, there are already PAC systems which are available, which provide for these kind of multi-factor authentication. Apart from this, I already mentioned that as a company ourselves, which is dealing in massive data across the globe, we built our own patient security framework protocols, especially on the DICOM gateway side, because we realized that it is important that none of the patient information gets leaked out. Then there are concepts which we comply to, which is known as data in transit, data in motion, and data in state which is not in motion. So all of that becomes an important part and adhering to it. But beyond this, I think we also need a compliance framework which ensures that the companies who are dealing in these kind of activities or businesses or any kind of public health are also having a same framework where they comply to, because that exactly is currently lacking in some of Indian scenarios. Today we might say that, you know, we are HIPAA compliant in India. What does that mean? There is no HIPAA law in India, by the way. Whom am I going to take to the court if something happens? There can be thousands of breaches happening on a day-to-day basis. My colleague Rajiv here mentioned that, you know, they were sending this WhatsApp message text. And I know this happens very frequently, whether it is for radiology or for pathology. What if your son, daughter accesses that? Do you consider it as a data breach, even if it's WhatsApp? You know, I mean, so there are so many things which are important. And I think all of these need to be considered in a holistic manner and ensure that we have some rules and regulations which probably meet current set of challenges and keeping in view of our current norms. While there is always a debate and the jury is still out on that in terms of whether we want to go the whole GDPR way or we still want to have a little bit of between what US does. For example, when we do our business in US, thankfully, we don't have to anonymize the data. But if we were to do the same thing in the European market, we would have to completely anonymize. The same thing we do in the Middle East. I think we'll have to look at what India wants for its own people, not necessarily look at what US does, what Australia does, or what Europe does. We have to look at what we want to protect from our people and ensure that we take the solutions which are correct for the time. And we might reach what these guys have reached, but that might take us a little more time. But that's more important part of it. That's how I look at how the data security and the framework needs to be done.
No, absolutely. I agree. There's a huge need for frameworks in India. And I think the government is working on such regulations, and it's going to come in place soon. Speaking of data breaches, in hospitals, it's even more complicated. There are so many providers at play. So my question is to Prashant. How do you manage this particular problem in hospitals, the data breaches and the data security concerns?
Very scary subject. But I would say basically the entire thing depends on the kind of framework actually which you are adopting. So the entire process, starts with the kind of maturity assessment and knowing your environment, as in what is missing in terms of tools and techniques, as well as the processes actually which should have been in the place and which is still missing. So I would say the journey starts with assessment, and then you have the visibility of what all tools which are still missing, and it depends on the kind of business you are in. Basically, it might be different with the healthcare vis-a-vis some other industry for that particular matter. And then comes the tools, the processes actually which are still in which are still adopted in terms of doing a lot of practices on the ground. Like for example, very simple example, like for example patching. Now everybody understand that patching is important, but you have to have some framework actually to understand whether it is happening in the right way or not. So that is number one. So number two is basically, apart from all the tools and technology, you still can't claim that I'm absolutely safe and nobody can enter in my environment. So there comes the various you can say loopholes actually which exist across the network, not only from the technology point of view but also from the person or employee point of view. So as per me, there is a entire need of having the cyber security awareness to be spread in the organization, which might involves a lot of gamification of the phishing attack simulation, and there are many other techniques and tools which are prevalent in the market and from the technology point of view. So number three is basically, so earlier actually we were using say antivirus tools. Now the technology, the way we are progressing, the dark web is progressing by 2x speed. So you have to be really cognizant of the fact that what all new technologies which you have to adopt. So you have to keep investing in order to safeguard the environment from that particular point of view. So going further basically, and in spite of having all of this, basically you have to have the business continuity planning also, so that there is a concept called zero-day attack also. So and there is nobody who is aware. There is no definition which is available. If you are impacted, the only thing which is in your hand is you can just only contain the infection, and you can just stop spreading in the entire this thing. So that is another thing basically, and the only thing which can really help you in terms of what kind of backup strategies do you have, whether it is on the server side and of course on the endpoint side. And very well, I think some of the my friend said that multi-factor authentication. So we have implemented a lot of technologies around multi-factor authentication and the privilege access management, which can really safeguard not 100%, at least 99%. Right.
I just like to add one more point here. Like he said, mentioned about certain aspects of in the hospital. We see, being global in nature, we come across hospitals across various parts of the world, and I find it very interesting that the developed economies, especially the North American part of it, the legacy systems play such a big role there that they sometimes fear changing, and the infosec becomes so critical for them that they delay as much as possible in adding up any new systems, because they just don't want to undergo a massive audit or the way it functions, because the burden of compliance is so very high in these countries that it becomes like a generational gap But to that aspect, I think India is much more favorable status because, our hospitals are adopting these systems now. So I think we might be able to leapfrog some of these, just like we did in the telecom space, where, people still had the landline devices, where India went into the 3G, 4G. So I think to that extent, I think we have the ability and we have the momentum to get into much more better data frameworks.
Right. So, in the interest of time, just one last question to Srinath before we go for questions. So, we've spoken about how the private sector has been working on so many fronts. How can the private sector help the public sector? This is my question to you, and very short. How can we share some of the best practices in the private sector to the public sector?
Yeah, so basically, there are lots of technologies that the private sector is building that we are investing, the investment coming from all over the globe. So the best way I would say how we can collaborate is the same technologies can be made available to the public sector at a lower cost or for CSR. In that way, we are able to bring in the technologies, which is AI, ML, data analytics, and make it a bigger impact to the society by ensuring that the public sector also and the rural communities can make use of the technologies.
Right. So I think sharing is important. Right. So any questions from the audience? There were a bunch of other questions that I wanted to ask, but I think in the interest of time, just jumping to the questions from the audience. Any questions from the audience? Yep, sure. I think there's a gentleman there.
So my question, I'm Alok Arunam, I'm representing JPL South Asia. My question is that there are a bunch of problems and use cases that you have told. Much of it is related to efficient diagnosis and also process streamlining. But my question is that how exactly these problems are being prioritized in-house across different organizations, and have you, while you are doing this problem prioritization, are you also looking at some of the problems which are generally very good for the public, like the lactation management system for newborn, which are very pressing problems, but the solutions are not being looked into? A use case would be that Wadhwani AI is also working on effective screening of SAM children. So some of these use cases that you think that your organization can work towards.
Okay. I can take that question perspective from a radiology perspective. I can state that we work with some of the, for example, mammography is one area, or breast cancer screening programs, where we work with some of the NGOs who are doing screening across in southern part of India using mobile vans, and we provide them the mobile, it is a mammography is equivalent to an X-ray, by the way. So we do have an AI solution which provides them a triaging kind of a mechanism. Because typically what used to happen earlier, that these buses or whatever, these mobile vans used to go, they used to screen a lot of people across in various states, and weeks and months would be lost before some radiologist actually reads the data, and that poor woman probably has gone into a next stage, or she doesn't know or what intervention needs to be done, right? So what now happens is we are provided with the mammography triaging solutions, which allows them to actually triage it there, and also a platform which allows them to send that X-ray back to a radiologist. Now, in this case, it happens to be us, but if they have centers, like for example, if Medanta or any of the hospitals are doing on their own, they would be able to have their radiologists read it instantly or in the next contemporaneous manner as fast as possible. So which means the interventions can be much better done. So that is one sort of an area which is being probably provided using AI/ML technologies. The other, of course, in our organization, we use AI very, very strongly in prioritizing in what is known as red, amber, green mechanism, because we are providing stroke programs and stroke solutions. So we also wanted to talk about, when he mentioned about how do we work with public organizations, we also have a program with AMTZ, Andhra Pradesh MedTech Zone, which we recently announced, where we want to we are into collaboration with them, where we want to probably set up kind of eventually India's first automated stroke centers or one of those kind of stuff, which would and this would be primarily targeted towards the government hospitals. We don't have stroke centers per se in India. The reporting in India still takes 4 hours for a stroke. The protocol in the US that we currently meet is 15 minutes of stroke reporting. I think we have a long way to catch up, but we can do that using technology.
Right, I think.
And on the prioritization framework, this is a standard framework irrespective of industry verticals. It's a, on one axis you have what is the impact if this is done, and how easy or what is the feasibility of doing it faster. So this is a typical framework. If something falls in the left-hand lowest quadrant, this is the one. Highest impact and easy to implement. This framework is like a very common framework.
Right. Are there any other questions? Okay, there's one question in the back.
I would just like to ask, how are you planning on addressing the problem of privacy when it comes to AI?
Yeah, please go ahead.
So first of all, any information which goes into the AI algorithm doesn't have any identifier for the patient. What it means is that we definitely have gender and the age, because that's very important with respect to clinical prediction. And other stuff which we have been doing, at least for the X-ray program, which is already in production, is that we did a parallel run, which is a blind study between the clinician report and the algorithm report for roughly 18 odd months on multi 10,000 odd X-rays. We do more than 1,000 X-ray per day. So what we do is that for anything, there is a traceability, which means that if AI, for whatever reasons, has given any positive or negative, that state is recorded into the ecosystem of the software itself, which means that if radiologist has said A, while the algorithm is saying B, we go back to the software and figure it out what are the traceability points for which the algorithm has said B and not A. So then there is a consensus which happened between doctor and the software development team, and eventually, we fine-tune the algorithm to reach so that there is no ambiguity. That's the general principle. I'm part of the CI-led Niti Aayog AI platform in the healthcare in India, and that's the basic principle which we have said that AI, like you have, device guidelines for healthcare, but do you have guidelines for AI algorithm which are nothing but a diagnostic in nature? And this is one important part which we are, ensuring that traceability is there, because this is to address public interest in large rather than the radiologist or the physicians or the healthcare providers.
Thank you. If there are no more questions, before we end the session, I would like the speakers, to end on an optimistic note, a half-a-minute prediction of what the digital health transformation of India is going to look like in the next 5 to 10 years. We'll start from that end and move here.
Okay, I'll be quick. With all the plethora of problems that we have in terms of physical infrastructure, doctors, all those kind of things, that's not going to solve for the next 20 years, except for the technology that we have to embrace.
3 trends according to me. One is that mobility is going to be the new norm and be the first norm in healthcare tech. Second is that care away from the hospital is definitely going to play an important role as we move forward. And the third, which is my own personal belief, is that done is going to be more better than perfect. You can't wait till infinity for screening and diagnostic devices to be 100% perfect when you are sometimes at the mercy of quacks in tier 2, tier 3 and villages. So have some mercy on these AI algorithms. They will be definitely better than, so don't wait for perfection. That's my third.
Just put it simply that, I believe that AI-enabled providers, organizations would definitely replace non-AI-enabled providers and organizations.
So I would say AI in conjunction with a lot of data analytics and IOMT basically is the future. And I think we have recently seen a lot of examples like diabetes retinopathy, and it really worked well. I think that is the future which I foresee.
I think as he said, like I see a personal health record system for everybody with analytics that can give you customized notifications for all your health needs.
That's excellent. I think pretty much everyone had the same prediction. I think the artificial intelligence complementing human intelligence would be the future, I guess. So thank you so much for the wonderful insights and sharing your experience with the audience. I hope it's been a learning experience for everyone here. It's definitely been a learning experience for me. Thank you again, and I think we'll wrap that session. Thank you so much.
Thank you, dear panelists. Thank you, Arun. For the final panel discussion for the day, I now invite Dr. Dinesh C. Sharma, veteran science journalist, Aparna Sanyal, National Award-winning filmmaker and producer, Dr. Tanaya Narendra, Doctor Medical Education enthusiast and content creator, Dr. Shreya Gupta, founder and CEO at Doctor's Circle. This session is moderated by Surbhi Kaul, digital journalist at BBC.
Hello, everyone. This is the last panel of the day. We're in conversation with content creators here. We have two doctors here, Dr. Shreya Gupta and Dr. Tanaya. You may know her, some of you may know her better as Dr. Cutress from Instagram and her engaging stories and reels on Instagram. We have with us a National Award-winning filmmaker, non-fiction filmmaker, Ms. Aparna Sanyal. And we have with us the veteran science journalist and PhD holder, Dr. Dinesh. So welcome, all of you. Pleasure to have you here today. And to start the discussion today, I would like to go to Dr. Tanaya first. You are working in a highly competitive, it's a very cluttered environment on social media. You're competing with anyone, basically, who has a smartphone, and you are battling misinformation, you're promoting safe health practices, and basically trying to promote public health literacy through your content. So I'd like to know, how have you created this reliable and highly followed personal brand? And how have you used audience engagement as a tool to promote this?
Okay. Thank you so much for having me. That's a very interesting question because of the way it's been phrased, because you're very correct in saying that anybody with a smartphone can go on and create content which is highly engaging, possibly full of misinformation, but very well followed. And I feel like that's the biggest challenge as doctor content creators, because there's so much that can get lost in, nuances missing in 30 seconds or 60 seconds of a reel or a short video. The nuance is missing, you don't have any credibility, you don't have any way to check the credibility of this information. So I feel like one of the things that has been very helpful for me particularly in building my own community was the fact that as doctors, we have a very strict hierarchical relationship with our parents, with our patients almost. We unfortunately, the way we've been trained, we don't respect patient autonomy as much, and we make decisions on behalf of our patients. And we tell them, like, I think somebody in an earlier panel mentioned that, you go to the doctor, they give you a piece of paper and tell you, ab jao dawai le lo, and we don't ask them, kya hua hai, किस चीज़ की दवाई है, क्या side effects हैं, nothing of that. So that communication is missing, that there's no two-way street situation happening when you're directly interacting with patients, unfortunately. And I feel like that way, social media has been great in democratizing that content and that information with its accessibility and its simplicity. So there's a huge space for doctors to come in here, and not just doctors, but, qualified individuals who have solid training in evidence-based scientific information and communication, and change the game, essentially.
So you mentioned the democratization of this space on social media. I'd like to know what your thoughts are about what we earlier discussed as these alternative medicine practitioners, as they describe themselves. They're not really doctors, they don't have MBBS degrees, or they're not registered professionals as in the sense we, some users might think them to be, but they have filled in a gap here. I think what you spoke about, sometimes the lack of empathy, or sometimes being in a hurry, a doctor is very busy, you're only human at the end of the day, and just connecting with the patient on a level, or dishing out health advice on social media in such a manner that it appears extremely friendly, extremely usable to the person at the other end of the smartphone. It's easy, there's no jargon involved. So how do you see this space? I mean, the gap that's been filled by them.
That's a very pertinent point, because this is something I particularly struggle with a lot. All of my content is around sexual and reproductive and menstrual health. And just to cite an example that I used with you earlier, there is no evidence to suggest that you should not wash your hair on your period. And yet everybody has heard that, you should only wash your hair on the 3rd day of your period, or don't wash your hair at all, or wash your hair to cleanse yourself because your periods are an impure time, or something like that. And I can go on and make content, and all the doctors can come on and make content and create information around this kind of topic. And yet there will be some doctors or some people from different thoughts, I don't know what the word for this is, but schools of thought, who will come and say that, no, it's actually bad for you to do this. And that leads to a lot of confusion in the minds of people, because what is evidence-based? We know what is evidence-based because we taught this is evidence and this is what evidence-based means. But this is not something that the general audience knows, which is why it's so important to make this information, like you mentioned, jargon-free, accessible. And this is where I see some collaboration with policymakers and government individuals who can step in and help us create a system of verification of the information that you're consuming, making sure that the source you're getting it from is an actual legitimate source. Maybe, I don't know, another blue tick on top of, maybe a green tick on top or something like that. This is an expert in their field or something like that. So it is quite a challenge. I don't know what the solution for it is, but it would be wonderful if, there's a lot of interesting people with interesting ideas in this room, if you all could come up with something that could help us tackle this misinformation and disinformation, this targeted, malicious disinformation wave we've had, particularly in sexual and reproductive health spheres and menstrual health spheres, that can help us and, get rid of these problems. Very interesting set of problems.
Thank you, Dr. Tanaya. Coming to the other doctor, you're a founder and a CEO of Doctor Circle. You're a doctor as well. And she spoke about the misinformation wave. I'd like to know, what about vetting processes? What are the internal vetting processes that a doctor would go on if you're as a content creator, or you're running an initiative that brings together so many content creators, your peers are pitching in your initiative. So what are the vetting processes? What do you think about the accountability here?
See, at Doctor Circle, we have more than 1,000 empaneled doctors who are coming up with videos in various areas. And as you rightly said, there is medical compliance, which plays a very important role whenever there is content going out in a public forum. Now, every doctor practitioner knows his or her role in, imparting patient education whenever he or she is in the public domain, or even when he or she is in the consultation room. They know that they are bound by a set of practice guidelines. So every practitioner follows the Indian medical regulatory guidelines, okay, which he or she makes sure that whenever there is content which is going out, he or she doesn't endorse any drug. There is no brand name endorsement. There is no medical equipment endorsements. If there is any OTC product also, there is a molecule name, which comes out. So there are teams, again, of licensed clinicians, who makes sure that this content is medically compliant. So that's a process which we are following in Doctor Circle. Each and every video which goes out, is vetted and is made sure that there is no endorsement as such. And that's how it is, yeah.
Thank you, Dr. Shreya. Dr. Dinesh, if I could ask you to come in here. You have been a veteran science journalist. You've seen the information landscape evolve from, information being largely disseminated through mainstream media, through newspapers, and now with the smartphone, with anyone who can have access to a smartphone can broadcast to a fairly large audience today. So what are your thoughts on this, and what are the tips or any observations you could talk about here?
Well, thank you for inviting me to this panel and share my thoughts. And I think it's a very good platform to have such conversations where people from different, sectors within the health sector come together. Like we had the previous panel, people from corporate hospitals. Before that, we had health communication, and they talked about health literacy, and now we are talking of content creation. So it's good to have conversations, because I believe that health is not something only for the doctors or the medical field to deal with. Health is something which concerns all of us in the society. And as health communicators or science communicators or communicators of any sort, we have a role to play, because experts are not good communicators all the time. And the job of journalists, or now content creators or communicators, is to translate that knowledge which is there with the experts in a language in which the common people can understand. So that is the challenge. And when it comes to health, it is far more challenging, because you're dealing with so many specialties, you're dealing with so many subjects, and the science is always evolving. It's not something what it is today, what we had 10 years back. Concepts change, new information arrives, new research comes, so one has to constantly keep oneself updated. So that's one of the biggest challenges before health journalists and health communicators as such, so that one has to be very much aware of. Coming specifically to this whole landscape of health information on social media platforms, I've been associated with mainstream media, as you said, for more than 3 decades, but as an observer, what I find, I'm going to present 2-3 points. See, there are 2 spectrum. If you look at what kind of health information is there or being dished out on all kinds of social media platforms, not just YouTube or Twitter and a number of them, there are 2 extremes. At one extreme, I find there is disease mongering. And I don't need to explain to this audience what disease mongering is. It is kind of medicalization of everything. You try to give a name. Suppose I have a backache. So instead of saying I have a backache, there is a medical name for that. And then you try to give a solution for that. So it's kind of a pseudo disease you try to create. There are a lot of syndromes, there are a lot of names given, and which are invented. So there is a lot of disease mongering happening through the videos and various kind of information which is being put out by different creators, so to say, on different platforms. At the other extreme are the miracle cures. Should just do a search by, I did that today morning, miracle cure. I got 1.6 million results within half a second or so, 0.4 second, and all of them were videos. I mean, I could scroll 10, 15 pages. So there's so much of information being put out for miracle cures. You know, we have so many chronic diseases, and half of them would concern cancer, infertility, and a whole lot of issues, stem cells, and there is a miracle cure for everything. So the other extreme is that. So in between these two extremes, you have doctors creating their own content. There are independent platforms like two of you are sitting here. You're also there. So there are people who are, creating health content from the mainstream media. Almost every newspaper or a television channel or a digital platform belonging to the mainstream or the legacy media has a vertical on health, right from BBC to Times of India. Everybody has a vertical on health. So they are there. So like this whole spectrum is there. Then in between there are also free birds who are neither doctors or nor medical professionals nor mainstream media. Anybody can put, as you said, anybody who has a smartphone can put out a video and call it a health video. And there are simple things like, I mean, you will find any number of them saying that यहाँ दबाने से acupressure से करने से eyes ठीक हो जाती है, and that kind of a thing. There are reels, there are, I mean, on an average, every smartphone user is bombarded with 5,000 messages every day. I mean, roughly half of them would be concerning health, politics, religion, depending on your, kind of interest. So that is the kind of landscape we have at present. And there are certain concerns, as some of the panelists have pointed out, about the credibility, the trustworthiness of the information which is being put out. So suppose I say, I'm a doctor, but I'm a homeopath. So can I go out and put out a video saying that I can cure cancer or treat cancer? Because homeopathy itself is under, being questioned in many countries. In India it is recognized, but several countries don't recognize it as a science. So can a practitioner of one stream talk about treatment of another thing? Those are the things. I think that's where, because unlike the mainstream media, there is no gateway of information where there are no fact checks, there are no mechanisms inbuilt. Like platforms do have certain guidelines, but how many of the creators or how many of the people who are putting out the videos or any kind of other information in any other form, are they following those guidelines? This whole thing about evidence-based and rational information or ethical information, should we promote stem cell therapy for everything when it is scientifically not proven? Or should we say IVF is the only solution under any circumstance? So those are the ethical, credibility, trustworthiness questions, and those are the, I think, major challenges in front of all creators. I'll stop here, and then maybe in another round I can take up on the solutions part of it. Thank you.
Sure. We'll come to the solutions part of it. And your message about disease mongering really resonated with me. There's also something about fear mongering, or sometimes, even doctors are helpless or could be helpless in that case. If we refer back to the early stages of the COVID-19 pandemic, and for example, I think at that time, early March or maybe in April, because the disease was unknown, even doctors were dealing with very new symptoms, patients coming up, and everybody was trying to get a sense of what the disease is actually about. There was a lot of fear. There was, some say decisions may have been taken in haste, etc. In that kind of a scenario, Dr. Shreya or Dr. Tanaya, would you like to talk about how, as a doctor, would you tackle such a thing? This initially, fear leads to panic, and panic leads to, I might want to check out everyone on Instagram and see what solutions are now in and what is everyone talking about. There was a surfeit of information, ginger and lemon water and God knows what all. So as a doctor, where did you stand at that time?
So yes, I remember when COVID came in, there was a panic situation, and videos we build are largely fueled by what users ask on the platform. So the panic was being sensed, right? The sense was coming to us. However, we were all constrained by, I must not say constrained, but we had to work within the framework and the guidelines, right, which have been put across by Ministry of Health and Family Welfare or WHO guidelines. As I said, whenever the role of content creators is to help the person out there, right, any user, to make sure that he or she is, comforted, assured that, okay, do not panic. And that's the time when healthcare providers, go out and, have to come out and make sure that they put across that, okay, this is just a viral disease, in 80% of people, this is not going to be fatal. The initial days were in assuring, the people about how COVID is going to, what it is exactly about, how it is going to shape up. And then in the later period came its treatment, right? Where in the earlier panels we spoke about how the treatment kept on changing, right? Whether it was remdesivir or before that it was ivermectin. So at various stages there were treatment protocols which were again conveyed to the public that do not do self-medication, reach out to the doctor, stay informed, don't panic. I think that's where the doctors had a role to play to assure people, to bring them out of the panic, because panic, once you're in panic, the disease actually, takes you back.
Yeah, and I remember some doctors, even virologists, in fact, came out and became content creators.
Right.
Whichever medium they are more comfortable with, be it through text on Twitter or on Instagram, etc. And they came out and they tried to bust the misinformation and calm people down about we've been dealing with viruses. At the end of the day, it's a virus, and this is how it should or should not behave. But this is about content creation. It's the immediate, it's the now, and it's very topical. But I would like to come in and ask about your perspective, Ms. Aparna. As a filmmaker, you'll connect the dots, you'll look at the larger perspective, often in retrospect, and then weigh in and measure, and sometimes what does it lead to with public health issues. You weigh in at a later stage, and then you connect the dots, and what's your perspective on this?
Yeah, thanks. Thanks, Survi. It's a pleasure to be here. I think we've basically done a lot of conversation today about health communication in a particular kind of context, which is that, there's something that's going on, and let's figure out how we can get what at this point seems to be the correct information, because that also keeps changing, and I think COVID has been a great example of, which has exemplified that. So in the here and the now, this is happening, how do we deal with it, right? And if you also go back in the past, you will see that public health information largely has been about that, right? So there's a thing going on TB or this vaccination, and then, there will be public information services and messaging that will happen and so on and so forth, right? Now, what that does is that you're constantly only thinking of health and health communication in the here and the now. I think what we miss, and perhaps that is where some of the problems begin, because like you rightly said, now everybody has a smartphone, right? And you can put out any kind of information. And what that is doing is that, again, it isn't the immediate. And sometimes others have a better response to the kinds of questions, because, a doctor needs to look at the guidelines, right? Needs to, you need to think about what you're putting out. But somebody else may not need to, necessarily sort of do those tick marks, right? Now, I feel that what we need to do, not just looking at, the sort of crisis moments, but what we need to do in the long run is to create a certain kind of culture of storytelling, a certain kind of myth-making, if you will. Because at the end of the day, human beings are emotional beings. We claim to be rational, but frankly, how often are we rational, right? So the irrational is very much a part of our mental and psychological makeup. Now, unless one invests in the culture or tradition of storytelling, where you're able to create stories around health which lead to more confidence, that also involves acknowledging when we've gone wrong. Little examples, I mean, each one of us, every Indian has a little mark here, right? How many of us know why we have that mark, or who? How that was
BCG
brought.
vaccination,
Yeah.
yes.
Who was it? Rajkumari Amrit Kaur. How many of us even know who Rajkumari Amrit Kaur was, the first health minister of this country, right? But where are those stories? Where are those aha moments? Now we all play games on the mobile and the computer, and everybody talks about gamification, right? We need to do gamification of stories, right? So something that I had shared with you earlier, right? This whole thing of ORS. We all know about ORS now. You're dehydrated, you need to take ORS. But how many of us know that it was pioneered by an Indian in the most, sort of challenging of circumstances in the refugee camps built for refugees who'd come in from East Pakistan in 1971, right? And the whole story behind that. That's a fascinating story. And, it's an Indian story. We don't even have to look at the West. And similarly, there are so many stories, and so many stories of missteps as well that we've taken. And I think it is reassuring for people when people in power or in positions of authority are able to come out with these messages where they acknowledge times when they've gone wrong, because that makes them more human. And we are, at the end of the day, human beings. Even doctors, and I think COVID sort of showed that very, very well, that, even doctors don't always have the answers, and that's just the nature of things. It doesn't mean they're bad doctors, or it doesn't mean that our public health, specialists don't know what they're doing. It's just in the nature of things. And I think the problem often is, and this is something you referred to, we're in this very paternalistic way of looking at patients and at people, right, where we know better, right? It's a colonial mindset that has been left with us. We are educated, we speak a particular way, and therefore we know better, right? Now, what I would like to submit to you is that every human being thinks like a scientist, right? They will take their decisions based on what their life experiences has shown them so far. So if your experience with public health has been good, you will trust it. If it has not been good, no matter how many pieces of communication you put out, you will not trust it. Because as a scientist, your life experience has told you not to trust it, right? So I feel like, we need to make health communication a little more bottoms up. There's too much of a top-down kind of an approach. We need to make it accessible. We need to respond to the kinds of questions and doubts that people already have in their minds. And we need to be honest. We need to be authentic. So I think without all of that, we can have many conferences, but we won't really be sort of tackling the problem where it exists.
Very interesting perspective. Dr. Dinesh, would you like to come in here? You wanted to speak about the solutions as well. And do you agree with her? Is this the gap? Can we focus more on storytelling, focus more on what went wrong in retrospective, look back at past mistakes, learn from it, maybe help popularize it, and then hope to chart a way for the future so that the same things are not repeated again?
Yeah, I do agree with Aparna. And in fact, ORS stories I've included in my book of the 100 innovations which changed India since 1947. So Dr. Mahalanobis figures in that. So yeah, we need to tell. In fact, what you're telling is part of the health literacy. I mean, these are the stories which we need to bring into our curriculum at the school level so that people grow with this kind of a thing. The children are told about how the health system works in India.
A lot of mainstream outlets actually ignored Dr. Dilip's death. He was the creator of ORS and passed away, I think, barely a few weeks ago. Some alternative news outlets may have picked it up, but largely ignored the story. So yeah, you were talking.
I don't think we teach our even children that how the health system in India works. I have not come across, I may be wrong, but that's why the health literacy should start at the school level, and I fully agree with what you said about the bottoms-up approach. Because, see, why are we talking of health communication? And why do we need to communicate about health? That is a basic question, So it is the it has something to do with the health-seeking behavior, which I don't want to get into the detail, but everybody has that, and it sort of differs from strata to strata, and everybody that they become aware and then they act on it. So that's the change. So health-seeking behavior, because in fact very, very little research has been done about health communication. Of course, there are studies which have been done, but in the landscape which we are discussing today, where does all this fit in the health-seeking behavior of Indians today? So that's one of the solutions which I want to propose is we need more research into health communication as such and the health-seeking behavior and the changing patterns of it. I mean, when we talk about smartphones, I think about 300 million people have out of the total 1 billion phones in India. So that number is growing. So what about the rest of them? Is everybody seeking health information or seeing a video on health only from I mean, even today, if you want to consult a doctor, you would ask somebody, have you been to that doctor? So that is part of our health-seeking behavior. So what? So it is to influence our, the way we approach health system and seek. So we need more research in that. Another is we need an observatory. India is a huge country. I mean, it's not one country. It's 33 countries. Every state has a different kind of health system. Every state has a different kind of health burden and health-seeking behavior. So we need to monitor, and there are videos being done in all kinds of languages. It's not just Hindi or English or Bengali or Telugu, but different kinds of. So we need to monitor that. So we need to have an observatory so that we look at the trends of what kind of information is being put out, how much of it is fake news, how much of it is misinformation, how much of it is real information. Then I think you mentioned about this point of some kind of engagement with the health creator. That's where institutional response or even civil society or these, where there should be a are, overcome whatever gaps we see in the health communication and information. And then we need a response at the institutional level. How do you, combat misinformation on health? The only way to do, I mean, no amount of policing will help. No platform can monitor whatever content is going on. It's impossible. There cannot be any regulation. So the only way to fight misinformation and fake news on health is to put out more authenticated news, and that's where the institutional response has to come. It should be the ministries, it should be the departments, it should be the civil society, it should be independent organizations. They should put out more professional scientific bodies, professional health associations. They need to come forth and put out authentic information so that, all the fake news is kind of overshadowed. So those are the 4 or 5 solutions I have. One example which NHS used to run in UK, but I think they have discontinued it, behind the headlines. They had the UK Health Department used to run a program where they would analyze, say, the headlines of health headlines, 5 news stories which are covered in media, and they had a panel of experts, and they would say whether it is correct or not. So we need more that kind of mechanisms of those kinds. And we need to empower the, agencies. We have the health.
That is a very good point. We need to empower. And the audience needs to feel empowered. Dr. Tanaya and Dr. Shreya, very quick tips before we move on to the audience questions. First, I'd like to, let us know in brief. So what are your top tips for the audience when they're engaging in health-related content on any social media platform? What are your top tricks so that they can glean through what is misinformation, who are the people they can actually trust, and what kind of information is actually eventually going to be useful to the end users?
I think a very, very simple trick that we somehow misusing is whatever you're looking for, type that onto Google and then write fact check after it. There are multiple fact checking agencies that run this by their, their rota of information that they have. So that's the first thing we can do. Anything, and the top tip for everything in life aside from content is be skeptical. Be skeptical of everything, whatever you're seeing on social media, whatever you're seeing in a book, always be skeptical. I think one thing that my book is coming out next month, and one thing that I've mentioned in there is the story of the clitoris. The clitoris, everybody has heard the human clitoris has 8,000 nerve endings, it's the most sensitive organ. What we always forget to realize is that this number of 8,000 nerve endings actually comes from a study on cows. It's not the human clitoris. So, if we just run the simple fact check thing, if we just were a little bit more skeptical about where this information is coming from, how authentic it is, and how much can we trust it, 2 tips, skepticity and, being skeptical and running fact checks. Aside from that, even the most verified, most highly educated people will make mistakes, and they will say things that are incorrect, and science changes like you mentioned. So whatever's correct at the moment seems to be the best policy to follow.
Dr. Shreya, any top tricks or tips from you? So 2 tips again. Say if you're looking for any health content online, always look at information which comes from the expert, who is the doctor. And yes, it is not always possible to check on, the background, the license. So go to trusted information portals. And then again, don't be carried away, and always remember that this is medical information. It cannot be taken up as a medical advice. You have to, there might be a dire need of going and meeting a medical, health provider. So don't try to always self-manage your condition. Reach out, do visit the healthcare provider. Yes, but, the content, whatever you're looking at, that should be from an authentic source. Yeah, that's how it is.
And one last point from you, Ms. Aparna. As a filmmaker, what Dr. Dinesh said about, institutionalizing and basically help from an institution, maybe such as the government, and backing of that, how would that help you as a filmmaker? Could it help you in combating misinformation, looking at story ideas, and maybe, popularizing things that need to be popularized?
I think we're all very starved for hope. And a lot of times what films can do, there's information, but what films can do is tell stories of hope. And I think if we can start with that as a beginning, perhaps then, some things can change, because then you're really looking at an entire trajectory, and you're actually backing it up with, people who've been through something, who've battled something, come out of it. And that, in a way, is the best testimony you could provide. Somebody's lived experience, so.
Thank you. Thank you so much for those wonderful last words. I'll now turn to the audience and see if anybody has any questions to ask today of our panelists.
Yeah, thank you so much. I have a question to the entire panel, actually. In the very beginning, we spoke about how scientific research is jargon.
Ma'am, could you introduce yourself, please?
Hi, I'm Pratibha. I'm a fact checker with First Check. So in the beginning, we had discussed during the sessions that scientific research tends to be very technical, and it's very difficult to get the message across without making it simplifying it and making it easier for the reader. So how, in your journalism experience and through your filmmaking and on social media, how has simplifying research been for you?
Yeah. Would you like?
No. I mean, there are no easy answers and there are no shortcuts to it. So first you have to look at from where the research is coming, and there are a few sets of questions which you have to ask. And if those are answered, and if you're satisfied, you go ahead and talk to the scientists and do the story. But this whole research ecosystem is also quite complex, and it has a lot of holes. For example, today, on Twitter, if you see one very a doctor with, I think, 100,000 followers tweeted saying that a mix of garlic and lemon juice can bring down your lipid profile can be controlled with these two. And he quoted a paper which was published in a research journal. He's a MD and DM. He gave a link to the paper, which is published in an Iranian journal, which said this, the conclusion of the study is that if you take some 5 ml of garlic juice mixed with lemon every day, your lipid profile can be fully perfect. But if you look at the paper which he quoted, there are a lot of holes. For example, there was not a control arm. They took only non-vegetarian people. The food habits could differ from country to country. So there are various points which another doctor pointed out. So even a research paper published in a, perhaps this journal, I don't know, it's an Iranian journal, how good or bad it is, I have not gone into that. But there can be problems with a paper published in a research journal also. But there are kind of checklists which if you carefully look at them, you can say whether the finding is applicable or not. So there are no easy ways to do that. It's a difficult path.
I think if I can add to that, I think one very helpful tip is simplifying using stories like you mentioned. If you tell somebody that period cramps happen because prostaglandins act on the uterus and cause uterine contractions, nobody's going to remember that. But if you go and tell them that there's something in your body that squeezes your uterus like a lemon, and like how you make shikanji to how you squeeze a lemon to make shikanji, your body is doing the same thing to squeeze out all the blood from your body. People will remember that, and instead of falling for misinformation about pills are bad for you, like painkillers are bad for you on your period, if somebody understands the logic behind why this is not true, these pills will act on these enzymes, so the squeezing will be less, and then you won't feel as much pain, and shikanji nahi banegi. So these kind of things stick with people, and the storytelling aspect of it is absolutely a game changer in it.
Also had a point to add on. So it is about rational, the rationale behind the information which you are consuming. So if you are able to justify that, okay, even for that matter, doctors, that, okay, if you're in stress, your level of cortisol is high. That's the reason why you get these symptoms, right? So there's a rationale behind you explaining it to the audiences. So if you are able to give the reason behind it, I think you will get an adoption of people consuming credible information, where people just are not bombarded by information from doctors that, no, I have to just follow him just for the sake that he or she is doctor. No, but then this is what makes sense to me. This is how I can relate to. I think that's an important thing.
And another thing is topicality. Whenever doctors have that sense, content creators have that sense, whatever, there's this sense of sometimes misinformation that creeps up in your subconscious, and you may not even be like talking about it or really thinking too much about it, but it does. For example, TV actors, a spate of them have collapsed in the gym, and a recent death just happened. And, people are suddenly, I get WhatsApp messages and saying, don't overdo it in the gym. Don't do this, and be very careful. And nobody's saying, go to a doctor and get tested if you have any concerns. Everyone is pointing out, relax at the gym, don't do too much. So, topicality and all the points that you added, yeah, that really ring a bell. If there's, I think, scope for one more question, if there's anyone. Please do introduce yourself. So if there are no questions, thank you so much. It was wonderful. Wonderful having you all here for the conversation, and have a nice weekend and evening ahead, everyone. Thank you.
Thank you, dear panelists. Thank you, Surbhi. To recognize trends, debunk misinformation, and to And to prepare response strategy for 2023, we have an exciting health misinformation workshop led by my colleague Varadarajan Ananthakrishnan, Director Training and Research at Data Leads. Also, audience, we are serving tea and coffee at the counter. You can grab a cup of tea while you attend the workshop.
Good evening. Good evening, everyone. I know it's been a long day. Okay. So if some of you at the back want to shift to the front because there are empty chairs here, so in case you want to. And I promise you this will be an interesting session. So I would, if you could shift to the front benches, that would be better. Okay, so my name is Varadarajan Ananthakrishnan, also aka Raj. So what we're going to look at today, it's been a very interesting day. So many people with lovely insights sharing their thoughts on many things around health misinformation. So you heard about the 5 W's, why, where, what, when, all of that. Now you'll see the how. You've seen what health misinformation does in, around different parameters. Now you'll learn what is the how. We know what is health misinformation. So what do you do about it is what this session is about. The how. When you're faced with misinformation, you might be a student, you might be a healthcare worker, you might be a doctor, you might be any healthcare professional working in the health sector. What can you do? What is it in your area that you can do to prevent misinformation, health misinformation from spreading? So that's what we're going to look at. It'll be a quick session. Unfortunately, it can't be hands-on because we don't have laptops and we're not equipped. So I'll take you through the paces on how to do it. And I'm available for any question offline in case you want to ask me any question later. So we'll cover these, the misinformation trends in this year, how to recognize trends, what is health misinformation, tools and techniques, and trends for 2023, and mounting a response strategy. This is important. Mounting a response strategy is important because when faced with misinformation and not wanting it to spread further, what do you do? So let's look at the year that was health misinformation trends in 2022. I kept the virus on top because it did trend for one more year. The virus did trend, and so the year was again about COVID. So apart from COVID, we had home remedies for treatment of serious ailments all over the social media. These two pictures are the defining pictures of a pandemic, according to me, because the coronavirus lodges in your throat before it travels to the lung, so you can have steam inhalation and kill it in the throat. It was one of the biggest falsehoods, biggest misinformation that went trending. And then you can have ginger, garlic, all of that, make a kadha out of it at home, have it, and you'll not have coronavirus, or you'll be cured of coronavirus. That's what you're told, which is false. We had some people committed to spreading misinformation about COVID vaccines, calling people dying out of COVID vaccine, and so you should not have it, and many other more narratives saying you'll have infertility, you'll have deformed babies, all of that. Of course, the most trending was the conspiracy theories about the pandemic, how it was produced in a China lab, and how certain people like Bill Gates were behind the pandemic and spreading the pandemic because they wanted to make quick buck out of it. Imagine Bill Gates wanting to make a quick buck. We also saw reproductive health misinformation. This is just a couple of things which we put as an example, but a whole lot of reproductive health misinformation, which includes how to test for pregnancy it ranges from how to test for pregnancy at home all the way to how to get a baby boy, how to make sure that you get a baby boy. So these were the reproductive health misinformation which was trending. And of course, cancer-related misinformation. I don't have that example here, but there was one video which went viral, which had more than 1 million views, which said the urine of a black virgin cow can cure cancer. It had 1 million views and some thousands of comments. People actually thanking the video uploader, saying, "You've given us a hope in life." That is the kind of danger of health misinformation I'm talking about. So how do we understand health misinformation? So it's false or misleading information about diseases, illnesses, potential treatments and cures, vaccines, diets, etc. What it can cause is people to make decisions that could have dangerous consequences towards health. Now, how many of us honestly have shared a WhatsApp, forwarded a WhatsApp with some health condition, easy quick fix for a health condition, and forwarded to people whom we think will benefit from that post? Honestly, how many of us at least once have done that? I have done that. So yeah, few people who owned up. We always think that it's going to benefit a few people, so let's do that. Why do we share it? Because we feel that this new information nobody knows about, so I will be the first one to share, so I'll share it. We also share because we think this information might benefit for the people whom we care about. We share it because we feel connected to others, we care for them. Most important thing, when you see an authoritative logo on the post, like a CDC, an ICMR or a WHO, you immediately taken in by that saying, oh, it's a WHO approved post. it's an approved announcement, so it must be true, without pausing to look at the fact that whether it's actually just all you have to do is Google it and go to the WHO website and see if such a post has been uploaded or not. That's all you need to do. So the mischief creators, the people who indulge in misinformation, usually use a authoritative logo on their post to sell their narrative. What constitutes health misinformation? It's unsubstantiated, unscientific cures and preventive measures for critical health issues. All these are health misinformation. Posts that are intended to create panic and chaos. In a health emergency like the pandemic, we've seen that people who post, pictures from some other part of the world, completely unconnected to the pandemic, they put that in and they say, look at what's happening. It kind of, in a situation like a public health emergency, like the pandemic, it creates a lot of doubt and panic among the people. Falsely attributed posts, like I said, picking up some post from somewhere and showing it as belonging to somewhere else. And of course, digitally manipulated content that looks believable, but it is not true. So how does a legitimate information ecosystem become a misinformation ecosystem? One is information overload, because there's so much information that you do not know how to sift from the right from the wrong. Human biases, because when you see an information, you put your own bias into that and then unknowingly or knowingly create that misinformation which travels further down and creates havoc. Emotive information, you are taken in by a post because of the pure emotion behind it, and then you share it because you thinking it's true. And of course, you have unverified information, which it's a legitimate information, but it becomes, when you add your own unverified information to it, it becomes misinformation. So how do you recognize trends? If you are a healthcare worker, if you are a medical student, if you're somebody, any professional at any level working in the health workspace, what do? How do you recognize trends? The first thing is to look at a post objectively. So if you see a post uploaded very recently and going viral, picked up millions of views or thousands of views and shares, and a lot of comments and traction among the people who saw the post, that is the first flag that you should know that this is something wrong. 9 times out of 10, it's a misinformation post, because we tend to consume misinformation faster than legitimate information. Stop. When you see a post like that, stop. And if you can verify the source and the content of the post. Text search is the easiest way, I would say, to look at any post in the most cryptic way possible. Describe what is there. We'll come to that in a bit. I'll show you an example. If we come to that in a bit, if you can verify the source and content of the post, half the job is done. So you can actually help stopping the post from going viral by at least commenting on it and calling it out. Please understand, you have to understand what is driving the post. What is it in the post that is driving the virality? Why is it going viral? We all know the blindfolded men and the elephant. They all interpret it differently. That's what exactly misinformation does to you. Everyone interprets it the way they want to, and therein lies the danger of health misinformation. So how do you build a response strategy? First, call it out. When I say call it out, you can do, you can report it, you can put it in the comments and say, please don't believe this. You have to call it out. It helps alert. When you see a post, and if you scroll down the comments, the best thing to do is go through the comments in the post. One person or the other would have called it out, and that is your first red flag that this post is misinformation. So you could be the person as well. You could help alert against this misinformation by putting in the comment, this is a fake post, and probably give evidence. here's the next point. So you do your own research, provide evidence to disprove. In your comment, if you say, this is the link which is the actual original post, and this is a manipulated post, half your job is done. You provide research and you provide evidence to disprove what you're saying. So that is that will help you give a legitimate response to the misinformation, and people will tend to believe you, your post, because you've given all the evidences to say what you're saying. Always advocate critical thinking. Much beyond tools and techniques, what you need to do is observe and analyze. Observe at a post, look at the content, look at the text, look at the image or the video, and think for yourself, pause for a bit and say, is this right or not? Could this have happened? Does it even look true? Does it look credible? Does it look real or legitimate? So now these were the things you could do without tools and techniques. I'll tell you now tools and techniques that that can aid debunking health misinformation. These are simple tools. I would request you to pay attention. This is on your phone. This is on your laptop. It's the easiest thing for you to do. You should do it. Okay? The first is a simple text search. Like I said a while ago, all you need to do is look at the post, describe the content in as cryptic as possible, Google it. Okay? Some person or the other would have fact-checked it, or if not, a WHO, an ICMR or a CDC would have flagged it and have found it to be fake. Most times, you can reach the original article and there is your evidence that this is a misinformation post. Do you know St. Luke's Hospital in Kansas City said after extensive research, our findings show that consuming alcoholic beverages may help reduce the risk of infection by the novel coronavirus, COVID-19. Vodka is the most important, is recommended for drinking, cleaning, and sanitizing. Now, this post went, this thing, St. Luke's Hospital thing, went viral all over the net in US, and people started consuming alcohol, assuming that this was true. Okay? So, how many of us think this is a legitimate post? This could have actually happened. Can you imagine? Okay, I have to give you a context here. This happened at the peak of the pandemic when people were scrambling for answers to fight the pandemic and fight the virus. So we're sitting in 2020, at the end of 2022, and the pandemic is hopefully on the wane. You will not consider this. You will probably laugh at this post. But at the time I'm talking about, this happened in 2020 March, where the pandemic was just, had the entire world in its grasp, and everybody was suffering through it. We had no answers. At the beginning of the pandemic, we did not have answers. We had only misinformation, and this was one such misinformation. I'll talk to you about a corollary or to this, not this post maybe. When somebody in Iran heard that alcohol cures coronavirus and prevents it, Iran, which is a dry country where alcohol is not allowed, people consumed methanol in the cleaning liquid in the hope that it will cure and prevent coronavirus in them. 700 people died in Iran. At the peak of pandemic, 700 people died of consuming methanol because they hoped it was panic that made them have that drink. So this is what can do. This is only advocating vodka, which is not half as dangerous. But then I'm talking about misinformation, what it can lead to. What is the real world harm for misinformation? So for this, we did a simple text search briefly describing the post. I said St. Luke Hospital, alcohol for coronavirus. Believe me, when you have the shortest description on Google and not a very lengthy statement, you usually get the right results you want. So this is what I got. You saw all the articles which have debunked it. You got a list of articles which have debunked it, saying it did not happen. Now let's do a small exercise. Pull out your phones, all of you. And this went viral in US. They said there was a face mask exempt card issued in the US for people, people with, it was under the ADA, American with Disabilities Act, and they are not supposed to disclose the condition in whatever condition they had, and they were exempt from using the face mask. Can you find out using just a simple text search on Google? Can you find out what the truth was? Is it true or not? Let's do the simple, quick exercise. Tell me if you got a result, any one of you. Got it, anyone? What is it? Somebody give the mic to him, please. Mic they don't go. I said a while before to look at a post carefully and observe it. My first alert comes that this is a misinformation post comes from the fact, look at the last few lines and the spellings. Look at the last few lines and the spellings.
It's right.
Civil rights, untrue. So it is a hastily created post. The first thing is to look at the spellings, the English, and the video itself. Yeah, somebody had the answer. Yeah.
No, I think there is an NY Time article also about this, and also what you said towards the end of it.
So it is a false or a true post?
It's a fake news.
Okay. So if I were you, what would I do is face mask exempt card and put the word ADA because that's the most relevant part of this post, because ADA is supposed to have it quotes ADA for not using a face mask. I will put that. So you say face mask exempt card ADA, you'll get to the post. So always the simplest thing for you, don't go for tools and techniques. That's all maybe too technical for you. But text search, you do it all the time in your working day. So all you do is write the text describe the post in as simple as possible and as short as possible, and you'll get to the post. Get to the reality of the post. The Department of Justice warned of this fake mask exemption cards. It had to put out a post saying this is wrong. Yeah.
Many of these responses are from 26 June and 26 July, around that timeline. So it means that this has become viral and then people are responding to that. So when it is occurring at that point, the mere text search would not be helpful. So if this is something very new, so we are able to do this analysis because it's already late and some response already has come up on the net in the form of several articles. But if something has come up right now, text search on the Google may not help because it will take some time to get to some results, right? So in that case,
very correct. So I'm happy this question has come because right now what we do when we do a COVID pandemic related health misinformation search, you will see more often than not debunked articles already available. Now, very good question. If I'm looking at a post which is a day old, what do I do? Let's say it's whatever content it is, it must have some source or authority. It's quoting. It can be a random post. If it's quoting something, you have to go to the website. See, for example, if it's saying ki today, if there is a post says that the Indian government has mandated masks for everybody, even in public places, even moving vehicles, all of that, would you believe it? You won't, because we are not in the state of pandemic when it requires masks. So what will be your response to it? You won't believe it, but you still want to understand whether it is right or not. What will you do? What is the first thing, where is the place on the internet we will go to? you'll go to the authoritative sites like the government website, MOHFW, or even ICMR. You'll see if there's any. And another thing, if there's a very important occurrence which has happened, which needs your attention, the newspapers of that day will be carrying it. Surely, if it's a very important occurrence, that newspaper will be carrying it, so you'll get your newspaper articles. Failing which, you can actually, the government websites are the most authoritative for these kind of information. You will have to always, whether it's an old post or a new post, you will have to check with the authoritative websites or the Twitter handle or their, whatever social media handles, to figure out if that is the right way to, whether that information has come from them or not. That's the only way. As fact checkers, as health misinformation debunkers, it's your duty to understand what is the truth behind the post. Because people do create panic. I'm telling you, even newspapers. For example, there was a news article in one of the newspapers yesterday, which says China is seeing a massive jump in positive cases. How many cases? The screaming headline was, China sees massive jump in COVID cases, new COVID cases. Okay, I went to the article to see how many cases? 124 cases. Okay, that's a very low number, of which 77 are asymptomatic. 77 so only 50 odd are symptomatic, and they have mild symptoms. So the headline versus the content, okay, somebody can be taken by the headline itself and not look at the content. You can look at the headline and say, oh my God, it's happening all over again. It creates panic. To me, that's also that's misattribution. If you're giving a wrong headline, screaming headline, and the content is something else. There was another major newspaper, I'll not take the name, a major newspaper a few months ago. It said, we are seeing a 80% jump in hospitalization. From 10, it went to 18. That's an 80% jump. But what would you make of the headline? What would you make of the headline when you say 80% jump in hospitalization? You will panic. You will get worried. It's clickbaity. One of the things which makes posts go viral is clickbaity. They want you to read the article. Whatever the content might be, they want to read the article. So that's what they do. Okay. So Google Lens. How many of us have Android phones and Google Lens on it? Google Lens is the best app you can have to debunk any misinformation. Luckily, it's also available on the laptop. You go to images.google.com. I'll just show you that. So when you see images.google.com, at the end you have this, search by image. This is actually Google Lens. So when you click on it, you can search any image with Google Lens. Even if you don't, what you do is, when you see a search for images and you do a right click on it, you have an option called search with Google Lens. What Google Lens gives you is just a reverse image search. What is a reverse image search? When you do a text search, you get to the text content. When you search with an image, it will give you same images used in various contexts since times immemorial. It will give you all the instances of that same image which is being used at different places. So that is your flag to understand whether you are in the right image or not, whether you got the right image or not, whether the context of the post you're looking at is the right image or not. I'll demonstrate one for you, but I'll tell you what Google Lens does. How does it help? It's an app on a phone. It can also be used on desktop, like I just showed. It helps you do reverse image search, which means you search for an image. It helps you verify if an image has been repurposed, picked up some other context, some other country, some other era, some other year, and presented as a present, with the present crisis, and is the image genuinely from the source which it claims to be. So Google Lens can help you. It's a very simple app, very easy to use, and you can do many things. one of the things which you can use if you want to, let's say there's a board you're looking at in an image, there's a billboard you're looking at an image, or there is a text printed on a cardboard you're seeing as a part of an image. You're not able to understand, or in a foreign language, in a language you don't understand. You just point your Google Lens to it, click the image, and then text search on that text and say translate. You will get to translate the image, the text on the image. On the image. It's on a billboard, it's on a cardboard, in anything, on a taxi. You can use that, you can use Google Lens to translate what is written. So fact checking, any fact checking becomes very, very easy when you can actually, abhi tak kya hota tha, we saw a thing on the billboard and said, oh, I wish I could read what is there, what is written. Now you can actually translate anything on any surface, in any language with using Google Lens, translate it and get a sense of where it is from. So I would recommend all of you to use Google Lens as much as possible in your daily life, because it does help a lot. It's a very, very versatile tool. So I'll show you one example. At the height of pandemic, this was shared as an Indian patient on a bike with oxygen cylinder. This post is from 2021 at the peak of the second wave. It said, look at it, look at what's happening to India, all of that. This is what's happening to India. People have no oxygen. People are taking oxygen cylinders on the bike, and this is what is happening to people. Now, this picture is aimed at creating panic. This is aimed at creating panic. But when I use a simple Google Lens, I'll use it on my system. I go to images.google.com, I select Google Lens, I say upload a file. I upload the file of the image which I have. So the things on the right is what I get. Using Google Lens on my desktop, this is what I get. You can do it on your phone as well. This way. So these are things I'm getting. While I'm looking at the results, I can see that altnews.in, boomlive.in, these are fact-checking websites. I'm looking at the third column, the first result, I'm looking at the Daily Star. If you know what it is, the Daily Star is one of the big newspapers in Bangladesh. So I click on that link, okay, and it doesn't say fact check. It doesn't say a fact check article. So let's go to that and see what it is. COVID-19, son ties oxygen cylinder to his back and takes mother to the hospital on a motorcycle. The first line, a man in Barishal. Barishal is in Bangladesh. Okay. This is a scene from Bangladesh, and it was repurposed in India as something is happening in India. So you see how simple search with an image gets you to the right result for you to say that this is a false information. Any doubts on this? We did this, we got to this, and we got to this. Anyone, any thoughts, anything you want to ask?
Excuse me. Yeah. Can you hear me?
Yes.
Yeah. So my primary addition to what you have said is that primarily whenever the fake news thing come in particularly of WhatsApp groups, it is in video format. How do you debunk those videos? Because videos are sometimes...
Coming to that next.
Sure.
Coming to the next. Okay. So this is from Barishal, India, Bangladesh. Now, there is this is only on the laptop or a desktop. There is a Google Chrome extension called Envid. Okay, you can search for Envid Google Chrome extension. You can do the search for Envid Google Chrome extension, and the first result you get is fake news debunker by Envid and V-Verify. You just click on it and say add to Chrome. All you need to do is click on the link and say add to Chrome. It will ask you add to Chrome. You can add to Chrome. Once you add it to the Chrome browser, it is available. What does Invid do? It's a web-based application. It gives you the biggest thing for us, for a fact checker, what it gives you, it breaks down the entire video into keyframes. It breaks down the video into keyframes. So what you have is a series of images which you can use to reverse image search and get to the truth. So any image, you will get the right context of the image because you're breaking down the video into keyframes and you'll get to what you want to. Okay? It's a very, very versatile tool. Anybody in the fact-checking space, or even you, if you want to, randomly understand what a video is from, it's a very important tool, very versatile extension. I would recommend all of you to put it on your browser. It stays there, it doesn't take up space, it stays there forever, and it's a very versatile tool. I would very, very highly recommend this Chrome extension to everybody. This video was wide. Okay, I would now like to request all of you to look at this video carefully and tell me if you agree, if you notice anything which is amiss. And this was shared as a video, vaccine scam in India, where the vaccine is not being injected and it is later sold into black market. Please look at the video. Please observe. What did you see in the video? The vaccine was not injected. She took it there and pulled it out. Now, this is a video from India. How many of you agree? How many of you don't agree? How many of you agree it's from India? It could be from India. Anybody give me an answer, yes or no is fine. And you don't have to be right. This is not a class test. Huh? You can't say. Okay, anybody who thinks absolutely it's from India. Okay, if you don't think it's India, what are your reasons? Anybody? Okay, it's an interactive session. It's not a teacher training your students, so you can say what you want. Sorry, I'm not getting.
Looks like Indonesia or some other, Malaysia or something like that.
Why do you say that?
Just features and what I see in the video.
Okay, does anybody agree that it's not from India because of the features, Indonesia maybe?
Yeah, looks like facial features are not from India.
Okay, I'll take you through how to use Invid here. When you add Invid to your Chrome browser, you can see it at the end of the address bar, right on top. You can see that pinned there, Invid. So I open Invid. Okay, now one disclaimer, Invid has a very bad habit of failing when you want it the most. So it actually failed now, so bear with me. So what I want is, see what all you can do with it. You can get thumbnails, you can understand the metadata, where it was uploaded, when it was uploaded, the comments, all of that. You can do video analysis. You can even do forensic, but that's very advanced. We'll not go there. So what we want is keyframes. I'm clicking on keyframe. And I can either put a link there or I can upload a file. So I'm saying file. Okay. I can say I upload a file. I say submit. Once I submit, What it will do, it will break the video into keyframes. Now these are the keyframes, I'll show it to you. These are the keyframes I've got. To me, all of this described easily, so I'll go with this, let's say with this. I do a right click on the image. I can either search with Google Lens or do a reverse image search. Let's do with Google Lens, let's see if we get results. So here are the images list we got. Look at the first result I have. It's in a foreign language, okay? My first alert that this is probably not belonging to India is this. So I click on this to investigate what it is. I don't want this in Spanish, I want it in English. You can see the video. This is actually which has happened in Mexico. It's Spanish, and the government has apologized for this, what has happened. It happened in Mexico City. The government of Mexico City and the Mexican Institute of IMSS confirmed that the volunteer vaccinator made a mistake while injecting an older adult in the National School of Biological Sciences of the National Polytechnic Institute, and indicated that the woman was removed from the premises. So you see, when you get a WhatsApp video, what you do, you first download it on your desktop. InVid works on desktop only, unfortunately not on the phone yet. So download it on your desktop, okay, and download the video, use InVid to break it down, and then be very choosy about the thumbnail you're choosing to verify with, because that thumbnail should have all the elements of, it should be fairly detailed as well as that the algorithm uses it to get you to the right result. Don't choose any random thumbnail. Please go with the thumbnail which has enough descriptive things on that. So we choose that. So any questions on this?
Excuse me?
This was not from India, this was from Mexico.
Hello.
Yeah.
Will it be able to distinguish between the deep fakes?
No.
Not yet?
Not yet. Deepfakes is something new, developing, evolving. We do not have answers yet. What do we have to understand deepfakes is to understand context, whether a person would have spoken the lines he or she has, supposed to have mouthed. So we need to do that. And right now, at the moment, as far as I know, deepfakes are still a challenge, but it can be all understood in context.
Okay, thank you.
Yes, there is a website called watchframebyframe.com. You can watch it frame by frame to see if it's been manipulated anywhere at any point. So that's one more tool you could use. So we did this, and yes.
I have one question, sir. Like, can we also, do the screenshot and then try to search? Can we?
Absolutely.
Wow, that will be time saving.
No, but why don't you use the InVid tool? It's very, very easy.
No, in case if we are stuck, like you have mentioned earlier.
So yeah, in case you want to just stop the screen, the problem with screenshot is you will not know exactly where to stop, and it can be blurry and all of that. It's a challenge. But yes, as a concept, screenshots can be used as images to do reverse image search or a Google Lens search. You can do that.
Thank you, sir.
So we sum up, health misinformation can be contained. Critical thinking is the way forward. Tools and techniques, ek jagah. Your thought, your analysis is one place. You have to sensitize your patients and the caregiver community against misinformation. People will run to you with misinformation saying, my kin has cancer, but this is what I read, this can be cured. If you search on YouTube, cow urine for cancer, you'll get about 20,000 results, all of them talking about how cow urine can cure cancer. So you can't blame the patient or the caregiver for getting taken in by the narrative that cow urine can actually cure cancer. So you have to combat this with information. Misinformation can be fought only with information, legitimate, evidence-based information. That's the only thing you have, that's the only armory you have to tell them that this is false. And they will buy it. When they see the evidence, they'll buy it. Because they do not have the evidence for the other misinformation. It's just a post, it's just a narrative. They do not, they want to believe because they want to be, they're in a state of mind to believe that. They're wanting to believe that. But if you show them evidence-based information that this is wrong, they'll probably buy you. Please advocate the line, not everything you read online is true. And recognize self-biases and learn to evaluate information on merit. Like I said, use simple tools like text search or Google Lens to verify information. And remember, health misinformation can be beaten back only by legitimate information. That was the session and the day. So any questions, I'm happy to take it. Any questions? Okay, thank you. Thank you so much.
Thank you so much, Mr. Raj. I now invite Surbhi Pandit Nangya, Vice President Data Leads, to deliver the concluding remarks.
Thank you so much, Shruti, and thank you, Raj. Before I do the concluding remarks and, I read out my notes from the entire day, just to let you know as to what my concluding remarks are going to be, I've been jotting down points since morning as to which panel discussion, what to say, so please bear with me another 45 minutes of concluding remarks. No, I'm sorry, but I'm not going to take that long. Raj, very good teacher to begin with. We have our Google News initiative and Fakshala team members in this room. So if you've heard some very good answers, so we have the GNI team and the Fakshala team. And of course, you guys are very good students too. Thank you so much, Raj, and thank you, Shruti. And a big thank you to all of you for being present here today. I wanted to beautifully sum up Health of India. And I thought, I'll go session, and seriously, I thought I'll go session by session and speaker by speaker and see, what were the best takeaways from the sessions today, who said what, and what is that we should take away from today's session, from the Health of India. We started with the public health session, we moved on to health misinformation session. So then I kept jotting down points and I realized that each and every word that was said, that was discussed during each and every session was so important. Starting from our keynote in the morning till Raj's session in here, every session has something or the other. They have one after the other important points that needs further deliberation, that needs to be discussed, and of course discussed again and again and again. I just want to sum it up with what the man himself in the morning said. And that man himself is Dr. Reddy. He had to leave early because of a commitment. But I think I want to sum up with what he said in the morning. And he said that better is not permanent. Better every day is something that we should aim at. So I think we want to conclude today and say that through Health of India Summit and through these initiative of ours, we want to better the healthcare system in India. We want to better the information ecosystem in India, and that's what our aim is. And I think with that also, I would want to reiterate the fact that Dr. Garth Graham said that it's very important to empower the communities with reliable information. And I think this is what the mission and the vision is, that very important is to empower people with the correct information, reliable information, and information which is reliable as well as given out on time, timely information. So with that, I wouldn't take a lot of time. I know that you've been here since morning and attentively listening to each and every session. Thank you so much for being engaging so much, asking those questions, making us think as to what is that, we actually want to understand what is that we missed. So if there is anything that you feel that we've missed in the entire day that needs to be covered maybe next time, or some session that can be covered maybe next time, you have our email IDs. Our team has been reaching out to you. You've read all the emails. Please reach back to us and be happy to have them in our next sessions. If there is any field that you want us to collaborate on, we'll be happy. Anything to do with health information ecosystem and to better our public health in India. We know that's been a challenge in the past. So thank you so much on behalf of our partners, YouTube, Health Here, Team Data Leads, and Team Health Leads. A big, big thank you, everyone. Please take care of yourself and stay safe.